morning and happy Valentine's Day. I would request, of course I did ask the hotel here to put some red ribbons on the chair, but I don't think we're going to make it just now. So, the hostess, we're going to start the session because we have a long day and we had a wonderful day yesterday going through different sessions, starting from the work that we had on the medtech to some of the AI solutions that were up there on display. And today we're going to focus again on, first of all, with the Chime session, and then follow it up with some of the other AI solutions, confidential computing, the work that we are doing on clinical AI, and then there are a few demonstrations that we'll be doing post-lunch. So we have a long day. I now request my hostess to start the proceedings. Many of you who are sitting at the back, you can actually come in the front and make yourself comfortable. That would actually look at, oh yes, and we do have a quiz during the lunch at around 1 p.m. There were lots of prizes that were won yesterday. And Ganpati sir says that there are many more which is left, and he doesn't want to add an extra baggage going back to Chennai. So he wants to give it to people, so please join him for the quiz. All yours. Thank you.
Hello, hi, good morning, ladies and gentlemen. Feeling energetic? How was your last day? Did you have a good time? So are you ready for today's day? Yes. With your full packed energy? Okay, so once again, I would like to welcome each and every one of you. Thank you so much all for being here. I would like to express my heartfelt gratitude for your special presence. Thank you all for being here. Thank you for your precious time. So we are all set to take this day further. Well, as we all are here, today we're going to have a lot of sessions. Today you will feel more knowledgeable. Today you will feel more knowledgeable, beneficial, because we're going to have some efficient sessions. One by one we're going to conduct that. And beside our session, today we're going to conduct one quiz session that's going to take place at sharp 1:30. Even yesterday also we conducted quiz session at the lunch area. So all the very best. Even yesterday we have given 10 prizes. And whosoever will answer right, of course, you will get some exciting prizes also. And beside that, please let's get clicked. We have a very exciting photo booth that we have placed outside. So let's get clicked. Let's make these memories more remarkable. And don't forget to mention our hashtag, that is hashtag THIT2023 on your social media. So without taking your much time, now we are all set to start this day with our first session. So to conduct our first session, I would like to call upon a person who doesn't need any introduction. He is very important to us. So allow me to welcome Mr. Ajit Veerappan on stage, who is founder and CEO, ABI Health Technologies, Foundation Partner, Chime India. So let's welcome him with your huge round of applause. A cheerful welcome to you, sir.
Hi, good morning everyone, and welcome to the second day of THIT. We've got a super exciting session to look forward to. I'm Ajit Veerappan, founder and CEO of ABI Health. So ABI Health is a health tech SaaS platform. We work with more than 1,000 providers in the country. We provide RCM and lab information management solutions. So the format's pretty simple. The topic's going to be about building better healthcare. We've got an esteemed set of speakers with us, 15 minutes for each of them, and followed by a Q&A. So I'd request everyone to come into the hall. I know it's February 14th, but yeah, it'd be great if you can quiet your cell phones and we can get started. Again, very proud to be associated with Chime. I'm seeing a lot of friends, old friends of Chime here, so looking forward to the next few years. We've been associated with Chime for the last 3 years. The impact has been spectacular, and I'm sure that, maybe I would like to contribute in whatever way it is to make the impact even more stronger in the years to come. So without taking too much time, I'll maybe start with a quote, because today's topic is more about digital transformation. It's not the strongest of the species that survives, nor the most intelligent that survives. It's the one that is most adaptable to change. Charles Darwin, the great man, mentioned this, and I think post-COVID, the adoption to health tech is becoming more. And I did speak with Andy this morning, and he mentioned that the technology is always there, but the adoption is just kept increasing, and we've got a great next 5 to 10 years to go in terms of what digital health is going to see. So we'll like to welcome Andy Kinnear on the stage. He's the Executive Program Advisor of Chime International, based out of England. So Andy, if you could come, his topics around digital transformation in the UK post-COVID scenario. Thanks.
Thank you, and good morning, everybody. And can I just say I've attended a lot of digital conferences over my career, and I've worked out that there's a way of working out who the most elite delegates attending a conference are. It's the people that make it to the early morning session on day 2. So congratulations, you have self-selected yourself as the most elite attendees at this conference today. Well done. So I'm going to talk a little bit about the National Health Service in England, and then talk a little bit about the impact COVID has had on us, and then specifically focusing on leadership, because it's the leadership story I think that's the most interesting. So just a little bit about me. I spent 30 years working full-time for the National Health Service in England. I was a CIO for about 22, 23 of those years, and then a couple of years ago I stepped off that seat and now do a range of roles, including working with Chime International and trying to develop the next generation of leaders in the digital space. So I'm sort of really pleased to be part of that family doing that work. And just a bit about the NHS, if you don't know its history, it was formed on the 5th of July 1948, a year after India gained its independence. It's a £130 billion a year publicly funded health service. It means that people in the UK get their health care free at the point of care. They can attend a hospital, see a doctor, see a nurse and so on, and that all of that service is free because it's taxpayer funded behind the scenes. Employs 1.3 million people, the biggest employer in Western Europe, huge organisation. And the digital agenda really, the health service, like health service in India, is always about people. That's really what our main objective is. You can see from that slide that I prepared a few years ago for one of the NHS birthdays. I think digital transformation is really just about serving our people, our care professionals, our patients and our public in the best way we can. So just a little bit of background about pre-pandemic, because we had an interesting decade leading up to the pandemic. Firstly, in 2011 we had a national programme for information technology that largely failed. It was the biggest investment in technology the NHS had ever seen, around about £12 billion. And it didn't really deliver on many of the major objectives. It was quite a depressing period as that programme failed. In 2012, our government passed a Health Act that created a very complicated version of the NHS. Lots of organisations competing for space and working together. And then through this decade, we've had reduced funding, really. So an austerity programme that has, that has squeezed public services quite hard. Alongside that, our country took a decision to remove itself from the biggest labour market available to us in 2016 when we voted for Brexit. And if that wasn't bad enough, we end the decade with a global pandemic that I know you guys suffered from as well. And I think that now, as we start to sort of reflect on the pandemic, there's a couple of themes I think that are interesting to sort of reflect on and sort of think back to. One of those really has been the way in which COVID has been a trigger for driving lots of existing technologies, I would say. So I can remember being interviewed at about the beginning of 2021, and people were saying, have you seen COVID driving lots of innovation? And I said, well, to be honest, not really. I think it wasn't so much innovation, it was more adoption. What we were seeing was technologies that had existed were being picked up and used in earnest by large numbers of people. Most of the NHS had things like Microsoft Teams on its desktops for 2 or 3 years before the pandemic happened, but it was the pandemic that drove adoption. Everybody was working from home, and all of a sudden this stuff was happening. Similarly, I know Harpreet will talk a little bit more about the NHS app. He and I were involved in its development. It launched in the UK around about 2015, 2016, but it's been COVID that has been the driver that has really pushed that agenda forward and seen that sort of adoption across the United Kingdom. So I think one of the legacies of COVID really has been to push the digital solutions to the forefront and to give people a chance to adopt them. Alongside that, we've seen massive rise in people seeking health advice. So again, the channel of folks landing on the NHS website, seeking advice and guidance on how to deal with their COVID symptoms, things like that. You can see there the #1 visited website last year was people seeking advice on COVID from the NHS. So there's been a massive drive in the interest around public information as a result of this, and I think that has then extended way beyond just the COVID agenda into all kinds of health and wellness programs and things like that. So that's the sort of second thing. And then the third thing for me, and probably the most important, through my 30 years in the NHS, I think the single biggest change I've witnessed, the single biggest positive change I've witnessed, has been the rise of the clinical voice in the digital space. When I came in, we didn't really have doctors and nurses working as part of technology teams. In fact, most of the tech teams were down in the basement, disconnected from frontline healthcare, somewhere removed from care. And what we've actually seen is a rise in the clinical voice over that 30-year period. And I think COVID has really just put that on steroids, frankly. It's driven it even harder, faster, stronger. And probably most impressively from my perspective has been the way it's given the rise of the voice to digital nurses and digital midwives. We've seen a massive rise in the profile of nurses in the digital space, largely driven by those two characters at the top there, Natasha and Fran. They are the Chief Nurse Information Officers for England and Wales, respectively, and have been sort of actively involved and very, very sort of passionate about driving that vision from there. And you can see from that campaign at the bottom, surveying the nurses across the system to try and gather information about what they feel about their digital experience and how that's been going. And I think this is, it's a source of great pride, actually, because for Jane and I and for the team in Chime UK, we've been working quite hard with our nurse colleagues to improve their digital leadership skills and help them with this space. So to actually see this now really taking hold at the frontline level has been extremely rewarding. And I think the real sort of game changer and the point I really want to sort of wrap up with, I guess, is that when I came in, the CIO was the digital leader. It essentially, the one person that led the digital agenda in organisations was the CIO. I just simply don't think that's possible anymore. I think if you're going to drive through digital transformation effectively, then the digital leadership team needs to be much bigger. It needs to spread across the organisation, and critically, it needs to involve your clinical leaders, very visible and active, and sort of part of that space. And this is a picture I use a lot to sort of describe that essentially you need your digital leaders there on the bottom left of that screen, and the clinical digital leaders working in harmony. And if you can get a board in your organisation, a chief exec and a finance director and so on board, then you will be successful. And I can take you to NHS organisations that have got all of those three factors in play, and you will find digital success. I can take you to organisations that have got one or two or none of those factors, and you will find the exact opposite. It really is that simple. If you get those three people working in harmony, then you can sort of drive through that transformation. And I think COVID has really demonstrated that quite effectively and given us a digital leadership legacy that we can build on, because ultimately what we're doing here is digital transformation, and digital transformation leadership, just like winning cricket matches against Australia, is a team sport, and it needs to be seen and celebrated in that fashion. Thank you very much.
Thanks, Andy. There have been a lot of negative effects due to COVID, but I think one takeaway is the adoption of digital tech, which I think is a positive. The next speaker is very enterprising Dr. Harpreet Sood. He is the VP at Huma and a primary care physician. He's going to give us a clinical perspective of digital transformation in the UK. It's been a while since I've been in the UK. I'd love to hear more from you, Dr. Harpreet.
Thank you, Abhi, and good morning, everyone. Like Andy said this morning, it's great to be amongst the elite who've turned up this morning, so thank you for the invitation. So what I'm going to do over the next kind of 10 to 15 minutes is just give a very high-level overview of some of the key initiatives that are being driven in the NHS in terms of the digital transformation. But I think it's important to highlight that what's really accelerated this, as has for many health systems, has been COVID, which COVID has really accelerated the adoption of technologies that we've seen across the NHS. And I think there's two things that played out in particular. One was that for a lot of clinicians in particular, especially more senior clinicians, there's been a greater acceptance of the use of technology, and behaviors have changed, and I think that's hugely important because more often than not, it's the clinical behaviors and the engagement that we have with clinicians that often acts as a barrier to the adoption of technology. So that's kind of the first thing. And the second thing is that we've seen a perceived usefulness of what technology can actually do. Because of the necessity that we had to have with COVID, it made many clinical colleagues in particular realize that actually remote consultations or consulting with your patient through a video or consulting patients through telephone and doing things in a very different way actually wasn't as bad as it was perceived to be. And that acceptance has really then shifted as well as some of the task shifting that we see. So those are, I think, two really important things that have come through which are worth spending a bit of time on. So the way I'm going to structure it is threefold. Firstly, if I look at the patient-facing initiatives that the NHS has focused on, there's been a number of initiatives that we've been working on. Firstly, the NHS app, and I think it's really important to just spend a few minutes on this. So the NHS app is now acting as the front door, as we call it, the digital front door into accessing NHS services for many patients. So we've had about 32 million downloads of the NHS app across England, and the ambition is by March 24, we want 75% of the adult population to have downloaded and registered with the NHS app. And the NHS app is very much focused on online appointment bookings. It allows you to do repeat prescriptions. It allows you to access your records. It allows you to then also book appointment in secondary care and the referrals that we make, you're able to track those. And additionally, we have two other additional features on there. One is around organ donation, so those patients that are willing to donate organs, so it's a good way to us engage patients and develop that registry. And then secondly, also for research purposes. Only recently, the NHS app added another functionality, which was to help identify and recruit patients onto clinical trials. And I think that for the NHS in particular is a huge moment because life sciences and pharma and innovation, we want to recruit and identify as many patients that are from diverse backgrounds onto clinical trials. And there will be other functionalities that come through, but these are some of the core ones today. And another point to raise here is that often people say, well, the app will lead to a lot of inequalities and we'll think about digital exclusion. The important thing about the app in particular is that it's built on a very low bandwidth. And the reason for that is that we can then access it with limited data or those that don't have Wi-Fi to make sure that patients are able to access it. I remember a story back in March 2020, when one of my patients came and saw me just as the pandemic was kicking off. And he was a gentleman from South Asian descent, from Bangladesh. And I said to him, isn't it great that you could now use your smartphone to do a video consultation with me? And he said to me, you know what, Doc, not really, because I've got limited access to data, and I'd rather use that data to speak to my family in Bangladesh. And I think it made us realize there and then that actually, even though there are technologies present, not everyone has access to unlimited data, not everyone has access to Wi-Fi, and we want to make sure that the services that we offer from the NHS's perspective is as accessible and as inclusive as possible. Linked to that, we've seen a rise in 111. So we have the NHS app, but then we also have a service called 111. So 111 is a telephone service at the moment, but also online, where if there were any things that you wanted to query with the clinician, you can call up 111 or submit it online. And we see about 50,000 usage of that on a daily basis, where patients are accessing services through online places. And then finally, appointment booking, again, is a very common thing that is being done virtually now through some of the patient-facing. And the final one I wanted to just put on the patient-facing one was the patient access to records. And then again, this is often usually a sticky point for many health systems where, in particular, clinicians feel like patients shouldn't have access to their records because, then there'll be lots of other issues that come up. But actually, the NHS has now given access to their records, and so patients have full access to their records as of a few months ago now. And I think that's a big step change as well, because it gives patients the autonomy and empowers them to make sure that they are able to see their clinical diagnosis, etc., medications, and also have a more active role in terms of how care is provided. So those are some of the patient-facing initiatives that we have, where we've seen the change over the last few years in particular, and the acceleration of the adoption of that. If I then move on to some of the clinical and system initiatives, and there's a few things here that I think are worth talking about. Firstly, e-prescriptions. Again, now 95% of all prescriptions are done virtually, which again is a huge step change. Previously you'd write on a script, you'll take the script to your pharmacy, whereas now a patient will come and see you. We can send that prescription electronically to any pharmacy across the country that the patient wants us to, which I think, again, is not only sustainable, but it's more effective, and it's a good way for us to interact with the pharmacies in terms of how we do e-prescriptions, but also to make sure that it's the right drug at the right time, and if there were any challenges, we can pick those up. So e-prescriptions are now a very common feature. A second big initiative that we have been pushing a lot on now in the NHS as part of what we're doing is an initiative called the Virtual Wards and Hospital at Home program. Over the course of the last day or two, a lot of the big conversations that many have been having has been, how the paradigm of health and care is changing, which is moving outside of the hospital into the community, into primary care, but also into people's homes. And that's where the virtual ward program and the hospital at home program in the NHS is going to be a big part of that. And the theory behind that is that, rather than having patients come in for certain conditions, how do we manage them more in a virtual setting or in people's homes? And that's both patients coming in, but it's also about discharging patients so that we can get them to a place, discharge them quicker from hospital, but at the same time manage them more effectively. And so the three areas that we're focusing on at the moment are in the respiratory space, so COPD, chronic obstructive pulmonary disease and asthma. The second one in the cardiovascular space with heart failure, and the third one around frailty. So those are the kind of three areas that the NHS is focusing on to start with, and then we'll expand into other clinical areas. And there's about £500 million that's been allocated towards virtual wards, and there's now many tenders that are coming through from hospitals, integrated care systems, where many of them are bidding for contracts in terms of setting up virtual wards. And this is going to be an interesting space because from a clinical viewpoint, one of the things that we are looking at in particular is what makes a good patient to be on the virtual ward. Because at the moment, it's unclear. Of course, there's some evidence and some science about how this might work, but actually, for a virtual ward to be effective and for it to be utilized in an effective way, we need to really make sure that the right patient that's engaged with technology is able to go on a virtual ward, rather than just getting everyone a virtual ward, because it's not going to be for everyone. And so that's a learning at the moment that we're doing to figure out who does this work with and who does this not work with. And then finally, a big system initiative that we have is the Frontline Digitization Program, which is essentially how do we digitize all the records across secondary care in particular. So at the moment, we have 86% of hospitals in the NHS are now on an electronic health record. and the ambition is that we want to get to around 95% by the end of next year. And so that's been, again, a big acceleration, and this kicked off, well, it's been in the making for the last decade or so, but it's really been accelerated since the last 5 or 6 years, where there's been more money that's been coming from central government, but also a lot more focus in terms of how do we digitize secondary care. Primary care has been on digital electronic records for the last 30 years, but it's only secondary care where we've been seeing a lot more, and so we'll see that kind of speed up over the next coming months in particular. And finally, I just wanted to share this point, which was that with all of the exciting things we're doing on the patient-facing stuff and on the clinical system-facing stuff, none of this would really be possible if we don't think about our workforce. And so there's a number of initiatives that are in play at the moment across the NHS, which is how are we upskilling and training our workforce? Because again, the technology is going to always advance. We're always going to see lots of new, shiny, interesting things, but ultimately it's going to be the people that work within the health service that are really going to drive this forward. And so on that, there's a number of things that are being rolled out, but also currently in play, which is allowing us to upskill and develop greater insight knowledge for the workforce. At a senior leadership level, when it comes to chief information officers, chief clinical information officers, but also digital leaders, we have something called the NHS Digital Academy. And this is a year-long program that is training up to 100 of these leaders a year, so we've had about 500 go through that program, but that's very much focused on developing that kind of senior leadership role where, again, we want to make sure we are training the best, and they go on to build great teams in their organization. So there's that kind of senior leader program. Kind of the mid-career program that we have is something called the Topple Program Fellowships, and that's very much focused on clinicians and non-clinicians that really, again, want to develop a career down the route of digital transformation and combine it with their clinical work. And so we have that program. The Philip Ives Review, which Andy touched upon, is that, you know, again, there's been a big push in terms of making sure that we don't keep this solely for doctors. How do we include nursing and midwifery into that as well? Because we're seeing many nursing and midwifery leaders who want to also be involved with digital transformation. So that review in particular was looking at what are some of the skills and competencies that we need across the patch so that we get many more nursing and midwifery leaders in place, which links to the Chime Digital Health Leadership Academy for nurses and midwifery, which I know Jane and Andy will also pick up in our panel session, but that in particular has been focused on training and upskilling nursing and midwifery. So you can see a number of initiatives in place. The exciting part here being that, you know, we're still on that journey. There's still a lot to be learned, but the fact that there's been a greater acceptance and many people are now seeing the usefulness of this, we're going to be heading towards a hugely exciting few years in the coming time. So thank you again, and great to be here.
Thanks, Dr. Harpreet. Very interesting. And I've been reading about NHS Digital and NHS England merger. I think that happened very recently, right? And it's fabulous that NHS has always been a leader in many initiatives globally. And I think a country-wise app is not easy to implement, as we all know here. So that's great to know. Also, upskilling, I think, is a fabulous initiative. I think that's something that all of us here can look through some of the programs that Chime's got and see how that can be implemented. The next speaker is Jane Dwelly. She's again from London. She's the Vice President at Chime International, and she's going to give us a CIO's perspective and how a CIO in Indian organizations could maybe, or globally, can adopt to policies, programs that Dr. Harpreet and Andy had spoken about earlier. So, over to you, Jane.
Thank you so much. Great to be here. Good morning, everybody. I'm Jane Dwelly. I'm from London, and I'd just like to thank the Chime India Board for inviting us to come to this wonderful conference in Delhi. And we've so enjoyed our time here, made some wonderful connections, and many, many new friends. So thank you so much, everybody, for helping us do that. Now, I'm going to talk to you today about digital health leaders and pick up on what my colleagues Andy and Harpreet have talked through already, the unique situation we find ourselves in now, in which we are now facing the post-pandemic world with all the opportunities we have to make digital health the thing that makes healthcare safe, effective, and a great experience for all patients that we care for. I'd like to introduce you to Myra Davis. Myra is a great digital health leader. She's also a CIO and has worked for many, many years at Texas Children's Hospital in the United States. And when the pandemic hit, if you remember, cast your mind back to the middle of 2020, Texas was particularly badly hit at a certain point by very high rates of COVID, and the Children's Hospital had to start taking adults who needed ventilation and help with their COVID symptoms. And it became a very huge health emergency for the hospital to cope with. And Myra called her team together and said to them, "There is absolutely no script that I can give you right now to show you how to lead, but you will lead through this time. This means that we will shift and shape and change and pivot, and we will continue to have momentum that goes forward." Now, Myra could say that to her people because she had spent 25 years herself developing as a great digital health leader, but also developing that digital health leadership within her own team. And she's also a fantastic member of Chime. And I want to just show you now the things that she does every day in her job and in her digital health leadership role that make that possible. And the things I'm going to talk through are called the Chime success factors. They are 6 attitudes, postures, and behaviors that we have worked out over the 30 years that Chime has been in existence that make digital health leadership go really well. And that's why they're called success factors. And I think it's worth sharing with you now because these are the kind of things we're going to be seeing people do as we go forward from the pandemic and as we start to work really hard to make digital health the thing that sustains healthcare for the 21st century. So the first thing that people working in digital health transformation do really well is they understand where they're going. They understand the strategy, and they understand how to make those digital strategies truly transformational. And that involves things like understanding what the end game is, but also looking for the potential in technologies and having that network of people around them that understand that making this happen is all a matter of having a plan and understanding what tools and techniques to use and what to do first, so identifying priorities. The second thing that we see at Chime that people do really well is obviously they lead change and they understand how change happens, and they have a good basic understanding of the various change models around. You'll be aware of some of those yourselves. But it's really important that you can use those effectively to make a plan to sustain change and also bring people with you by creating a case for change and describing a vision. And it's interesting, actually, a lot of the work we do in Chime is surrounding communication and how people explain that vision and use techniques like storytelling and their own personal reasons for being in that job to make that change possible. And people will only follow leaders that they believe in and that they trust to lead them through a difficult time. And we find this happens very well when people have got that power of storytelling and the understanding of the potential of where they're taking their team to. So we're extremely, we focus more and more on the power of communication and storytelling, not something you might necessarily associate with a digital health leader, but we believe it's really important. Thirdly, a digital health leader of the future needs to understand their customers. And by customers, we mean everyone accessing those services. We tend to use the word customers more than patients because sometimes we're looking at people who are living at home and helping them in their home environment. And also, ultimately, we hope they're not patients. We hope they are people accessing wellness services delivered through whatever organization the digital health leader is working in. So understanding a customer is really important and making sure that they are constantly engaged in the process. So many times in the past we've seen initiatives fail because they haven't worked for the end user, the customer or the patient. And understanding that fast-moving world the patient lives in they have access to so much information, and making sure they understand and engaged in what we're talking about as part of the digital health transformation in question is incredibly important. And again, in Chime, we talk a lot about how we can understand the customer and also give them what we would also call a retail experience. After all, people are very used to using technology in every aspect of their lives, from things like the way they handle their money in banking, from their social lives, paying their taxes, and so on. That's all done online, and they've become very sophisticated consumers of digital services online, and that shouldn't be any different in healthcare. So understanding how we can make that transformation happen is a key part of our digital health leadership. But of course it has to pay, and it has to be something that is adding to the value and the productivity of an organisation. You'll be all aware, of course, that most digital health initiatives come at a price, and so describing the benefits that come from that investment is a core part of a digital health leader's role, and making sure that people understand how to get the money in the first place. What's the governance model? What's the business case? How do you understand how to get that money through the system and as quickly as possible into doctors' and nurses' hands to start making the difference count. And of course, there is never enough money around, so balancing existing priorities with the initiative you want to bring about is also an important part of your leadership role. Teams. Nothing is possible without people. We often say in Chime that digital health starts and finishes with the people that deliver it. And technology is nothing without the people to bring it about. And Harpreet, working in the NHS Digital Academy, took that idea and ran with it when they started the academy by making sure that everybody understood that every health worker is now working in a digital health environment. So every health worker needs to have at least a basic digital health knowledge, if not a more superior one. And so understanding how your team develops, how you look after your team, sustain them, educate them, and recognise how individuals in that team can contribute but also take away from that success. So we're asking our digital health leaders to be amazing team leaders as well. It's a big ask, and there's a lot of aspects to this leadership role that we think is very important, but also, as you can see from this list, there's a lot of stuff to ask one person to do. And finally, building networks and communities. We often say that it can be quite lonely being a digital health leader. We know from our experience working with digital nurses and midwives, oftentimes they're the only digital nurse or midwife in their organisation. And it's hard to carry on being that person without support or understanding and buy-in from your own organisation. So at this point, we encourage people to turn to their networks to make sure they have got people who can encourage them, share their stories, share their dilemmas, share and celebrate their successes. And we have seen a huge success in the UK with networks, but I'd also like to think that Chime and Chime International and our friends in Chime India are also a fantastic network of support, encouragement and understanding for people working through this very difficult, challenging but ultimately rewarding role they have as a digital health leader. So they are our 6 success factors. They're the things that Chime has identified through our work with digital health leaders over the last 30 years as the key areas in which we'll see productivity increase and digital health leadership become a major focus of any healthcare organisation's efforts. And finally, here is Chime International. I'm so proud to work for this organisation. I've been doing this for 5 years, and across the world and with our friends here in Chime India, we do 3 things. We look after a global network of digital health leaders, making sure they have access to the information, resources and the network they need to be successful and to learn from the best and take comfort in what's going on around the world. We offer and run exemplary professional digital health education for digital health leaders of all stripes, managers and clinicians, so CIOs and the doctors and nurses who work with them. It's really important that we are able to bring this education to people in a way that is effective for them. We don't take up weeks and months of their lives to do that, but we do it in a way that's, the 6 success factors I just talked through, and also the way in which we manage their time on the course. So we're very proud of the work we do there. And finally, we also run an accreditation program. go back there, sorry, an accreditation program, which gives people the chance to benchmark those success factors, their experience and their leadership skills against other digital health leaders around the world. And we would like to recognize success. We think professional excellence deserves recognition, and we do that through our accreditation program. So thank you so much for listening to me today, and I'll be happy to take questions with my colleagues after this.
Thanks, Jane. Very insightful. I think healthcare, digital healthcare 2.0 is more about consumerization, and it actually gives a lot of options for CIOs to open digital services for their healthcare organizations. And the programs of Chime, I recommend that to everyone. I think they're fantastic, and people need to enroll to that going forward. So our next speaker is Vishnu Saxena. He's the founder and CEO of Scale Health LLC, which is an IT consulting firm based in New York. So he's in India after 12 years, and he's very excited to come to Delhi, and he's going to talk about data democratization, accelerating India's digital health transformation. I'm sure we can draw some constructive comparisons between what's happening in the UK and what we're looking forward to in India. So I'd like to welcome Vishnu. Hey, Vishnu.
Good morning, Delhi. Good morning, THIT. And it's an honor and privilege to be here. And as Ajit said, this is my first visit after 12 years since I left India 12 years ago. The city is, I call it my beloved city. I got my education. I started my first job. I never realized that it will take that much time, long time to come back. But it's very honored. And also equally excited to be part of this THIT community and this conference. And this is my first ever conference, a health IT conference in India, of course. And the kind of dialogue, the kind of conversation, the kind of cooperation led by Apollo with across the variety of stakeholders and health system in India, design, dare, dream, and execute. I think these things are very unique. And it gives me tremendous confidence and encouragement that India is on the right track to adopt technology and to provide better healthcare, which is affordable, which is accessible, and of high quality. So, and thank you, Jane, for great presentation, great insights. In my previous life, my UK team was working very closely with NHS, so great to see NHS team representation here. And I was also a former Chime Media Liaison in the US. I worked very closely with Chime in the US, with the Russ and the whole gang, and a variety of other fellow Chime Media Liaisons. So the topic that we are going to talk about is data democratization, how it can help accelerate a digital transformation journey that India is on. And so I lead a company. I'm a founder and the CEO of a company called Scale Health. It's based out of New Jersey in the US. And we are at the intersection of health IT consulting solutions and innovation and engineering. Next slide, please. oh, sorry. Yeah. So what we're going to talk about in the next 10 to 12 minutes is, context of data democratization. Why we are even talking about data democratization, and how we can democratize the data that can essentially help accelerate the digital transformation that we all talk about and wants to have. And the challenges, what challenges, data challenges, barriers that we see along the way, and that is holding us back, right? So let's have a look quickly. And lastly, and very importantly, it's not about the data. It's about what you do with the data. That matters. Whether it's a bad data, it's a good data, and if it is good data, and if it is lying, just no meaningful outcome is coming out of that. So it's important that once you unlock the value of the data, what you do with the data. So I'll talk about at the high level, 3 use cases like digital front door, health equity, and AI for care delivery. So let's have a look at the context of data democratization. And the whole game, the whole aim, sorry, okay, is how we can leverage digital to drive and produce an outcome that results in a healthy country, right? If the aim is to have a healthy country, it starts with the healthy patients, healthy hospitals, that translates into healthy community, and that results into healthy country, right? We are the most populous country in the world, and that means we have added responsibility to leverage technology to drive that high quality care delivery outcome, right? So if you see on the right-hand side, and these are some of the key factors that essentially driving the need towards data democratization, right? We have a first vast supply of data, right? If you see on the right-hand side, on the circle in the 9 slices, these are the, the variety of sources where we are generating data. And healthcare is one of the industry which is highly data-centric compared to any other industry, right? And not only we have high velocity, high amount of data, but variety of data, right? So A, we have lots of data coming, and then B, we have lots of variety of data coming. That complicates, the situation further. So, if you see a patient journey, right, it starts with the primary care office, then you go to a specialist, then you go to an imaging center, then you go to an, if it is required, an operating room. So all these stops generates data. And then these days, of course, we are wearing wearables and all those, consumer-centric devices. They are generating data, right? So we have lot of data coming. So we need to really need a meaningful outcome and actionable insight out of the data. Then the consumption of data. We talk about AI, we talk about analytics, we talk about all these things. They really need actionable insight. You can't feed raw data and these all vast data into an AI or, an automation or, any other areas, like you want to provide a personalized, great consumer experience. Based on what? Based on curated, high-quality data. So analytics tools, AI, they are data hungry. They need lots of data, but that has to be a good data. Time to value, speed to innovation is something extremely important, right? So if you see, most of the time, 70% of our time goes into accessing the data, collecting the data. That leaves all of us less time to focus on innovation, to focus on getting the meaningful output out of that, because we are too busy in just collecting the data, cleaning the data, ingesting the data, right? So we got to reverse that. We got to reverse that in a manner that we focus only 30%, 20 to 30% of the time in accessing the data, collecting the data, and then ingesting and cleaning the data. So less manual labor work, more focus on innovation, more focus on how we can drive that insights and can provide that liquidity of insight across the enterprise. So that's called like time to value, speed to innovation. That happens through data, data democratization. Okay, let me go back. Improving health of population. I think this is something we all want, whether it's the US, whether it's the UK, whether it's India, Australia, everywhere, everyone wants better outcome for their citizens, for their people. They want to reduce the cost of care delivery, right? And they want to provide better healthcare, accessible, which is affordable. So improving health of the population, how you can, you really need to understand the population, right? And how you understand the population, you really need the high quality, good data, not just clinical data. I'll talk about the other types of data, like social determinants of health data, right? So how we, get that. So that's where the context which is driving the, the need for the data democratization. Enhanced experience for care of patients. like everybody in this room, we must have booked flights, right, to arrive here. We are shopping on Amazon, right? So we are bringing our experiences from other industries, and we expect the same kind of experience in healthcare, right? So we call it like liquid expectations. So the experiences are seeping in from other walks of life into healthcare. We want on the mobile phone, to be able to make an appointment, right? We want to see our lab results, right? Cancel change appointments, all those kind of things, prescription refill. So so data, so the modern consumer experiences are shaped and defined by data. Reduce per capita cost of healthcare delivery. This is something extremely important. We are a most populous country. We can't afford, even if we have hospitals in every nook at the corner, we cannot achieve, the sustainable model. So we really need to leverage technology. We really need to leverage data in order to reduce the cost of care delivery. How? So for example, if I'm seen by a doctor, and then I'm referred to another doctor, and another doctor prescribes me certain tests, which I have already done in the past, like 2 days back. So, but the problem is my data is stuck with my previous doctor, and my specialist is not able to access that data. So a specialist ended up and ends up prescribing more tests. So you can see there's no need for further tests. It adds, the cost of the care delivery. So one test, unless it's needed, then of course it's required, but you don't need the test in a week, multiple tests in a week, just because the other doctor doesn't have your vitals or your the data, right, clinical data. Improving the life of clinicians and the staff. I think this is extremely important. In healthcare, lots of focus. We all talk about patient centricity, consumer centricity, and I love Jane, of course, we are all about consumers. So consumer centricity is, we all talk about that, right? But in that process, sometimes unintentionally, we miss the people who deliver the care, the clinicians, the staff, nurses, right? They also deserve the same level of attention as patients. So physician burnout in the US is a big problem. I'm sure it is a big problem in the UK and the NHS. So how we can leverage the data that essentially reduces the workload of our dear physicians, nurses. They have actionable information. They will be able to provide a great care delivery, right? So that these are some of the, I would say drivers that are actually pointing all of us towards the need of data democratization. Now, how? So we saw the need that data democratization is important, but how, right? And how we can create a data-driven hospital and ecosystem. So the first thing that begins with is digitization of the patient record, right? I think this is something is like a table stakes, and this is extremely important as a fundamental as it could be. In close to around 10 years back, right, around the same time I went to US, the US government mandated the use of certified electronic health record across the US, right, with the passing of the HITECH Act. That triggered the tsunami. Actually, that created an environment, that created a catalyst environment where all the digital transformation started to take place. Now in India, just imagine that situation in India. We are a big country, we are a very complex country, and we are still a lot of paper-based. And in fact, US is such an advanced country, but just imagine 12 years back, we had all paper-based, everything was too much of paper-based. So they realized, hey, we need to correct this course, and they started, and they forced hospitals to buy certified EHR technology. And that led to the innovation and digital health, mobile health, everything that you can think of started from there. So applying the same thing in India, I mean, hospitals, the hospital department, government-owned hospitals like railways hospital, army hospital, everywhere, like at the village level, at the district level, all those hospitals, first, they need an EHR technology where a patient's clinical information can be captured, and then it can be shared across the variety of stakeholders which needs them, right? So UHI, I was very impressed yesterday when I learned from, I guess, Dr. Alok Garg from the National Health Authority. So India is on the right track with the right policy, with the right set of technology being implemented. And I think that will further accelerate, and we got a UHI, right? But it will accelerate if we have across the board a EHR that being used by all the hospitals. Individual longitudinal health data, I think this is something very important because the clinical data determines my health outcome only 30%. A person's health outcome is determined not only by the clinical data, but other data, like social determinants of health data, right? So I think this is critically important that we really need to focus more on how we can have individual longitudinal health data. Within the episode of care, like, you know, when you have medical devices, when you are in a hospital, and then between care setting and the stakeholders, when you are transition from one care setting to other, getting data seat at the table is extremely important because hospitals now should have a chief data analytics officer, chief data officer, along with the CIO, along with the key other leaders. So getting the data seat at the table is extremely important. Standards HL7 FHIR is something, is critically important, and I'm glad to see that the FHIR adoption and HL7 adoption is taking, ground in India, and I think all the ABHA and Ayushman Bharat Digital Health Mission is using HL7, and I think this is critically important. People, process, and technology, you can't go wrong, and these are the very fundamentals to achieve that democratization. Next, I'll be fast. I know I have unpacked lots of things. What is holding us back? If you see, again, lack of availability of the PHI, right? So that's something is holding us back. Data integration and sharing across the ecosystem, interoperability. I mean, you can't achieve the interoperability if you don't have the patient health record available in electronic form. You can achieve that in pockets with Apollo, with Medanta, with Fortis, with Breach Candy, Manipal, all right. But what about the rest of the India? You really need to have that digitized patient health record, then you share. Data integrity and the quality of data is extremely important. Old phrase, garbage in, garbage out. So quality of data is extremely important to provide a high quality outcome, right? Lack of processes, enterprise data governance, is extremely important. You really need to have how data is going to govern across an enterprise. Data storage, people and culture, privacy. The more you share the data, you have added responsibility to protect that, right? We talk about data liquidity, which is good, but then we have added responsibility that we need to secure the data. The cybersecurity is a big problem, right? So we really need to focus on privacy and the data security. Awareness, adoption, and top leaders buy-in. I think data democratization should be an enterprise goal. It started with the CEO, with the CFO, with the CIO, with the Chief Data Analytics Officer, because it is extremely important. Data is a new solar. Data is a new found oil, right? So this is extremely important that data should be given top priority by the business stakeholders. Now, it is not about the data, but what you do with the data. This is my last slide, and I will be quick. Now, you got great data, clean data. You got, you're able to do AI. You are able to do an automation on top of curated insights, which is coming out of that. Digital front door, right? We talk about consumer centricity. So digital front door is something is extremely important, that how you can provide a frictionless, a experience across patient's journey and across the channel. I call it, click it, walk in. If I want to see a doctor, I can go on my mobile phone or my laptop. I can schedule an appointment. I can, call a call center, and the call center agent has all information about Vishnu Saxena and can provide a great experience. I call it, right? Walk in. You can walk in an urgent care center, and the front desk has all information about you. Walk in, right? So that's important. And how that is possible? When you have data which is driving, which is unlocking the value that is powering your digital front door. So if you see this journey, if you see the circle, start from identifying the doctor, contact center enablement. I'm not going to go the whole, but the idea is that how you can enable a digital front door, which is doing the round, which is a big, big focus in the US. And I'm sure in India as well, that how you can provide that frictionless experience that patients crave, the way we have in Amazon. Health equity is extremely important. We are a complex country with lots of languages and races and all those things. So again, data drives that health equity and reduces the health disparity. AI for care delivery, how you can data to do a prevention, to do detection, to do diagnosis and treatment. So I know my time is up. This is a great topic. I can go the whole day, but I'm really appreciate that, being part of this community. And thank you so much for listening. Look forward to your questions after the talk. Thank you.
Well, it was indeed a great session. So with this, we are done with the first one. Okay, so to give token of honor, I would like to call upon Mr. Nicholas Peters to please join us on stage. Thank you so much, all the speakers, for your wonderful thoughts.
So, thank you all for that excellent session. So you'd like me to moderate the discussion? Yeah. Mementos. Okay.
I request you to present token of honor in the form. Yeah.
Delighted to do whatever requested.
Can we have gifts, please? So I request you to present to all the speakers. Sometimes it happens. All right, ladies and gentlemen, let's be a part of it with a huge round of applause. Thank you. Okay, so one exciting thing I would like to share with all of you on public request. We have decided to serve you. We have decided to give food to thought before we serve to the stomach. Yes, we are conducting our quiz session here in this hall just before the lunch, and don't forget about our exciting gifts. So all speakers can take their place. Okay, Q&A. Okay, so we have 5 minutes for Q&A. Feel free and ask whatever is in your mind.
I think the floor is now open to the audience.
Yep.
Love to take, maybe we can take a couple of questions. Try to please keep it brief and, if possible, relevant to the topics discussed. The speakers are anyway going to be around, and I'm sure you can get hold of them outside. So, any questions?
We have placed mic over there. Yeah.
So I thought that was a particularly enlightening session, and coming from the NHS, I particularly enjoyed listening to my NHS colleagues. Just a question for Harpreet. So the 111 service is being highly promoted, and in the context of the effort in virtual care, and particularly virtual wards, in an attempt, which is an attempt to keep patients out of hospital beds. The trouble is that 111, of course, is driving patients towards hospital beds because it's not a source of action. Just to explain to everybody, so 111 is a telephone and online service for giving advice, but is not really empowered to initiate and to close the loop and initiate any sort of treatment. And the default, if there's any doubt in 111, and of course in clinical care there's always risk aversity and an element of doubt, and so very often patients who ring 111, and I don't know what the figures are, but they're driven towards go to the ER, okay, go to the ED. So we have a number of conflicting forces here, and so if we're going to keep people out of hospital beds, at the 111 point, we need some sort of actionable process that is a safety net and initiates treatment at a level that is safe without simply guiding them to the EDs. Or we've got a conflict of interest here and an internal conflict that is so common in the NHS. Harpreet, any comments around that?
I think that's a great point, Nick. And if I can give you a view from a clinical perspective in particular, if I see the patients that I see that come through the one-on-one, I think it ends up creating more work for me than it does actually reduce my workload.
And for me too.
Yeah, exactly, because we're having to do the whole thing again, take the history, examine, and so on and so forth. So I totally agree with you. I think the initial concept for the one-on-one, as well as with the app, is creating those channels that allow people to access services, to help alleviate the burden from all the other services that we have. But the challenge with that is that if you don't staff and resource it properly, like you're saying, you all end up going towards your GP or your A&E anyway. And I think that's where there is some thinking going on at the moment, but there hasn't been enough for us to divert those services. So just as an example, we have now, across the one-on-one service, more pediatric clinical members who are engaged with that to help children and the families that call in regarding pediatrics. But I think it's not a fully fledged service like that yet that will allow us to do exactly what you're saying, and I think that's a big opportunity that we need to focus on.
Okay.
Vijay Theo, I represent from Narayana Health. My question to Vishnu Saxena. You mentioned about the 30% less focus on the data collection. Don't you feel the structured data is more important for whatever the 70% of the innovation what you're focusing on?
Very good question. So essentially, when you unlock the value of the data, your focus on and your efforts in collecting and accessing the data goes down, and then you focus more on driving that, using that actionable insights to drive innovation, to drive more use cases, to train more quality AI, to do more robotic process automation, and that enables the enterprise-wide transformation. So, we need to reduce the effort in collecting, accessing, cleaning, ingesting the data. You have to put an effort initially to begin with, because it is a tedious task to get the data right. As you start the journey, the focus should be in minimizing the effort in accessing the data. Because if you continue to access the data, because once you have the right people, processes, and technology, as I said, in place, your focus will be less on collecting the data. Your focus would be more in how you can take that curated insights out of that data to drive more innovative use cases.
Thank you. Do we have time for another? Yeah, okay, thanks. Thanks.
All right, so with this, we are done with Q&A session. Thank you so much, all the speakers. Thank you. Thanks. Okay, so before we switch to our next session, I would like to share one small quote. The best collaborations create something bigger than each person can create individually. Healthcare with IT is the best thing, and they are doing wonders together to the people around the world. And credit goes to each and everyone. So you may applaud that for yourself, ladies and gentlemen. Thank you. Okay, so let me tell you all, now it's time for our next session. And the topic is computing challenges in clinical data. To conduct this session, I would like to call upon chairperson on stage. He is Mr. Ashokan Somavirappan to please join us on stage. He is Chief Information Officer, Apollo Hospitals. Welcome to you, sir.
Namaste and good morning, everyone. It's pleasant to hear the speakers from the UK and the US for us. Now we will come back to the country of our own selves. This session is all about how do we kind of manage challenges within the computing that we kind of see with more amount of data. To start with, we will have Ms. Shika Agarwal from Microsoft. She is the CTO of the data portfolio in Microsoft. We heard her yesterday on the ChatGPT and others. It was great to hear her yesterday. And this topic that she's going to talk today is about how do we clear the room and get homomorphic encryptions for all of us. Over to you, Shika. Thank you so much.
Great. So first of all, I want to express my gratitude for a very, very inspiring session yesterday. It was thanks to this opportunity, I was able to engage in so many enriching conversations with the global leaders in healthcare space, which are on a mission to enable healing and care for all of us. As I was heading back home yesterday, there was a key thought that was lingering at my end, and that was a question posed by Lord Ajay Kakkar, which was like, are we doing enough? And, you know, looking at the possibilities that become available to us via collaboration between people on the ground who understand the real need, people who understand the possibilities arising out of tech innovations, the possibilities that emerge out of a good understanding and collaboration and unleashing the power of data, they are phenomenal. And earlier in the session, we saw how democratizing data access is a key to a lot of artificial intelligence related endeavors that today we are pursuing with, at an accelerated pace. So the topic of today's session for me is confidential clean room, which essentially is a construct that solves some of the challenges that we heard early on in the session when we talk about collaborating and breaking data silos. Let me get started with the slides here. Now, if we look at some of the possibilities that become available via just artificial intelligence, so we are able to create machine learning models for predictive diagnosis and care guidance. And I know some of the projects that have been undertaken by Apollo to really accomplish this. And and then of course in medical imaging, today we have the ability to analyze all those diachroma images and train machine learning models that can come to the assistance of the doctors to figure out what are high probability cases for, say, cancer. And also in COVID times and pandemic times, we saw how population scale health analytics enabled us to act quickly. So now, yesterday in one of the conversations, what we observed is how important is the power of utilizing diverse data as we engage in any AI or machine learning activity. So a simple thing like what leads to obesity. Now, if we restrict ourselves to data points in a certain geography, say India or United States, there is a likelihood that the machine learning model will sort of interpret that people with high income are more likely to be obese. However, if we incorporate data from a country like Australia, you know, that's when the model might actually learn that the core that leads to obesity is, you know, the eating habits and the fitness programs that we follow. And so that is just one simple example how important it is to break data silos, not just within the organization today, but across organizations, across verticals, as we embark on unleashing the power of data via these amazing AI algorithms that are becoming available to us. Now, what are the challenges as we sort of strive towards collaborating this data across organizations? So data privacy, we see across the globe, data privacy concerns come in the way of collaborating on data projects. Also, if we look at another challenge, that is the regulatory compliance. It is getting more and more stringent, and then how do we actually break these data silos, bring all this data together to create these compelling machine learning models that can then give results that are beyond human capability. So good news is today we have technological solutions that enable us to do something that was earlier unthinkable, which is you enable data sharing without actually giving data access. And that is made possible with something called as confidential computing. So traditionally, whenever we would look at accomplishing something like this, we would look at creating encrypted data repositories, and that would, of course, give us an ability to take care of the privacy, etc., while the data was in storage and also while it was in transit. But with confidential computing, we are now able to take care of data privacy, data confidentially while it is being used. And that is essentially made possible by processing the data in what I would term as trusted execution environments. And let me share some insights about what do I mean when I say trusted execution environment. So some of the hardware innovations made possible by Intel and AMD. Today we have hardware chips with something called as Intel. For Intel we have software guard enclaves, and for AMD we have SEV SNP VMs, which essentially give us an ability to do two things. So A, as the data is being processed, it is being processed in encrypted memory, and two, we have now an ability to perform remote attestation that we are actually executing our code in trusted execution environment, and the binaries, the business logic that is going to be applied on top of that data, it is really what we expected. And only after we make a remote attestation of that is when we can make a decision whether we want to share the data or not. So if we look at remote attestation and another, so I talked about remote attestation. There is another hardware or a combination of hardware and software construct, which is secure key management. So one of the things that we do as we process all this data is to encrypt this data. Now with secure key management, we now have the ability to define policies which say that this encrypted data is going to be decrypted only in my trusted execution environment. So these are some of the building blocks that make it possible for us to create those confidential clean rooms wherein now multiple parties can come together and share their data while data privacy, data confidentiality, all these requirements are taken care of. Now, just to give an overview of the confidential computing landscape on Azure, so starting with virtual machines powered by both Intel SGX as well as AMD SEV SNP VMs, along with NVIDIA-powered GPUs, to containers that enable us to create those population scale solutions using this confidential compute technology, to managed services like SQL Always Encrypted, Azure SQL Ledger, and managed CCF. We have a whole comprehensive suite of offerings that enable us to create the solutions that would enable us to unlock insights from the data as we attempt to process data for machine learning or any other data analytics sort of computational scenarios. Now, if we talk about multi-party machine learning, the key objectives out there are to preserve the integrity of the model, to preserve the integrity and confidentiality of the data, and of course the code integrity. And with trusted execution environments, with our ability to decrypt data only within the trusted execution environment, we are able to accomplish all these objectives. Similarly, even when we talk about inferencing. So let us say an organization like Apollo has created a model that can be utilized by many organizations across the globe. Now, with confidential computing, we can give attested verification that the data being shared for inference is going to be used only for the purpose that it was meant for, which is getting inference on top of the model that is hosted. And so the organizations will be a lot more comfortable in utilizing this capability, which an organization may have built after investing a tremendous amount of effort in training the model. So that is possibly the core thematic that I wanted to share in today's session, considering the possibilities that it enables for us via unleashing the real power of data by collaborating with multiple parties. We believe that it is going to be the future of computing. And with that, thanking you all for the opportunity and handing over to the next speaker.
Thank you, Ms. Shika. I think the previous session, last speaker said about democratization of data. I think this is democratization of technology. She kind of laid the entire thing. I think the mantra that I think all the techie guys are going to take is CCTEE. Yeah, that's good to have. The next speaker, now that we heard about the enterprise company, now we'll move on to the consumerism company. We have Nitin Agarwal from Google. Nitin heads the cloud AI computing services. He has a decade plus of experience on machine learning and artificial intelligence. What is it that we are going to hear from him as to how do we build gaps and get the cloud computing in action?
Thank you so much, Shokan. And thank you so much, THIT, for this particular opportunity, this amazing opportunity to interact. Just like I mentioned, I'm Nitin. I currently lead Cloud AI Services team for Google India. We're closely working with Apollo 247 as well. We will be mentioning about some sort of implementation, some sort of ideas as a part of our workflow. I really concur with the ideas that Mr. Vishnu has presented in his one of the session about data democratization. I'm a strong believer that yes, democratization of the technology, whether we're talking about the data, whether we're talking about the healthcare protocols like HL7 or FHIR, that's going to bring the right value, that what kind of problems that we should be solving and how we should be solving. Yeah. So we are saying that, okay, hey, the data is actually exploding in the healthcare domain. In one of the recent study published by Brunswick, they mentioned that almost 30% of the world data is being created by the healthcare sector itself. Is generating data is enough or not? It may or may not be say that, okay, hey, a lot of medical imaging, a lot of structured data, one of the questions came in, is being created by this particular domain. But can we actually transform the patient care? That's the foremost vision. That's the foremost target behind providing these kind of a healthcare transformations or any sort of a transformation using technologies. Just generating the data, just storing the data may not be adding that particular value. The idea is that how we are processing the data, what kind of values that we can actually add using AI or not. We are actually moving forward with an idea of diagnosis and a prognosis. We are moving away from the predictive analysis on the data rather than we are moving towards a preventive analytics, that what kind of a things that's going to happen in the next 1 year, that's going to happen next month, sometimes what kind of a things that will be actually happening 24 hours or 48 hours down the line. Along with that, we are saying AI is not just about what will be the next best action. AI is actually transforming the overall business workflows, the healthcare workflows, that how we should be thinking about the problem and how we should be solving the problem. This is our future. This is what we are saying is that, okay, hey, the future of healthcare is connected. We are saying is that, hey, FHIR, FHIR is going to be the future. We are saying all the data will be actually stored in this particular domain and this particular protocol. Whether we're talking about payer, we're talking about provider, we're talking about the patients, all the data sets will be automatically and easily extracted, connected, so that we will be able to make a common sense out of it instead of processing data at the silos. Data interoperability is going to be the ubiquitous. It's going to be the most powerful thing that will be happening in the healthcare, because unless you have the connected data, you will never be able to connect the dots. You know that why the pain is happening, but you do not know what's the reason behind it. You know know that, okay, hey, why you're getting this kind of a disease, but you do not know that, okay, what will happen 3 months down the line. If I'm going through some sort of a cardiovascular, what I should say, care in any hospital, in any clinic, I do not know that, yes, if I'm actually changing my lifestyle, my clinician, my physician is not aware of it, and AI is going to be the Microsoft that particular future. It is going to provide me that, hey, these kind of things are actually happening at your end, what kind of things that you should do, and how should we changing it. So in this case, we are saying that, yes, everything is goody-goody. We are saying, hey, FHIR is going to be the future, ML or democratization or data interoperability. But what are the key challenges? The data governance, privacy, and security is the biggest challenge. One of the speakers, my previous speaker, Shikha, mentioned about that how we should be processing these kind of data. When we're talking about AI, we will be moving forward with federated learning so that patients needs not to upload their data anywhere into the cloud. Given the cloud coming into the picture, giving the computing power coming to the picture, data governance and security is going to be the key reason behind it, or some of the key challenges behind it. What kind of an encryption technologies that we are using, how we are encrypting the data, to whom we are actually sharing those kind of data points are going to be the most important questions. Data interoperability that we have already shared, but finally about turning the data into insights, what kind of things that we can generate, what kind of things that we can solve, that's going to be the most important thing. Now you can say that, okay, Nitin, you have shared a lot of terms, you have shared a lot of what I should say, gyan in Hindi, that yes, what are the things that you should be doing? Can you share me a customer journey? Can you share me a patient journey? That what are the things that I should be solving? How should I be solving? So let's take an example. I'm saying that, okay, hey, Sally is a 30-year-old woman. It's just like a sample example, let's say, and she needs some medical care about some certain conditions. And she wants to know about that, what are her options, her medical insurance plans, how it works, what will be the in-network and out-network, like the doctors and so on and so forth. So what I will do, like what the Sally will do, Sally will start doing some sort of a research, typing, interacting with a chatbot. Mention the first interaction is going to be a chatbot where we will be saying that, okay, Sally asking questions. I'm facing these kind of conditions. This is my insurance plan. No, I'm just saying that, okay, hey, can you help me out? I'm getting some headache. I'm getting some fever. What should I do? And the chatbot will be actually helping that, okay, hey, these might be the thing. These are the next steps. Asking some more questions based on the data has already been shared by that kind of a chatbot, and identifying the right plan and say that, okay, hey, whether these are the deductibles, this is the limit already left on your co-insurance, on your OPD or IHT or whatever it will be. That's the first thing we are saying about search and discovery. The second point is about coordinating care, where we are talking about clinical decision support system, where the Sally will be actually going to a doctor, to a physician, to a specialist, and this CDSS system will be having all the data points about Sally. Like any x-rays, any medical imaging, like MRI scans that will be happening, any sort of a blood work, any tabular data about the vital organs or vital functions will be actually storing and providing details and assistance to the physicians. Have you already tested these kind of things or not? Have you tested these kind of checks? If you're prescribing these kind of medications, do you know that, okay, hey, these kind of side effects might be happening here and there? That's the kind of a support we're talking about that will be happening between patient and the doctor, or the patient and the physician. And then we will be again providing the virtual assistance if patient needs that assistance. So now we are saying that payer is directly connecting with patient, patient is directly connected with the provider. Now we are coming back to it and say that, okay, hey, I'm actually wearing a smartwatch, whether it's a Fitbit, Apple Watch, Samsung Watch, whatever it will be. And if I'm going through a certain conditions, my physician is recommending me, hey, you need to walk 10,000 steps every day, or you need to manage like your SpO2 level to 98% or 99%. That data will be actually again routed back through the cloud so that it will be able to make or help you to change your lifestyle so that you will be getting better preventive care and the future diseases can be actually sorted out. And I was just having a conversation with Dr. Sujaykar on this particular thing. This is going to be that, yes, you do not need to mention that what kind of a diseases that you're actually facing, what kind of a conditions that you're actually facing. It's almost like putting your diseases on a temporal graph and understand what kind of the next action that you should be taking to prevent these kind of a future conditions or the health implications. And then you will be monitoring it, and then you will be going back. In India, the biggest challenge is claims. When I was in US for a few years, I realized that, okay, the claim processing is very easy. But in India, even if I'm going through a same network provider, similar kind of a system, I need to upload all of those kind of an imagery. I need to upload all of those kind of a bills. I need to upload all of the kind of the details again and again and wait for 15, 20 days to get it processed. And where we are saying the another integration will be happening with payer, there all the details will be automatically provided and I do not need to do anything. So this is what we are calling it as the future of healthcare in India, where everything is automatically connected with a high computing power, various kind of interaction points and various kind of values that we will be generating. One thing that's currently actually happening in this ecosystem or in this particular workflow is a chatbot. Chatbot will be coming at various places, but again, a lot of people are actually talking about challenges with chatbots. Now there is a really interesting conversations are going on with the large language models, irrespective of manning any names, but definitely the challenges are coming up. So this is one of the research published in 2019 by NCBI, and they are saying that what are the key reasons or the key challenges that physicians think about the chatbots. Interestingly, privacy and data sovereignty and those kind of things, patient privacy, never emerging as a polarizing issue. The topmost conditions, the topmost point came out as that, okay, hey, the concerns in providing the real value about effectiveness of the care provided by these kind of chatbots. This happened 3 years ago, and I'm very sure that NCBI is doing another survey very, very recently, and they might be coming up with results very soon, and this thing will go away, and the more concerns and the reasons will be coming up on the data privacy, because with the large language models, the impact has been changed. Now, if I'm an engineer, okay, from the engineer's point of view, what kind of key conditions, what kind of challenges that I can think about? I categorize them in 3 top buckets. One is understanding. If the model, if the machine learning, if the AI can actually understand the user, the intent of the user, right? India is a very funny country. Nobody writes in one language. Nobody talks in one language. We talk about Hindi plus English plus vernacular languages plus my local languages. So how I will be able to understand that particular entity, the intent of that particular interaction as a human, that's going to be the biggest challenge. The second thing is about the performance. What kind of a model explanations that I can say? Given the large language models, the model hallucination is going to be a bigger problem. Where the models say that, okay, hey, I know it all. And I'm really excited for the next section from Professor Amit that, okay, yes, how can we actually make model feel that, okay, hey, that model doesn't know everything. So it means how the model can forget few things. And finally, we're talking about the trust. Building trust in healthcare is the paramount, is the part out of it. And over here, we're talking about some sort of a distinctive anthropomorphism. What do you mean by that? So it means if you're talking to a chatbot, are you getting a feeling that you're talking to a machine or you're talking to a human? 3 kind of cues that actually distinguish these kind of machines versus humans. One is visual cues. If you're drawing some sort of a diagram, some sort of a pictorial representations. Second thing, you're talking about the identity cues. If I can actually call you by name, some sort of an identity, I can recognize you. And the third thing is the conversational cues. Can I actually mimic a human language or the human intention? That comes to the trust part, and you need to build that particular trust that yes, whether what kind of a mechanism, what kind of a value that you should be adding. And that moves to the next section for this thing. What kind of a privacy requirements we need to work on these kind of a chatbots if you're working in a very high computing environment in sort of a cloud computing. The confidentiality, the data sharing, that to whom that or with whom you will be sharing that particular data, who will be the third party accesses, what kind of an accesses that you will be providing. Along with that, one interesting point that Shikha also shared about bias and discrimination, right? What kind of a data that you're actually using to train your model on? If the data itself has a discriminations or some sort of a bias, are you actually preventing or predicting the similar kind of conditions to a certain demographic again and again and again or not? So it means the data must be biased, it should not be discriminating, and these days, if AI is improving, trust me, the spammers or the hackers, they are just one step ahead us. So it means the AI will be actually supporting the adversarial attacks, the kind of vulnerabilities that will be coming into the data privacy, data security, encryption, cyber attacks, ransomwares, these are just few of them. So we need to work on that particular idea that how we can actually prevent the privacy. And if I feel like as a patient, if I do not want you to use my data, if I do not want you to save my data, how can I actually provide that particular value without hampering the overall ecosystem of connected ecosystem to train the model based on those experiences. With this is going to be my last slide that, okay, yes, just conclude or what I should say, summarize what I said. Integrated data, that will lead to the intelligence. When I say the integrated data, it means payer, provider, patient, or research cannot be actually distinguished. You need to connect them and you need to integrate the data all together to generate the actionable insight. The second thing we're talking about is the shared ecosystem that leads to the freedom, like HL7 or FHIR, those kind of data interoperability. It's idea behind providing that sort of freedom so that you can take your data, move from one section, move from one hospital chain, move from one payer to another payer. Embedded insights. At the moment, it feels like you're providing an insights. Can we actually embed such kind of an insights into the lifestyle of a human? Can I actually get a buzz that, okay, hey, Nathan, you have not walked like 10,000. You're only at a 7,000. Can you walk for 30 minutes? It's necessary for your heart. because you are going through these kind of medical complications like hypertension, diabetes, or whatever it can be. That can actually provide the better care, and that will actually solve the real problem behind it. And finally, the trust and privacy, the trusted ecosystem that can provide the right protection that can solve that problem. Everything will be running on parallel of sustainable technology, because given these kind of a computation, you will require a high computation where you will be working, the kind of a processing that you will be required, what kind of a sustainability technologies that you can use. Are you just creating or burning like a more carbons to generate like a lower carbon points? So if we have that sort of a parallel, horizontal, scalable technologies to settle those kind of a things, I'm very sure that the current gaps that we had with the healthcare, it will be solving a lot of our problems, and it will be providing the better care for all of us. So yeah, thank you so much for the better future. You can connect with me on that.
I must say that was a quite jet express that went through from Nitin. So much of terms that I kind of tried to note on, the slides were slipping and his voice were moving on. I think the couple of key points that I took from Nitin was one, AI is the microscope of the future. I think that's good to see how a doctor's strains is going to go away. Anthropomorphism, and he also said, echoed Shika's thoughts about shared and confidential in ecosystems. Our next speaker for the day is going to be from a great academician from IIT Bombay. We have Professor Amit Sethi with us. He's going to give a topic on how to take whatever both of them said to a next level, to say, how do you give the critical ability for AI to think, I don't know. Let's see. Over to you, Doctor. Great.
Thank you to THIT for inviting me here. Today I'll talk about cautious AI. Basically, cautious AI is just the title here. I'll talk a little bit about cautious AI, but mainly I'm going to talk about a whole pyramid of things that I'm involved with, a whole pyramid of initiatives that I'm involved with, fortunate enough to have collaborators and visionaries who have laid the foundation for that, and how that is enabling us to prepare ourselves for delivering some healthcare services in a large hospital like Tata Memorial, which is one of our key collaborators. So as we all know that if we want to run any diagnostic apps, any healthcare apps, it's not just the app, there's a whole pyramid of support that is needed. And right at the bottom of the pyramid is our people and institutions. And I'm going to talk about Koita Center for Digital Health. Then we need good problems and data. And that's where I will talk about a biobank, cancer image biobank that is being built at Tata Memorial, but it has collaborators from AIIMS and PGI Chandigarh and Rajiv Gandhi Cancer Institute as well. And IIT Bombay is supporting them in building that. And then I will talk about how to get labels and annotations, which is a big pain point in medical image, building AI apps for medical images or medical data. And then some technology that we are building, and then finally the apps that we want to launch. So first about Koita Center for Digital Health. This is a new center at IIT Bombay, which has been started with generous donation from the Koitas. They have been alumni of IIT Bombay, and they are founders of CITIUS Tech, which is behind a lot of EMR software that they build. And the idea behind the Koita Center is to promote interdisciplinary work between technologists at IIT Bombay and healthcare providers, which may be big hospitals, it may be different chains, clinic chains or radiology lab chains, and they can also be other industry partners, including those that are in health insurance and so forth. So the idea is to bring all of them together so that we can do research, we can run academic programs to train the manpower that can work on health data in the future, in the very near future. And we are building programs on master's programs as well as PhD programs, and our undergraduates are taking minor in digital health to prepare themselves for these industries. So the digital healthcare partners that we have, what kind of things they what kind of organizations these are. These are hospitals and healthcare providers, health tech organizations, as well as government and NGOs that may be working in healthcare. So in a nutshell, anytime you're thinking about healthcare data, we would be the ones I would like you to think about to partner with when you're thinking about getting a research problem done or even translational research. Actually, there's a lot of emphasis on translational research at KCDH. So we are doing academics, research, and we are also working with policymakers as well as funding agencies. And these are some of the organizations that we have already partnered with, and I encourage everyone else to think about whether KCDH could be a good partner for you. So we have hospitals such as AIIMS, Tata Memorial, Narayan Health, and various companies such as Bajaj Health, ICICI Lombard, and so forth. We are also supporting the rollout of the Ayushman Digital Health Mission, which includes training the state level directors and supporting them with various policy initiatives and so forth. And this is a list of our advisory board members, and you can see they are, it's a very diverse group and people who have done well in health sciences and data analysis. Our key focus areas are healthcare applications, data management, etc. And these are some of the projects that are already underway with our digital healthcare providers. So in a nutshell, KCDH will provide the institutional support for multidisciplinary people to come together, for building tech, for rolling out tech, and for training the manpower to work in this exciting future. So now I will switch gears. I will talk about the work that I am involved with, which is developing AI solutions for medical images. And as you might know that it's not just about finding the data and training models and validating models. There's an entire life cycle that is associated with AI, right from need identification, data gathering, etc. And then of course going to deployment and often forgotten monitoring of how these models perform, so that if things change, if there are domain drifts, if the model doesn't perform as good going into the future because something underlying that is feeding the data has changed or the patient population has changed, we should be keeping track of that. So I'll give you some examples of how we are doing that. So the first initiative that I'll talk about outside of this, for this data and AI is the Cancer Image Biobank. So we've been very fortunate enough to have champions from Niti Aayog and Department of Biotechnology to give us a grant for building a large cancer image biobank. So how many of you have heard of TCGA, the Cancer Genome Atlas? So this group, probably almost all people would have heard of that. So that has it's mainly a genomics data archive, but it also has a rich repository of pathology and radiology images. So today, a lot of researchers who work on AI for medical images, they use TCGA data. But that's only data coming from US, only from a certain population of the planet. So there are needs for more diverse and different data sets, and perhaps India-centric or low and middle income countries specific data sets that cater to diseases and cancers that are more prevalent here. So that was the vision behind starting this Cancer Image Biobank, which is coming up at Tata Memorial. And it has collaborators from Rajiv Gandhi Cancer Institute and PGI Chandigarh and AIIMS. And IIT Bombay is supporting in rolling this out. So the idea is that we will collect longitudinal data for major cancers, starting with head and neck and lung cancer. So this will have, for a patient, anonymized data, including pathology, radiology, treatments given, and the outcomes till the first progression or death. So this will become a treasure trove for people who can define problems that they want to solve for diagnosis and prognosis. And we will expand this to other cancers after the first phase is over. So these are the kind of data that we'll be collecting. NACT, if you are giving NACT, then pre and post imaging. if we are giving any other kind of targeted therapy, pre and post imaging, and so forth. And some part of the work has already been done. It's running year and a half behind schedule due to COVID. But the kind of work that we have done is we have already built the digital annotation tools which are being rolled out inside Tata Memorial for the time being. Once they are stable enough, once the growing pains are over, then we will roll it out to other partner institutes and AI companies as well. So how are we trying to accelerate the annotation, which is a big pain point in working with medical images? So we're trying to think out of the box. This figure must look somewhat familiar to you. Instead of these pathology tiles that you see, it would be like crosswalks and traffic lights. So these are the recapture images that you see when you log into some websites, and the companies are getting you to annotate their data for their self-driving cars. Basically, they are authenticating you as well, but they are also getting you to annotate the data for them. So we are doing the same for our pathologists at Tata Memorial. So we try to make it not very annoying, so they don't see it for the next 4 hours if they have already logged in. But every fourth hour when they log in, they will see this little quiz that click the tiles that have this condition or that condition. And we sneak in, some of these answers we already know that what is the status of each tile. And that basically establishes the credibility of the doctor. And we sneak in couple of those where we don't know what the annotation should be. So when they annotate that with the authentication of the known tiles, and we get the annotation for the unknown tiles. The other thing, along with that, what we are working on with King's College London is crowdsourcing annotation. And when we do crowdsourcing, we give people enough instructions to spot the medical condition and so forth. And what we are finding is that if we put the minds of the crowd together, they do reasonably well. They may not do as good as a doctor, but they do reasonably well. And two people don't make the same mistakes. So we're building AI training techniques that will cancel their mistakes, and they will augment the annotations that the doctors do. Now, the real problems that we face when we are building AI beyond the research papers are, especially for medical images, the shortage of data, shortage of labels. The data is not perfect. There will be errors in the labels and the annotations because there's inter-physician discordance, even intra-physician discordance. And just the nature of medical images, diseases are on a continuum, but we are giving them discrete classes. So there are going to be some issues with that. And then unexpected data characteristics. What we say in India that a question was out of syllabus. So if you give an out of syllabus question to AI, how should AI respond? So here's an example of what we are working on with noisy labels. So if the labels themselves are not correct, then we are building techniques that will automatically see that these examples are hard, so they must be wrongly labeled, and they reduce their weight in training, which improves results and spots pathology patches. I work a lot with pathology images that are useful versus not useful. Then the next part is the cautious AI. So if you give out of syllabus question, how should AI recognize it and flag it? So we are changing the way AI is trained so that there are tighter clusters of each class that you are looking at. Anything that is not close to any cluster is going to be marked. So what are some examples? So let's say you give AI some images that have staining artifacts, or they are acquired from a different scanner on which it was not trained. So AI will be forced to give an answer, and that answer could be wrong. Instead, what it should say is that, whoa, I don't know, give the decision making to a human, or give the decision making to another more expensive test. I don't want to take a decision. So that's the ability that we are giving AI, and we recently put out a technique in JCO-CCI for that. And then we are trying to build techniques to recognize a lot of driver mutations just from inexpensive HND stained images. So here, in India, in resource-constrained settings, genomic tests for targeted therapies are quite expensive. So if you can recognize, at least do the screening using just HND stained images that are quite inexpensive, that would be a big boost. We got very good results for detecting BRAF mutation in thyroid. We're working with EGFR for lung and RAS for lung and a couple of other mutations for other cancers. And the whole idea is that finally what we'll do, this is my last slide, is that now all of these things, the institutional support, the data sets, the techniques, they are all coming together, that we plan to roll this out in this coming year. So hopefully when I come here next year, I'll have at least, I'll be able to describe the growing pains of deployment of some of these tests at our partner institutes in Tata Memorial and other places. So thank you very much.
Thank you, Professor Amit. That was great to hear from you. Being an academician, the kind of lens. I don't know how many of you realized when the camera was moving on, it looked like the microscopic image was moving out as to how the microscope view is happening. That was interesting to see. Our next speaker for the day is Professor Sweta Sneha from Kennesaw State University, Georgia. She has 2 decades of experience in managing digital consortium of digital transformations in healthcare. We would welcome Professor Sweta to do all that.
Thank you again for the opportunity. I have been part of this conference since, oh my God, since 2015, I think. I was also there at the Hyderabad Summit, and it's come a long way. Enjoy being part of it, and very much enjoy meeting the diversity of speakers that the conference brings in. So thanks, Dr. Ganpati, for bringing me back here again. I wanted to start with, sorry, is this working? Yeah. I wanted to start with really talking about an experience, a patient experience, and I'm really vested in that space because technology, of course, empowers that experience, but we'll miss the mark if we don't think of the people that we are here to serve. So I'll start with a story, and I have been in healthcare and technology for a little over 2 decades, and I date myself when I say that, but it's been an incredible journey. For the ones who are visiting from US, I don't know if you may have heard of the Hosey King case. And so this story really propelled my journey in the digital healthcare transformation. Sorry. Okay, I got this right now. So this was way back when the Institute of Medicine first came out with its report. And this was, don't know if you've heard of it, but it was the IOM first report, and it was called To Err is Human. And that was for the first time that we really saw the published data, that there were about 100,000 deaths that would happen in United States alone on preventable medication errors and preventable errors that would happen in medicine that would lead to adverse outcomes. A lot of them were fatal. So Hosey King case drove or changed my trajectory in healthcare, because before that I was happily living my consultant life with PricewaterhouseCoopers, was moving from one part of the country to the other, sometimes internationally. It was a ton of fun. I learned a lot. But this was in the early years, in 2000, when this 5-year-old girl gets admitted to Johns Hopkins for burn injuries. She was getting better. She moved from pediatric ICU to the regular ward. She was getting better. Her family was getting ready to get her back home with all kinds of pictures, with all kinds of posters. And the day before she was going to be released, she lost her battle at Johns Hopkins of dehydration. That couldn't have happened. Johns Hopkins is the best, absolutely the best in healthcare, global healthcare, really. And for a little girl to die in Johns Hopkins ward in pediatrics for dehydration just shouldn't have happened. Dehydration is a third world condition, so we keep hearing about it all the time. But should it happen at Johns Hopkins? Absolutely not. And it was not because the physicians and the clinicians woke up that day and said, this is going to be my goal for today, that I'm going to make it happen. So it was really a lapse in communication. It was really a lapse in workflows, in how data was transferred from one set of group to the other, how medications were managed. And since then, we have come a long way. So there is obviously technology that assists in clinical decision making. How do I move the slides? So I'm just like stuck on the first one. Okay, that one, okay. So I talk about the patient experience and the patient journey because really that's why we are here. We are vested in technology, and we do believe that technology is going to drive the healthcare of the future, because in all honesty, we don't have the human resources to support it. So in US alone, we see a mass exodus of nursing workforce. We see a mass exodus of clinicians, just because everybody has been stretched beyond their limits for the past 3 years, and it continues to happen that way. So technology is going to merge it all together. And again, we have come from talking about mHealth, we have come from talking about remote patient monitoring, and now we're entering the era of metaverses and augmented reality and virtual reality and mixed reality, and how that is going to impact healthcare. So these are some of the use cases in healthcare that we have seen and that we'll continue to build on. One of the things that, of course, that I'm really excited about, and since Microsoft was here, Cleveland Clinic and Case Western Reserve University, they partnered with Microsoft on this project called HoloLens. And that was designed to really propagate education and to really propagate collaboration among physicians in healthcare. So a lot of times when they're performing a surgery, they, of course, are looking into the patients. They have multiple data sets that they're looking at. There are multiple images. But what if we could bring everything together under that one lens that the physician is looking at? So they don't have to look away when they're doing a surgery or when they're doing any kind of procedure, that they can see the whole picture together with an augmented reality that they can interact with. That is phenomenal. And also it allows physicians across the universe really to come together in one room using a lot of the mixed reality and extended reality, and they can collaborate on serving the patient's needs and moving it forward. The other aspect is education, that of course I want to see how it will propel, because there are people all across the world who want to learn about the practices of medicine, the best practices, how to get involved with certain procedures. Now, we cannot always bring everybody on the same platform and on the same table together, but we can bring them together using a lot of the technology that supports the metaverse into one room virtually, where they will interact with each other as if they were together and consult with each other, be able to do surgical procedures, be able to talk about patients without them having to travel thousands of miles to get a consult. So my friend, Dr. Shafi Ahmed, he's actually associated with NHS. He was one of the first physicians to perform a surgery that was broadcasted all over the world using some of the augmented reality technology that we are talking about. How many of you have heard of the disparities in clinical research? So clinical research drives a lot of the pharma industry, drives a lot of the medications that hit the market. Well, it's been driven largely by what happens or what we found in the Western part of the world. And that's, again, not by design. A lot of that has to do with how we are recruiting people. We are running through the whole gamut of recruitment, to running the trials, to making sure that we're collecting the data. And a lot is lost during the process. So, sorry, is it me? I sit on the board for a clinical research or clinical trial company that is wanting to increase the diversity of the space. It's been supported by NSF, by NIH, And we are vested in bringing that to the Indian subcontinent, of course. And we're using a lot of the augmented reality to actually help with recruitment, to building that funnel and taking people in through the clinical trials, because it is important to increase the diversity of the people that go through clinical trials, because only then we can see the dream of evidence-based medicine coming to fruition, because the limited data that we have is going to be projected on the biases of the metaverse, because you may have heard of this terminology called the social determinants of health. And it's driven widely by the fact that the modern marvels of medicine, you can keep it on one table, and you can take the zip codes and where people live and the environment where they live in, and that will drive their healthcare more than all the modern marvels of medicine. So if we take that concept, and if the zip code that people live in is a better predictor of health than everything else, and if we take the data that supports it, and if we just project it on a metaverse, we will have a highly biased metaverse in healthcare that we are working with. So it is really important to increase the diversity of the information that flows into it, because we all know that the information that's building all of these technologies, whether it's predictive, whether it's diagnostic or treatment, it's going to be supported by the data that falls into it. How many of you have heard of this thing called opioid crisis, or mental and behavioral health anxieties, right? So opioid crisis is sweeping across the US in more ways than one. And despite of all of the bells and whistles that we have imposed on prescription of opioids, it still continues to drive it. Over the past 3 years, COVID really exposed the dirty underbelly of public health and health systems in more ways than one. And one of the things that really bubbled up was the mental health anxiety and the behavioral health problems that we have really been pushing under the rug for a very long time. And we just don't have the capacity or the luxury to keep doing it, because it's impacting our youth, it's impacting the children. There are virtual reality and augmented reality use cases that can help with managing mental health anxiety and help manage the opioids, help manage with pain. And it's important we look into it. It's important we invest into it and really take it forward, because we just cannot sustain this whole trajectory that we are on with managing pain and managing anxiety with more and more medications going forward. So I'm going to skip through some of the slides for brevity. We did talk about the ethical concerns, and it's important that we pause for a second before we move forward. Because, for instance, you can talk about the population health management all you want, but if the population that you're looking at and if the data that you're collecting with population is limited to a certain class of people, you're really not managing population with the most scientific tools, with the most advanced technology. You're trying to manage a class of people that are represented in that. I'm going to skip through some of these in the interest of time and talk about some of the trends that we're looking at into the next 5 to 10 years. The management of disability and elder care is really at the top, because if you look at the population, we are graying faster than we would want to actually acknowledge. Most of the Western Hemisphere has an aging population, so you may have heard of this phenomena called graying of the globe. That really represents that a lot of the Western Hemisphere is 60 and older. And with that, it comes with multiple challenges with chronic conditions, and metaverses are going to be useful in that. Blockchain, of course, helps with putting all the information together and integrating it in a way that it's immutable. And with that, I will take any questions, and thanks again.
We have 2 questions for the audience. Yes, please. Gentleman in the front.
Am I audible? Yes. Hi, my question is to Shika and obviously to the rest of the panel. See, when we are training the AI with the data sets, so I'll take your quote of obesity. If you're relying on only with one country and extrapolating to scaling up to other countries, it may not be reliable with the accurate data. So I pretty much agree with that. Having said that, so we do have anatomical differences in different countries. Like Indians are more prone to the chronic diseases or high cardiac diseases. So by generalizing to all the data sets, maybe AI may leads to hallucinating sometimes to the inferences, or else excluding these nuances of the clients or the patients or data sets may not lead to a proper solution also. So how do we handle this double-edged sword, if I can put it in that way? Thank you.
Yeah, so I'll attempt to answer that. So if you look at this obesity example, it's important for the model to recognize that while most of the people with high income are likely to indulge in unhealthy eating practices and maybe unhealthy fitness-related activities, it is not the high income that is leading to obesity. Now, if you work with limited data set, the model is likely to get biased towards that, because most data points wherein obesity is, say, 1 or yes, will have that as one of the features. And so model training, I would say, is just one of the activities. We need to really, as we train the models, we need to perform all sorts of exploratory analysis and see the feature and really look at feature importance that is being returned after you train the model. Is it making sense to your logical thinking? So most of the times what I've seen is that machine learning really surprises us as humans. So what we think initially as something that would enable an outcome, we get more insights with machine learning in addition to what we originally thought. But it's important to do all those activities post model training, and that will enable you to ascertain whether now you do have the right data set. But very good question. There has to be a balance.
So I have a slightly different take. So even after all the due diligence that has been done on the model, and we haven't made the mistake of correlation and causation, what I'll suggest is that we have to keep the entire life cycle of AI in mind. So monitoring is a big component of it, or should be a big component of it. Never trust the model to work as good as it did in certain conditions when you deploy it in a new condition. So there has to be a phase of monitoring, at least initial phase, before you hand it off completely to the model.
One more. Yes, ma'am.
Yeah, this is a question for the professor. I'm Sumit Ganguly from Princeton, New Jersey. I live there. The question is for your great initiative with the Courtier Center for Digital Health. Do you have some measurable results, and do you have a timeline within which you're trying to get those results?
So the measurable results on the academic side, it's clear that we have milestones that will start this program and this program. Some programs have already started. We recently started the PhD program. We are working on the master's program now. Now, on the research side, a lot of it is driven by faculty agendas of what they want to do research on, and our partner institutes' agendas. So each of those projects have their own milestones, they have their own deliverables. So for example, we are building a lot of diagnostic tech with Tata Memorial, and we are building a lot of the disease monitoring tech based on some funding we have from Bill and Melinda Gates Foundation and so forth. So they all have their own milestones, yes.
Go ahead, Dr. Sujoy. You had to ask questions.
So first of all, Shikha, Nitin, Amit, and Professor Sneha, thank you very much. One of the things, Nitin, you picked up in terms, and Shikha also spoke about, in terms of federated learning. And where are we moving, particularly, it will be very relevant in the next session, in consensus algorithms. when you see the model drifting, when you have data from particular ethnicity or geography, would you highlight how you would then put the computing and then how you would do or go about in building consensus algorithms?
I will take like the first step and Ashika after you. And that's an interesting question, Dr. Sujay. I think you put us, like, at least me on spot. Federated learning has recently been, what I should say, gained a lot of momentum. But I have still yet to see a very significant implementation or the successful implementation with a very quantitative metrics that yes, it is working. It is one way to actually turn around on some sort of a data privacy, that you're not sharing the data, rather you are just sharing the model weights. But again, the biggest challenge is the concept drift and as well as data drift. The idea behind it, identifying that drift itself, is very, very challenging. The approach till now for the data drift detection is very statistical based, that if these are the statistics that are getting changed, we are saying the data has been drifted. The question that comes up is the data has been drifted or the model has never seen that kind of a data in the past and the previous data was biased. So the federated learning, whenever we do that, we need actually to build some sort of a consensus algorithm, just like you mentioned, to add that sort of a metadata around the data itself to give the different kind of a weights, the kind of a weights that you will be uploading on the server for the larger model training. So those kind of an experimentations were going on. I attended like some of the sessions by Zomato itself. Zomato is doing some really interesting federated learning algorithm implementations on some of the data for delivery apps. Some things are happening on healthcare, but still it's very, very at very, very early stage.
Not much I can add to the beautiful answer given by my colleague. So yeah, I'll leave it at what he said.
Thank you so much. So with this, we are concluded this session. So I request Mr. Sumit Ganguly to please join us on stage for felicitation. Can we have huge round of applause for all the speakers? Louder one for them. Thank you. Token of respect, token of honor we are giving in the form of gifts. Well, ladies and gentlemen, we have few more sessions lined up, and once again, let me tell you all, today we're going to conduct quiz session over here just before the lunch. Thank you all the speakers for your time, your thoughts. Thank you. Okay, so let's move further. Now it's time for our next session, and the topic going to be implementation of AI in clinical practice, a global perspective. To conduct this session, I would like to call upon Chairman on stage, Dr. Shiv Kumar Jalepalli. Can we have huge round of applause, and let's welcome him all together. He is Chief of Cardiology and Clinical Lead, Cardiology AI, Apollo Hospitals, Hyderabad. A cheerful welcome to you, sir. You have very interesting dimples. Can we have a louder one for his dimple? He has 2 dimples. Wow. So, go for it.
Morning, everybody. I can say one thing is that if all those who are interested to see that how the healthcare is going to emerge in next 10 years, how it's going to practice, probably this next 1.5 hours will describe it. I personally feel that it will be a tectonic shift, the way the practitioners are practicing all across the globe and in our country. So probably, before I really go, I would like to see that, is any, other than Dr. Peter, Professor Peter, any other cardiologist is here? Oh, yeah, sorry, Kapil. I'm so sorry. Okay, so it will be interesting for all of you, because one word which I heard in the last 2 hours I'm sitting here is every second word probably repeated was a data. Okay, data, 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 data. And you like it or not, at least in perspective with the cardiology, I can say that we are the end users of whatever the big stuff, great stuff, you guys do it. Okay. In the same stage, I've been conducting a lot of cardiology conferences. We had more than 5,000 delegates. And when we talk about the probably data never features, data never comes. So one of the challenges which I sincerely feel, and probably that's the reason, I'm basically an intervention cardiologist. I've been doing interventions for the last 25, 30 years. I must have done more than 20,000 angioplasties. I don't want to boast myself, but yeah, primarily I was an intervention cardiologist. In the last couple of years, I have shifted and started doing probably a lead in AI in Apollo cardiology side. Basically, I'm leading the AI program of cardiology in Apollo. And the reasons is that I felt that all of you great guys, you do, especially I heard the professor saw that he's been associated with a lot of institutes. One of the challenges I feel is that the last mile connect is lacking in most of the innovations, the great innovations you people are doing it. So the reason what we did with an AI CVD, that artificial intelligence-based first cardiovascular disease risk score globally, which was done by Apollo with Microsoft. The primary aim was to use the last mile connect. But more challengingly, I feel that somehow we need to bring both the technologies, the engineering brains, and the medical fraternity, who are the end users, onto the same table. And at least we start talking in the language which is understandable to both of us. That would definitely change the scenario. That would definitely change the way the whole thing is practiced. So with this, today I can tell you that we have a wonderful session for the next 1.5 hours. There will be a video from the MIT, and of course Professor Peter from the Imperial College of London, Dr. Kapil, and many more interesting things, how cardiology is going around in the present scenario. So I have this privilege of doing the first lecture also in this session, so I'll go with my lecture. Can I have the slides, please? Okay, I have nothing to disclose. And I do agree that the medicine has been in the last thing to probably adopt AI into the clinical practice. But one thing I can say, the cardiology has been in the forefront as far as the adoption of the AI in the clinical practice is. So the different subsets where the cardiology is leading is, of course, the outcomes of the clinical outcomes in cardiovasculars, and now the AI is able to help us to see that, we have, like I can tell you, the heart attacks, there are different types of heart attacks are there. There are different regions of the heart which gets affected. And depending on that, whether he had an inferior MI or he had an anterior MI, we can tell what could be the prognosis of this patient and how long that patient is going to stay in the hospital, and what could be his overall outcomes. So that's how one of the best uses of AI in clinical outcomes. And yeah, this is the very interesting thing is non-invasive diagnosis of the coronary artery disease. And before I really see this, you can see that primarily, all of you, that we have to do an angiogram to see the coronary arteries, and which is an invasive procedure. Of course, we have a CT angio, but again, the CT angio is not as good as an invasive angio. But this, you can see the 4D photon, single photon, the CT, and see the clarity of it. It's beautiful, actually, though all those in cardiology can appreciate the coronary arteries are absolute. I'm sorry. Can I go back on this? Okay. The red one? Okay. Can you help me? So, oops, sorry. Okay. So that's the clarity of the coronary arteries, and the advantage of this is that now most of the invasive procedures will be avoided. So there will be a time very soon where the patient will be walking into a doctor's chamber with already the diagnosis made. Probably the diagnosis is in his phone or is on Apple Watch, and then where we can see the arteries and everything. This will be a really challenge for the cardiologist, because there will be a huge clinical information already with the patient, and patient will be well informed, and to give him the satisfactory replies, and he demands a lot of it from the doctor. So then the doctors will have really challenged. So this is the time that they need to adopt the AI into their clinical and day-to-day practice and see how the things are happening. So the reasons why the cardiologists are, I'm talking specifically cardiologists, I mean physicians as such, that why the AI or whatever the things are not being accepted into their routines. Because it's basically, I feel it's a cultural problem, because the way that we have been brought up, the way we have been taught, the way the whole medical fraternity grows and the way we discuss, that differs from the AI completely. So normally what we see is that traditionally statistics has been the standard method used in medical research to show the benefits of the new treatment and identify risk factors. Traditional medical research proposes a hypothesis. We generally propose a hypothesis, and then after that we try to put in equations to get the outcomes. And then usually we will always have a cause and effect relationship. That means these are the causes and this is an outcome. So that's how we are wired like. Now suddenly you get an AI into that and they say, oh, there is no cause at all, there is no reasoning, and still this is an outcome. So that becomes really difficult for the most of the medical fraternity to accept, but how come this has happened? So that is the reason that probably we need to train the doctors as well, that the AI works in a different fashion. So AI does not have to confine itself to the methods that are biologically observable, that is the humans. And similarly, it has been systems' ability to interpret data correctly, to learn from such data, use those learnings to achieve specific goals and tasks through flexible learning. So I'll just directly go, this is what it is. I feel the artificial intelligence, or I can call it as an assisted intelligence, and sometimes I call it as an augmented intelligence, because there are doctors are worried that artificial intelligence eventually may take over them. So basically we can call it anything. The genetics, which I was hearing it, that okay, yeah, genomes is a one again. So precision cardiology is the one thing which is coming up, and then I would definitely request all the technologists here is to help us out to get into a polygenic risk scores, and polygenic risk scores can help us to diagnose the diseases much earlier and much more precisely. And similarly, the different models and the IoT, the Internet of the Things, is again, which can help us in remotely managing the things, because that's very, very important. As I heard few speakers talking that, when we really need to manage and with the same facilities, the IoT probably would be a great help. So with this background, I would directly take 5 minutes to just see that how we have developed this artificial intelligence-based cardiovascular disease risk score at Apollo. And this is the first time that we could connect to the last mile connect, and we could do the end user benefit also. So how we started it, this is the reason basically why I shifted myself. So this is a real clinical situation where you can see the two subsets of the people, where a young guy and an elderly person. And this young guy has got all the things. He has got a blood pressure, he has got an immense stress, he keeps smoking, he doesn't do any physical activity, vis-a-vis the elderly gentleman who has got a blood pressure, diabetes, and atherosclerosis, but he does a walking and a holistic approach. Unfortunately, when we start putting these people into the existing risk scores which are already available, the risk score calculated for the young guy is very low compared to the elderly people. And the outcomes you can see, now what you can see in 5 years down the lane, the young guy usually gets a massive heart attack, and probably the elderly gentleman somehow he keeps on carrying on. So the sudden rise of young MIs, the sudden deaths, what you have seen, so many celebrities, so many the film personalities and other people have suddenly dropped dead despite being fitness freaks. So there I feel that there is a gap between what is being seen by the profession as a risk factors and what is actually happening. So there is definitely, something which has to be filled. The answers still many times we are not able to give it, because I do come across a teetotaler who had nothing, comes out with a triple vessel disease or comes out with a massive heart attack. So at that time, to tell the attenders what could be the reason, it becomes impossible for us. So I personally feel that there is a missing link between what the traditional risk factors we are looking at and probably what is causing it is there is a gap. So that's where the AI and probably the machine learning and other things has a role. So we started off with this 400,000 people, the retrospective data, and then we have iterated it, and then finally we had a group of cohort of some 32,000 people, and then out of this 32,000, 7,500 were the positives and 24,000 were the controls. And The reason why we came out with the risk score was the existing risk scores were available. We were not the first one to come with the risk scores, but the existing risk scores, when the randomized trials were done, they were not effective. The outcomes were not satisfactory. And again, as she said, most of the trials were done in Western countries, and they have been extrapolated on our population. So basically, we never had any risk score which was done on a South Asian population, this part of the continent. So these were the few things, and then more importantly, the feedback loop, that is, it was not a static study. And the risk factor selection process, again, whatever the risk scores were done, the risk factor selection was skewed or basically on a particular group basis, whereas we have taken the correlation coefficient value to select the risk factors. And the most important out of the whole thing is an accuracy. AUC scores where we had existing traditional risk scores are giving an AUC of 0.47 to 0.49, whereas the risk scores with this model, the AUC was between 0.85 to 0.89. So these were all the different things. We had a validation cohort differently. The different two centers of the Apollo hospitals participated. So first we validated internally between the Apollo group, and after that we subsequently took it out of Apollo, that is in the KGMC in Lucknow, and of course the AIMS also. And then once it was validated, after that we went internationally, where the MASTEC did the validation of the model. And finally, the overall, the AUC scores are somewhere between 0.83 to 0.87 to 0.89. The things after the reasonably good success of the AICVD, we are moving out with another two things. One is heart failure, because heart failure is another second most important cause of the mortality and morbidity in the country and globally also. So to identify the heart failures, that is an asymptomatic left ventricular dysfunctions, we call it heart failure is a left ventricular dysfunction. So how to identify those who have not been established is through an ECG. So we have an AI screening. We did develop a methodology where we are screening the ECG and coming out with an AI screening tool. And if AI screening tool is positive, so we can tell that those who are asymptomatic, when can they develop a heart failure in future, and what are their likelihood. So this is the one thing which we are coming out. It's in the process. Probably in few months we would be able to get more data on this. The third aspect, for the last 1 minute I would say take it, is that what we are coming out is as I said, the precision cardiology. In precision cardiology, because one size doesn't fit all. So today what happens is anybody who had a heart attack, anybody who had a heart failure, they all get the 4 or 5 battery of medication, same thing are given to every patient, and then we expect the same type of results, which is not true. So in precision cardiology, we are going to take the genomics, we are going to take the environment, and then of course the risk factors. With that, the whole outcome, so that it will be a tailor-made for in each and every person. So that's our the new thing. With this, I'll end my talk here. And before I really invite Professor Peter for his lecture on how it is being done in NHS, may I take just 5 minutes to run a video from MIT?
Good morning, everyone. My name is Ignacio Fuentes, and I'm the Executive Director of Good morning, everyone. My name is Ignacio Fuentes, and I'm the Executive Director of MIT Jamil Clinic here at MIT, the Massachusetts Institute of Technology. Our initiative works at the intersection of technology and healthcare life sciences, and it's based on 3 main pillars. One that is on the line of epidemiology. You may learn this branch of medicine, which deals with incidence, distribution, and possible control of diseases and other factors relating health. John Snow, Florence Nightingale, I may remember some of them, 200 years ago maybe. We've been doing some interesting work there on, during the pandemic. Another one that is on clinical AI, which is the one that brings us today here. And we're very happy about this new opportunity, although we've been working with Dr. Sujoy Kar now for a number of years to make this possible. And finally, the last one on drug discovery and molecular design. The reality is that on clinical AI, there's been advances on the technology, but we believe that initiatives like ours is what, and with the joint collaboration, is it what really will make an impact finally on reaching out patients and changing outcomes, right? We can imagine today AI in healthcare impacting different areas from nursing, pathology, robotic surgery, any database, clinical judgment, the drug discovery and drug design was saying, medical imaging analysis, which is most of the work we do, working on vision, managing health records, and all the online consultations since the pandemic that we've been all experiencing. But I believe what makes this opportunity unique is that this collaboration between Apollo Hospitals and the MIT Jamil Clinic is bringing those tools, the cutting-edge technology, to patients and their families. And this is something we are very proud, and we are very pleased with this new collaboration, with the opportunity to effectively deploy in clinical settings those tools. We started a few years ago with a tool called Mirai that is a predictive model on breast cancer, and not just allowing to detect a potential tumor, but also what is the likelihood of a patient to develop breast cancer. But also most recently, Civil, our most recent tool on lung cancer. As you know, this is also one of the big killers, and an early detection can have a significant change on the outcome of a patient, right? And we have on the pipeline other tools also that could be eventually implemented. But today I think it's more like to all be pleased about this collaboration being in place, Apollo Hospitals joining our hospital network and having the opportunity, as I said, to impact lives and patients. This is a journey. It takes some time to put those tools in place, models that need to be trained, not that has to be processed and cleaned and arranged. It's not just like an easy plug and play, but we know that with the joint efforts of the two organizations, we can really make a difference in health and in patients' lives. So again, thank you very much for this opportunity. Thank you very much, Dr. Sujoy Kar, for this, for your persistency over the years to make this possible. And I'm very much looking forward to this, to continue this collaboration. Thank you again, and have a great conference, you all. Thank you.
So thank you so much. And now I invite Professor Peter he's an electrophysiologist from Imperial College of London.
Thank you, Dr. Shiv Kumar. I'd also like to thank Dr. Sujoy, Professor Ganapathy, the Reddy family, and all of my colleagues at Apollo Hospitals, along with Darrell Arnold of Connected Life, for being here and being invited to this meeting, which is really extraordinary. It's wonderful to be back in India. I was here just 3 weeks ago on my honeymoon. It's now good to be here and contributing. So, the talk that I'm going to give is going to be addressing the title I've been given, that's Rollout in the UK of Clinical AI, where we have a few flowers blooming in a rather ancient meadow. I'm then going to drill down on a couple of quite granular use cases, one of which is a solution to an unmet need, which which addresses the broader context of my talk, one of which illustrates one of the challenges to conventional thinking about the introduction of AI, and then some strategies for change, because we clearly need to change what we're doing. We need to move from healthcare 1.0, and the UK context is a great illustration of how we need to do that, and the history and evolution of clinical care. And it's in this respect that I'm particularly excited and privileged to be working and collaborating with Apollo Hospitals, along with Connected Life and Fitbit, in evolving clinical care. And actually, evolution is as much about knowing what we need to give up as what we need to build. And giving up is a very important element, because we have some monoliths, in fact, several monoliths, a polylith of obstacles to get out of the way before we can really move forward. And I'm going to illustrate this with an example of AI in skin cancer diagnostic tools, of which there are several. And the text that I've put up here is from a release about this particular technology. And what I want to draw your attention to are the number of organizations involved in this press release. In just this 10 lines, there are as many organizations involved in the UK, all claiming responsibility for the action, but actually not necessarily facilitating this product and its development. And that is in part a problem. We have the Artificial Intelligence in Health and Care Award, Accelerated Access Collaborative, NHS England, NHS Improvement, NIHR, the Chelwest Innovation Programme, and digitalhealth.london. And these are monoliths, and they're as much obstructing each other as they are facilitating. And so, just to add to this mix, in the last 12 months, the MedTech funding mandate policy. This is one that actually mandates the use of technologies, selected technologies. And this document refers to the need for effective technologies with cost savings over 3 years and affordable to the NHS. And this initiative from this year's publication refers to last year's technologies, of which there were 4. And one of them, HeartFlow, includes an element of AI. And then makes reference to this year's selected technologies, of which there are 7, 4 of which are alternatives to transurethral resection of the prostate, so less invasive and presumably cost-saving, and 3 other technologies. This is not a transformative program. This is not transforming healthcare. This is focusing on small areas that, in the grand scheme of things, is not going to transform healthcare. Meanwhile, we have these statistics. We simply need to transform. And the NHS strategy is to supposedly innovate its way out of a crisis, better patient outcomes, are financially rewarded, and invest to save. Well, that's mum and apple pie. That's clearly the way forward. But how do we put that into action? And by the way, invest to save is a new concept in the NHS. It is only just realized that spending money to save down the line is the right thing to do. And so this is the latest. This is this week's missive that's come down to the NHS, supporting clinical leadership in virtual wards, a guide for integrated care systems, clinical leaders. So we heard in the first session this morning from the Chime group about reference to virtual wards, that the way to address the bed-based problem in the NHS is to extend the bed base into patients' homes. And we also have the opportunity, through using population health intelligence, personalised care and digital inclusion, to ensure that the outcome for patients reduce health inequalities and do not widen them. A virtual ward is a safe, efficient alternative to NHS-bedded care that is enabled by technology. This is a wish list putting this into action, as we have been now mandated to do, and there is between £0.5 and £1 billion being made available to this, is a credible initiative, but it is probably misdirected and the wrong place to start, and is going to be very, very difficult to implement, in part because of the behaviour change that this requires, and more of that later. And the unit of business in the current structure of the NHS are the 42 integrated care systems, integrating primary and secondary care, and this is the money that's been shared out between them. So a lot of money available, and I'm leading on 2 virtual ward initiatives at my hospital, and therefore have first-hand experience of the change in behaviour that really is something of a struggle in order to make these things happen. And so in a nutshell, we have the Department of Health that plans, the NHS that funds, and our integrated care system, the North West London integrated care system, that receives the money. And all this is steered by the National Institute for Health and Care Excellence, yet another monolithic organisation in there. But actually, this works quite well. And the National Institute for Health Research is a means of funding clinical work that can feed into NICE and can feed into this schema. So this is a fairly sensible summary of the way forward. And the NIHR research is something we have tapped into in respect of a particular technology, which I'm going to refer to. But let's think about healthcare in the more broad sense. This really is the spectrum, from healthy to dying sick. And of course, a sickness service healthcare system, which exists in insurance-based countries in the world, is highly monetizable. Sickness is a great way of generating dollars, in particular, US dollars, and so in the United States and other insurance-based healthcare systems, it really is a sickness service and monetizes sickness. But of course, healthcare, and increasingly we're hearing at this meeting that we should be focusing on the healthy end of the spectrum and maintaining health and detecting those that are becoming sick. And of course, this is where big data insight has the greatest value and benefit. And we've heard a lot this morning: public health, risk identifiers and management, N equals billions, and billions of individuals, but finding a way of personalizing healthcare and care plan delivery, and the time is now. So moving on from point-in-time detection and care to T equals now the whole time. So real time, real world, deriving new insights, clinical science, and transform direct care. And so left shifting along this spectrum towards the healthy end. And in terms of left shift, one of the technologies that I'm going to just focus on now in a granular sense, that is addressing a really big ticket item, is a point of care detection for heart failure that we've been working on at Imperial in London. The NHS has this diagnostic pathway in which only 10% of patients get through it to time and target. It requires a blood test, an NT-proBNP, the result of which then dictates onward referral into cardiology with a time ticking clock, and only 10% of patients get through that pathway. So the result is an unacceptable 80% of patients are admitted and their diagnosis is made with an emergency admission. They're sick, their outcomes are worse, and they become very expensive. So not surprisingly, the NHS long-term plan mandates improvement of this. And we've been using a point-of-care diagnostic, which is a stethoscope that is, has an ECG incorporated, and through cloud processing of the ECG signal using some technologies that were developed around AI ECG analysis. We have demonstrated a highly sensitive and importantly a highly specific tool which has left-shifted. It's left-shifted enough that this can become a screening tool, and it is a true example of AI transforming healthcare, and we're moving this now into primary and secondary care. I said that I would focus on a granular challenge and some work we've done around the ECG, using the humble ECG here to distinguish rhythm mechanisms, but here also looking at prediction of body mass index, visceral adiposity, and concurrent metabolic ill health. So the humble ECG, virtually unchanged since the 19th century, is having a whole new lease of life. And in order to drill down on its use, we used a convolutional neural network to detect arrhythmias, and we decided that we wanted to understand more about the subclassification of these arrhythmias. So we chose to look at features from a penultimate layer and look at the features, and to our surprise, we found that using an ELBA technique, that if we looked at the penultimate layer, we found 3 groups of clustered patients. And to our surprise, one of these groups has a 10% reduced mortality at 6 years. So a 10% increased mortality at 6 years, which is a completely unsurprising finding, is completely inexplicable at the moment, but at the very least generates hypotheses. So in respect of this schema then, bringing together, it's addressing these challenges and bringing together the strengths of AI. There is the exciting underpinning of the development and the collaborative work we're doing with Apollo hospitals, with the 24/7 use of connected life and Fitbit technologies to feed into the AI, the CVD AI program that Dr. Shiv Kumar referred to. True digital transformation of public health and optimizes value-based care. Kapil is going to be speaking about the use, the combination of the connected life and Fitbit, which we've been using at Imperial for a movement program looking at well-being in cardiovascular, diabetic and fatty liver diseases, the digitally enhanced rehabilitation in cardiac patients program that we'll hear more of later, which is funded and underpinned by NHS and the British Heart Foundation, and of course the Apollo wellness and risk tracking with AI incorporated, and the use of these technologies is an exciting collaborative development. So quickly then, let's put this all into context. Healthcare 1.0, and I'm going to scan this table in horizontally. So the strategy and the reality of Healthcare 1.0 is that we define populations by clinical syndromes, and we use largely 19th century tools in order to do that. The classification, therefore, is by blunt tools with subclassification by tests that we've developed, but these tests are anchored to the polyliths of the 19th century tools in medicine that we continue to practice today. Innovation is defined by these tracks of clinical science, refined by blunt tools and increasingly exclusive, and the inertia to innovation is the valley of death, that we are on these rails, we're on these tracks, and we're stuck with them, and we feel shackled to them. The target is sickness, unrefined populations, the tests are how we phenotype, and of course there's a lot of money in sickness care, so this targeting of sickness has an inertia to move away from that. And delivery is by periodic points in time, reactive, by classification of patients and treatments, and of course doctors knows best, is part of the inertia to delivery. What we need to transform to, in my final slide, is that we can learn from Healthcare 1.0. We learn that there are big wins. We know what they are. We need to innovate for the many, not the few. We need to focus on health, not sickness. And we need to deliver in a real-time, real-life fashion. And hence the excitement of working with Apollo, with Connected Life and Fitbit around delivery of real-time and real-life care. And so it's in conjunction with this collaboration that really Healthcare 2.0 has got to be built on initiatives like this. We've got to touch patients in their real lives. We've got to accept that connected technologies, consumer technologies, have an awful lot to bring to the table. And that is how we're going to democratize healthcare delivery and bring it into the 2.0 era. Thank you.
Thank you, Professor Peter. Moving on to the third one, actually the third speaker should have been here, but for some reason he couldn't travel. So he's Professor Alex from Singapore. He's the Director of Innovations from MOH Singapore and clinical AI rollout in Singapore. So can we have a video?
Hi everyone, Alex here. Greetings from Singapore. Unfortunately, I'm unable to be there with all of you today. However, I know all of you are having a successful and fruitful time in Delhi. Thank you, Apollo Hospitals and Dr. Sujoy for inviting me to give this short 5-minute talk, probably while you're having your coffee or your drinks or whatnot right now. I'll be giving you some pointers about implementing AI in clinical practice and some of the challenges that we face, not only in Singapore, but anywhere else in the world for anyone who is working in this AI space in healthcare. So improved diagnostic accuracy. AI algorithms can analyze large amounts of medical data, including medical images and electronic health records, to help support clinicians and nurses in making more accurate diagnoses. As we enter the age of ChatGPT, where AI is finally tangible to the masses, there's a renewed interest in this, and it'll be very interesting to see how generative AI handles sensitive patient data or medical information, right? Where generative and accuracy and validity would be real big key issues here. So very interesting to see this space. Personalized medicine would be the second piece I would like to highlight. AI algorithms can help predict patient outcomes, such as the likelihood of disease or the effectiveness of specific treatments based on individual patient characteristics. So in this space of personalized or precision medicine, we definitely will lean heavily on AI and ML to deliver this new era of medicine. Improve patient outcomes is always the ultimate goal, but I also need to highlight the point about how by supporting accurate diagnosis and personalized medicine, we also hope to reduce health disparities across all socioeconomic classes. And finally, one of the key and most important things that we are working on here ever since COVID, became a reality we saw burnout in nurses and clinicians alike, and healthcare workers in general, and the need to reduce workload for healthcare providers has never been more important. AI can definitely automate certain tasks such as data analysis or other kinds of administrative work, freeing up healthcare workers to focus more on complex patient-centered tasks. And finally, an important point that should not be missed out is patient engagement. The ability to empower patients to self-care, to self-engage, and improve their own health literacy cannot be understated. And smart AI tools will definitely be helpful in this setting. So I've already mentioned, just a few topical points about how implementing AI in clinical practice can bring many benefits. But some of the challenges here, first and foremost would be data privacy and security. One of the main challenges here is the need to protect patient data and privacy for obvious reasons, right? But more importantly is that you don't want to undo all your hard work as you are pushing the envelope and you're pushing, this area forward. One data breach can be devastating and set you back years in terms of data of regulation in this space by your ministries or your governments, right? Algorithm bias would be another. AI algorithms, as many of you will know, is only as good as the data that they are trained on. And there is a risk that algorithms may perpetuate certain biases in data. This can be, unfair. This can lead to unfair or inaccurate predictions, particularly in marginalized populations. Another challenge is ensuring that AI algorithms are clinically valid and relevant. So you need large amounts of high-quality data and a deep understanding of the clinical domain for whatever kind of AI algorithm that you're working on right now. I think this is a good opportunity for me to highlight, the spirit of collaboration that Apollo and Dr. Sujoy share. Really excited to be, to be able to work with you guys in the future with regards to multi-center, multi-geographical efforts and collaborations towards, further developing your AI tools with Apollo hospitals.
So I think Dr. Alex has rightly so echoed the feelings of most of the cardiology profession. I was hearing Nitin Agrawal, and then he was telling the data and then the ease of data flow and everything. Yeah, that's right. The ease of data flow is important, but the privacy and the security of it is one of the big challenges which comes into for all of us, and then it really makes us scary, how comfortable you are to share and to publish the whole thing. So I think those privacy issues of data would be one of the biggest blockers to get the cardiology professionals onto the table. So with that, we move on, and then the next speaker is going to be Dr. Kapil Parekh, who's a medical head and lead in Fitbit from Washington, D.C., and then he would be briefing how the Fitbit is helping with AI.
Thank you. And thanks. Sorry, is this on? Can you hear me? Yes. Okay, great. Yeah, thank you. Next slide, please. So real honor and privilege to be here, and really appreciate the invitation from Apollo and the organizers for doing all the hard work of setting this up. So thank you. So my disclosures, I'm a medical lead at Fitbit and Google. I've been at Google for about 8 years. That's my full-time job. I am an adjunct associate professor at Georgetown, where I teach a class. I'm also an adjunct at Yale, where I collaborate on research. I'm a cardiologist, so I work 1 day a week at the Washington, D.C. Veterans Affairs Medical Center, and I wrote a book called Searching for Health with Johns Hopkins Press. So why am I here, and what is Google doing in health? So as many of you know, Google is a consumer tech company, and it's a privilege and an honor to be invited to this setting and to work with folks like Apollo to enable work in health. And Google's goal is to be more helpful for everyone, and Google's goal in health is to be more helpful. And what that means is billions of healthier people. And we have this approach that we call the 3 C's. So we look at consumers, information and tools to meet people in their everyday journeys and help them with their health. Caregivers, and these can be clinicians, but also informal caregivers, doctors, nurses, even family members, and give them the data that they need to support patients in their journeys. And then finally the community, and we support a lot of public health measures to make this work possible. So we take an ecosystem approach to impacting health. We work all across the ecosystem, and really the key is partnership. And you know, as I mentioned, we're a consumer tech company, so partnering with key institutions across the ecosystem is incredibly important. So my relationship with Apollo actually goes back to 2016 when I was working on search, and we were not launching knowledge panels. And at that time, we collaborated with Apollo to verify the knowledge panels on search that you might see as a blue box. And we had launched them with Mayo Clinic in the US. I led that effort, and then worked with Apollo on this one. So it's a wonderful honor to be back here on this stage. In terms of other partnerships that I just wanted to highlight before I jump into the next one, I had a slide here with a tweet from Dr. Tedros, and unfortunately it got sort of lost in the transition, but it was lovely to see his little video at the beginning of this conference. And you know, we launched a collaboration. This is more on the public health side of the work, but Google, I was at Google Fit after search, and we launched a collaboration with the WHO. It was the first one that they'd ever done with a tech company, and we launched it around physical activity. And we put the WHO guidelines into the physical activity app that we had launched, which is Google Fit, and there was a lot of anxiety over this, but Dr. Tedros supported the work and in fact tweeted about it after the launch. And that initial relationship has blossomed over COVID, as so many things have, and we, search, YouTube, and other channels have been really important vehicles to translate and transmit the WHO message to billions of consumers around the world. So really proud of where our partnerships have taken us. So as we think of the promise of AI, you know, AI is built into all of Google's products, whether it's Fitbit, YouTube, Cloud, and so many more. And AI helps make these products more engaging, personalized, and simply it makes it better. And so with partners, our products can be leveraged for incredible health impact. And whether it's in cardiac disease or diabetes, healthier lifestyle, things like that, but also more interesting ways of using these products. There's a company that we partnered with recently that helps people with substance use disorder. And what they're using the Fitbits for is they've created a solution that checks heart rate, and if your heart rate is elevated at rest, they think maybe something's wrong, and they just ask, do you want to speak to somebody? And that's the message that pops up. Do you want to talk to someone? Because that may be the moment that they're withdrawing, and that's the moment of weakness where in the right moment, if you intervene, you can prevent relapse. So I want to start with a tangible example, because you know, you hear all these things, oh, AI is helping people with cancer and their chemotherapy and so on and so forth, and it sounds great, and I want to sort of make it real a little bit rather than these abstract things. So the tangible example is the one that Nick had referred to. So we, in cardiac rehabilitation in Ireland, right at the start of the pandemic, cardiologist Susan Connolly, who's fantastic, reached out to Fitbit saying, I need to make my cardiac rehab program virtual. I've never used virtual tools. Can you help me out? And so it started with Fitbit, and then we partnered with Connected Life. We built it, which is built on Google Cloud, and we built in some videos, et cetera, in exploring YouTube sort of integration there. And essentially, we virtualized the whole cardiac rehab program. And we published a paper that included this recently, and her analysis of outcomes after 1 year showed they were equivalent clinical outcomes as the face-to-face program. What was even more remarkable is that it expanded their reach. You know, patients couldn't always come in 3 times a week, and now they were able to come in. And what we've done with this is actually we've launched a randomized control trial called DEREC, which Nick referred to, Professor Peters, sorry. It's across 3 healthcare trusts, the Northumbria, Imperial, and Sheffield. And we're going to randomize patients to this virtual program or what we call conventional sort of cardiac rehab and see if there are differences and if we're able to achieve our goals, and that will be evaluated by the British Heart Foundation, and this is work that's funded by the NHS. So that's one example of how our tools come together to make this happen. So I want to go through some of the tools so you have a better sense of what the sandbox looks like. Now, how many people have heard of Fitbit for 10,000 steps? Anyone heard of 10,000 steps? Maybe? Yes? Okay. So Fitbit started off as 10,000 steps, and that's really what it became known for as a step tracker. And that's evolved a lot more since then. And so in addition to steps, Fitbit tracks active zone minutes, which ties closely with the WHO guidelines on physical activity. Tracks sleep, some of the best sleep tracking mechanisms because of the long battery life. Heart health, which includes an ECG right from your device, as well as detection of atrial fibrillation passively by looking for irregular heart rhythms, as well as mindfulness, a best-in-class EDA sensor that can passively detect stress, as well as health metrics. So sometimes people ask, like, well, these things, like engaging consumer tools, almost like toys, are they really useful in medicine or in health programs? And so, the randomized control trial is the gold standard of scientific investigation. This is a meta-analysis of 37 randomized control trials that looked at Fitbit. And if you incorporated a Fitbit in your program, you found that people had more activity, more weight loss, more steps per day. And so it basically made a difference by incorporating Fitbits into interventions. In terms of the heart health features that we've come out with, this is where advanced computing helps significantly. So we can take a single lead ECG straight from a smartwatch or some trackers, and then many of our devices track when you're asleep or when you're not moving. If your heart rate is irregular, they can alert you that you might be in atrial fibrillation, which is a dangerous heart rhythm that increases the risk of stroke. This is the Fitbit heart study that proved this feature in over 455,000 people. And this slide talks about the EDA sensor that I had mentioned. So in addition to Fitbit, we have YouTube. Over 2 billion viewers visit YouTube every month. And it is really where we have an opportunity to help people find reliable health information in ways that are meaningful to them. The challenges with paper are literacy, and you can replace that with videos and make it accessible, credible, and easy to understand. We also have cloud. One of my colleagues spoke to you about cloud earlier today, and the amazing ML and AI work that's happening in cloud. And cloud also has features that can help you connect with the Fitbit data. I mentioned the research. In addition to the meta-analysis, there's over 1,700 published studies on Fitbit. And these tools are not only for patients, but they can help providers with their well-being, and we have some data around that as well. Another theme that I've heard through the conference is health equity. We have a Google Health Equity Research Initiative that actually uses these tools to promote health equity in multiple ways. So where I wanted to end up with is we have these incredible tools all across Google, and working with partners, amazing partners like Apollo, we can do really cool things. So I leave this with the audience, take a look at what we have and think of how you can use them to change the world.
So the only disclosure that I have today and I have to apologize in advance, is that you're going to learn a lot more about me than you really wanted to. So I will be exposing some of my personal data for you to just understand how much I do or don't sleep, how sedentary I am or not, and how basically these kind of consumer wearable technologies is fundamentally motivating improvements in wellness and health behavior. I also have to apologize for the croaky voice because I was screaming for my sons during a rugby tournament this weekend, so I'm a little bit sore on the throat. So at Connected Life with Fitbit, we are absolutely fascinated by the sheer potential of consumer wearable technology, whether it's on your wrist or in your pocket, to be able to motivate and drive healthy behaviors. What's fascinating is that by leveraging such technologies, we can facilitate all-day monitoring. That monitoring helps us to understand the core pillars of around activity, nutrition, sleep, and stress, which can actually, if we can manage those effectively, can really support effective preventive health programs. With more data, and data that we capture in clinical settings, we can then start to develop personalized care programs, being able to predict our causes for concern, cardiovascular disease risk with respect to the work at Apollo hospitals, and our other wonderful clinical AI initiatives. Such personalized programs present a wellness score that is easy to understand for the individual. That wellness score breaks down what is positively and negatively driving the wellness and the health of the individual, and provides them with a care plan that, if they follow that care plan, will lead to improved outcomes. Of course, such data, given its accessibility 24/7, enables their care team to be constantly connected. And not just a single relationship with a primary care provider, but a broader audience of dietitians, fitness coaches, and of course specialists. And as we just go about our day, generating more and more data, as I constantly am doing right now, we're able to unlock that data for use in population health and to basically advance and drive government policy. So at Connected Life, the work that we've been doing is being able to provide consumer, easy to use, accessible, affordable, for the mass tools to be able to monitor and manage throughout the whole health continuum. Because we're able to leverage the cloud, our cost of distribution is very, very low, thereby driving down the cost and use. And working with clinicians and partners, we basically work around what is important to monitor from a compliance, from basically a wellness and clinical aspect, and drive and push those alerts at the right time according to pre-agreed protocols. At the core is the ability to facilitate an easy-to-use wellness assessment. So for example, visiting your primary care provider, the individual is encouraged to complete an assessment to the best of their ability via their smartphone. In the clinical setting, with their clinician, further health vitals can be collected, also consultation on some of their answers and queries, to then generate a care plan that can be edited on the spot based on certain contexts. And as you can see, one of my observations about coming to brilliant conferences and traveling like this is that unfortunately it drives down my wellness score because I spend a lot of time sedentary, whether it's sitting in the conference or on the plane. Unfortunately, I tend to snack a bit more than I should and occasionally drink a little bit too much alcohol. And so, I'm far healthier at home, and these contexts can be picked up with respect to management. The care team can be constantly monitoring and responding to alerts, and we can participate in holistic challenges that can be relevant and motivate positive changes in behavior. And we're getting really, really great feedback from basically patients and users throughout the world. And just one point of reference to share. Digital literacy is something that we need to be fully aware of. But if an individual is comfortable sending a WhatsApp message or basically taking a photograph on their smartphone, typically many of these digital tools are useful and applicable for them to use. So the applications are only limited by our own creativity. So whether it is continuity of care for high-risk surgeries, or being able to monitor those living with Parkinson's disease, or supporting a Healthy Mum, Healthy Baby program, the leveraging consumer wearable technology has a massive important role to play. And in Singapore, we're doing additional work to figure out basically how we can basically motivate primary care providers to play a greater role in preventive care. So with respect to the wonderful work by Dr. Sujoy and team, we've been working to basically integrate the clinical AI that's in development into our end-to-end platform for remote monitoring, diagnosis, and delivery of care. Critically, by being able to leverage basically continuous data that's coming from the wearable or the pocket, we're able to bring about a transformation from a point-in-time assessment to one that is continuous and dynamic in a remote home setting. So we can dynamically report back and feedback to the individual and their clinician that if they do follow and adopt that prescribed care plan, that they are reducing the risk of cardiovascular disease complications or liver fibrosis downstream. And this is something that is incredibly exciting, and we're just at the beginning of the journey. So on screen is the illustration of a widget as sitting in our platform, and I'm now going to do the most dangerous thing out and do a live demonstration of the technology. So is it possible, oh, I think it is, can we just go to the other screen, please? Of course, I just lost my mouse. Can you just help me 1 second? I'm not too worried about that, but can I just, I can't quite get my screen. I can't get. Just 1 sec. Sorry. No?
Yeah, you need to remove something.
Should we just unplug all this? Sorry, if it's not going to be possible, we won't do it. Okay, I think, can we show up on the screen? No. Okay, that's a real shame. Never mind. No? Okay, maybe what we'll do is we'll move to questions, and then if we can, we'll basically bring it up. Huh? Okay, No, let's move to questions. Let's move to questions.
Okay, so before he proceeds, can we go ahead with any questions open to the House? Please go ahead.
Hi everyone, this is Sahil. Hi everyone, this is Sahil from Pharmascroll. We are a analytics firm based out of Hyderabad. And I have a question for Daryl actually.
Sure.
So Daryl, we have been working with a lot of companies who are providing digital solutions and connected devices to the patients through various stakeholders. And one of the challenges we see in the industry is the adaptability of these devices. I mean, because there are a lot of challenges and related to adoption of these devices as well. How do you ensure that the connected devices are getting adopted by the patients, they're not facing any challenges, and how do you ensure the awareness of this to your particular patient base or to your community as well?
So the clinician plays a really, really important role in all of this. So by the clinician basically providing a clear understanding to the individual as to how using such an application can help the clinician better understand how they're progressing, and also then provide the information back to the individual. Then you see far greater compliance with the use of the application. That's very clear. If the clinician is not involved, you see basically a fall in compliance rates. The other thing that we recognize is by leveraging existing consumer technology, you know, the principle being is the individual already understands how to use such technology. So we're just on building on what's already clearly understood.
I think Daryl's underselling himself a little bit. Their platform is also available in multiple languages, including multiple languages in India. So there's also those considerations that they made cultural adaptations of including not only language but videos that are adapted, that are in local language by local people, etc. So I've particularly been impressed by the versatility of the program and what we've been able to do around patient engagement. We as a baseline, like Fitbit's key sort of value prop is engagement. We've sort of supercharged that around health, which is really exciting.
Hi, I have a question for Daryl and you together. I understand the platform is a rather horizontal platform which can be applied to different lifestyle disorders, as I can see. So the question that the HCPs constantly ask for is clinical outcomes, clinical trials around clinical outcomes in individual lifestyle disorder. Is that question applied to you as well?
Yeah, no, absolutely. So I just mentioned that we launched a randomized controlled trial with this platform in the UK with 3 hospitals, and the goal is to collect randomized controlled data on this. The pilot data that we have is around 600-700 people in Ireland, and they showed the outcomes were at least equivalent to regular cardiac rehab, but without the added burden of having to come in 3 times a week to a physical facility and have supervised exercise. We also had amazing patient satisfaction. There's actually a BBC interview of one of the patients who loved the program so much that he talked to the BBC about it, which was lovely to see. So, you know, between the anecdotal evidence of the engagement that we see with patients, the feedback that we get, the actual data where you see their cholesterol numbers get better, their readmission rates get better. The other thing is that this is presents an opportunity to do more than just virtualize a program. That's sort of the first step. The next layers that build on top of this are, for example, you can get signs that somebody needs a call because you see some changes in the data, and you can use AI to figure that out. And unlike, you know, medical data, where if I see a change in a patch that's medical grade and I call somebody, hey, you have ventricular tachycardia, this is what you need to do about it, come in and let's get it evaluated. This is consumer grade data. So if you see changes in resting heart rate, for example, and you call them up, it may be that they're having some medical issue and then you have to come in and evaluate them. It also may mean that they're hungover because they went out last night. Yeah. And so that's the difference, is that you can't make medical decisions with this data, and that's something we're very clear about. But what you can do is use it to evaluate people and then make a medical decision, because you can't evaluate everybody every day. But what I mentioned about reaching people at the moment that they need it, because you have a continuous on data stream, you can find moments like that.
Thank you.
Also just want to comment, so basically with all of our stakeholders that we work with, we typically run in parallel a clinical research collaboration as well as delivering the platform as a clinical service. And we get the consent from the users, or a percentage of the users, to make their data available for further research. So what that means is you've got a continuous learning and development cycle with respect to this and see the potential. Again, it's a collaborative relationship with the clinicians. So there's a generation of clinicians now that see the incredible potential, and it's been accelerated because of COVID, of leveraging such consumer-driven technology in the healthcare domain.
Just one other quick point on that, and I come as a clinical academic, but I would say that the randomized controlled trial is very important. But nonetheless, if we have a technology that increases activity, we know through the Healthcare 1.0 learnings that increased activity translates to better outcomes pretty well in any clinical setting. And the randomized controlled trial is important, but we don't need it to make that inference. And these technologies therefore can be introduced at a level before the 10-year randomized controlled trial that shows outcomes. And I would argue that may even not be needed.
The last question.
Trust the connected device person to do the connecting here. This is Sumit Ganguly, and first of all, the two presentations from the cardiologists, both of you, fascinating presentation. So my question to both of you, the applicability of AI in cardiology, is it mainstream, and are you seeing doctors adopt it? And are you seeing a whole host of mainstream technologies coming out to support you?
Okay, very nice question, because in relation to India, I can say that it is still in a very nascent stage. And that's another reason despite my, whatever may be my schedule, I keep jumping into all these conferences and meetings, because I individually, personally feel very strongly that the AI needs to be pushed with the cardiology profession, and it has to come into the mainstream because future is there. That's the future. I am personally convinced, and I know how the things are moving. But yes, I completely agree. That is the reason in my talk also I was saying the same thing, that we need a more interaction between the technologies and the medical professionals at a platform, at a stage where the more exchanges can be done in the language which is understandable to both the sides. Because I suffered it when Microsoft initially came. For initial 6 months, I was not able to understand what he is telling, and they were not able to understand what I am talking about. When eventually we understood each other, and then we took the model forward. So similarly, I think you're very right. That's the reason I feel a little pained also that, so much of things are done in the innovation side, in the technology side, but the last mile connect, or the usage into the mainstream, is still very far off, and then we really need more of a medical education to the technologists and technical education to the doctors as well.
And for my part, I mean, there are some examples. One of the technologies, the heart scan technology, which infers flow down coronary arteries from CT coronary angiography, is a transformative technology. There's some AI in that, but the point-of-care diagnostic, the smart stethoscope with the ECG. See, I'm a cardiologist. I'm a cardiac electrophysiologist. You could have sat me down in front of an ECG for 1,000,000 years, and I would not be able to determine whether that patient has good left ventricular function or not. AI has given insight there that is superhuman, truly superhuman. And in fact, 10 years ago, the statement that you could infer left ventricular function from an ECG would have been heretical. So this is truly new insight. It is truly superhuman. And this tool will find its way into mainstream. In fact, we're about to start a study with 200 GP practices, and other GP practices that are not among those 200 are biting our arm off to get a hold of this device and this technology, because it will transform care. It will allow screening for something for which only 50% of the population are diagnosed. It's becoming more common, and it's one of the big ticket items that we need to focus on in order to transform healthcare. It's no good focusing on widgets, creating widgets. The statement yesterday that what India needs to do is come up with a technology that the rest of the world uses in terms of a piece of hardware. I don't think that's transformative, nor do I think it speaks to the strengths, the immense strengths that exist in this country, and the work with Apollo hospitals exemplifies that.
So with
that's what happened. Sorry, as a cardiologist living in both worlds, the one thing I'll add to both of what you said is, I think it's important to incorporate these technologies in workflows. That's often overlooked. Like, the technology dazzles you, and then you forget the part where, like, you got to make it part of your workflow. You got to figure out the revenue cycle. You got to figure out all the other pieces of it, the regulatory framework. And we have examples of technology that has been integrated into workflows for decades. So every ECG that we see has a little reading on top of it. That's an automated reading. And it's not perfect. We all know that it's wrong some of the time. And we've all been to situations where, like, I see a OBGYN with a fluttering EKG, like, I don't know what this means, but this looks bad. But we figure out how to integrate that technology into our flows. We know which ones you can trust, which ones you don't, what you do with it, how you bill for it when we read ECGs, et cetera. All of that has been worked out, the regulations, that it's not, because it's facing doctors, it's not a patient that's interpreting it, it's okay. That's the same level of sophistications that's needed for the technology to go from there to becoming as ubiquitous as the ECG read. And those are the steps we need to take.
Thank you. With that, we come to the end of this session, and may I hand over to the organizers.
It's just
So with this, we are done with the session. And I request Mr. Angus Metcalfe to please join. All right, ladies and gentlemen, now we are all set for our very exciting quiz session lined up that's going to take place by Professor Ganpati. So be here. We have 10 smart watches to give away. Let's see who all going to be the lucky personalities today. So, well, before we start our quiz session, can we have huge round of applause for the man with distinct vision, Professor Ganpati? Let's have louder one, and let's have huge round of applause for all the speakers also. Stimulating presentation, I must say. Okay, so Professor Ganpati is going to take over now.
Good afternoon, everybody. I know I'm standing between you and a gastronomic delight, but in the next 1,500 seconds, I'm going to show to you, hopefully, that food for thought is as important as food for the stomach. Yesterday, we realized the very hard way when the first 10 questions were asked in this quiz program that intellectual repast is secondary to gastronomic delight. And of course, there were the few people who did participate were very excited, but most people preferred to have their lunch. So today we are trying to delay your lunch by just 20 minutes. And as you can see here, before I start, first of all, I must express my, sorry, this is too fast for me. Can I get back to the previous slide? Okay, Dr. Rohit Rao, Associate Vice President, who was instrumental in initially putting together a wonderful software program. We thought that the 472 delegates who had registered exclusively for the THIT conference, excluding volunteers and people in the store, exhibition, etc., we somehow thought that many of you at least would spend 45 to 50 seconds to download an app and join the program. We even made efforts to have virtual joining with Microsoft Teams, so anyone, anywhere in the world could have answered the question asked yesterday afternoon. To our surprise, we realized that behavioral modification is required even in a highly intellectual THIT, excited, passionate people who you think have already been converted. I realized that we need to convert the converted because only 6 people downloaded that app. Therefore, today, ladies and gentlemen, I hope you will use your NI. I know I'm competing with AI specialists. As you can see from my white hair, I belong to the BC era. I'm not talking of before Corona, I'm talking of before computers. I was the last neurosurgeon in this country who was trained before there were computers in hospitals or even a CT scan. I still think there is a place for NI. And why do I say that? Before that, Vinod Shekhar, manager, and Lakshmi, my secretary, all of them helped put together the fact. Of course, I take full accountability and responsibility for the contents of the quiz, the question, the answer, the references, etc., etc. I hope this will be a sort of teaching quiz. It's not really to find out how much one knows and how much one doesn't know. I mean, all of you belong to the Phi Beta Kappa Mensa Society. I'm sure none of your IQ is less than 130 or 140. Now, to start with, if you have NI, you will be sitting next to the microphone. The way this question, the housekeeping rules are, the first person, because software failed, I thought we'll use the fast finger, so the moment you press your icon on your smartphone, within 1/100th of a second, the number would have come to the screen. And we had so planned the software that the first 3 people would have been asked. I think it's very unfair that I'm being subjective. I'm not being objective. See, unless your face falls in my visual field. Now, for example, a person there may say, I know the answer. You may say, I know the answer. It happens where I'm looking at that particular point of time. That is why we wanted to remove subjectivity, but objectivity with sophisticated software failed disastrously yesterday. So today I hope things will be a little different. So I'm just giving you a clue, a hint. There are 5 or 6 floor mics on the floor. I'm told that there are 5 or 6 people moving around in the audience with a microphone as well. Can you just take this? Yeah, just switch it off. 5 or 6 people in the audience moving about with microphones. So you need to be alert. It's not a question of your repository of knowledge stored in your brain which you are able to recall. That is, yes, that is important. But equally important is how you become the first. So you need, I have a little hardness of hearing, a little fall in visual acuity, and obviously I should have guessed slight mental retardation, perhaps age-related changes if you want to call it. So all these 3 put together, you have to convince me that you are the first in this room to give the answer. So please shout me first and go to the nearest mic. Then only I will ask that person. Okay, so that's how the game starts. And what are you going to get out of it? Our previous speaker from Google showed you the importance of wearables. And I was absolutely surprised, I was shocked to understand that the first BIS certified health watch, the MRP says 9,999 rupees. So this is the price which you get. And unlike the usual prices, we are not giving a first prize, just a second prize and third prize. Everybody who gives the answer for each question will get a 9,999 worth wearable watch which will give you your blood pressure, oxygen saturation, etc., etc., etc. Now, ladies and gentlemen, as is the practice worldwide, the decision of the quizmaster is final. Now, people who have answered, who have already won watches yesterday, I don't think wearable technology is that sophisticated where a watch on the left hand and the watch on the right hand is going to give you different. So you are disqualified from getting a prize. You are of course welcome to compete. A person who already wins the first prize will not be given the second prize. In case there is a tie, as happened yesterday, see, I'm also a human being. So it's a pretty young girl who gives the answer and an old man like me who gives the answer, I would naturally choose the pretty young girl. So I don't want that to happen. So we'll toss a coin, heads or tails, and then you decide among yourselves who gets the prize. So these are the rules of the game. Now, next question. Next one, please. I think a fool with a tool is still a fool. I think that's a what. No, this is not. Question 11, please. I had specifically deleted this question. All this was, that's right, thank you. You can read for yourself, quick, quick, quick. The time starts now. Compared to 2021's total of 542, only 244 new unicorns were created globally. Name 2 in India in the area of diagnostic healthcare. I repeat, 2 unicorns from India in the area of diagnostic healthcare. Sir, please follow the rules. Yes, I happen to see you now, but you must get up, go to the mic and shout. Otherwise, I will not be able to see you. Use the mic. And please announce your name and where you come from.
Sumit Ganguly.
Yes, sir.
I'm coming from Princeton, New Jersey.
Yes, please.
And the 2 names, I think it's Dozy and ResMed.
Okay, anyway, okay. The rules of the game, the first person doesn't answer correctly, the second person will be given a chance. Second person doesn't answer correctly, the third person. If the third person doesn't answer, the quizmaster collects the prize. Second person, please. Obviously, you're not correct, sir, but thank you for attempting.
Molybio and Tata MG.
Sorry?
Tata 1mg.
I think someone else is destined to get the prize today. Yes, sir. Please announce yourself. Use a mic if you don't mind. Somebody give the mic.
Bharat Gera, I think the answer is Cure.ai, and why, sir?
Okay, the answer I give, as you see, is reference. I don't just like that pick up an answer. It has got references. If anybody is questioning me.
Sir, can I answer?
Oh, sorry. You were 2 seconds late. I've already put up the answer.
Oh.
The answer is Temasek, Molybio Diagnostics, and 1 milligram Tata Digital, valued at 1.6 and $1.25. I'm sorry, in my obviously mild mental
Sir, these two are the one I told. Molybio and one Tata 1mg.
You get the answer?
Yes.
Okay, fair enough. If you have already given the answer, ideally, I mean, if I am a theoretician, I would have cut the watch into 2 and given you, because you get, the question was to name 2 unicorns, so you answered half of it. So I cut it and give it, but I don't want to do that. You told both, is it? Oh, excellent. Excellent. I didn't hear that. Congratulations. Yeah, please hand over the prize. I'm sorry, in my, I just forgot that Mitra is here. Hey Mitra, you want to compete with all these brilliant people here? What do you think?
Hi, Quiz Master. I wish I could compete with all the obviously brilliant delegates seated here. Give me some more time. At the next conference, I guarantee none of you, including the Quiz Master, will have any chance competing with me.
So this is what the future is. I'm sure in the next conference, whoever is the Quiz Master then will find that none of you, all of you put together, probably will not be able to answer what Mitra answers. Am I right, young man? Thank you. Congratulations and apologies my hearing. Sorry. Thank you. Good. Excellent. Question number 12. It will either be the best thing that's ever happened to us, or it will be the worst thing. If we are not careful, it very well may be the last thing. This has got 3 components. Who said this? When? Where? And what does it refer to? So actually the complete answer is 4. Who said this? When? Where? And what does it refer to?
Elon Musk, and he was talking about AI.
Try again. Obviously you're a fan of Elon Musk, justified or not, I don't know. Next one, please. Keep trying, don't give up that easily. Elon Musk is the wrong answer. Yes, madam, please. Why don't you please give a mic or come to the mic, announce yourself. We would like to know which part of the world you're coming from.
I'm Mitali, I'm from Bangalore. It's Stephen Hawking, and I think he was talking about AI.
There are 4 questions. Who said this?
Yeah,
when, where, and what does it refer to?
Just the last, I know 2, that's all.
Okay, anybody else to help her? I mean, I'm being extremely fair. There are 4 components here. If anybody else is able to answer 2 components or 3 components, in all fairness, they get it. She has given you a clue.
Yes, sir. So I'll just help madam. So he said this in 2016 at a conference in Cambridge University at the Center of Future Intelligence.
At the?
Leverhulme Center of Future Intelligence.
Let's see the answer. Professor Stephen Hawking, absolutely right. During the New Space Exploration Initiative said it on April 12, 2016 in New York City. Now I leave it to the audience to decide who is to get the prize. Obviously both of them share the prize. So is it Stephen Hawking? Or do you think that Stephen Hawking was a clue to this lady, and this lady may not have thought about it unless she had been prompted with Stephen Hawking? Okay, let's be very fair. In case one of the prize questions are not answered by anybody, the Quizmaster's share will go to both of you. Can somebody please make a note of it? Please, somebody make a note of it, please, because I won't remember. So just give me a few more minutes. If nobody answers the subsequent questions, both of you will get one 9,999 watch alone. In case we don't have it, we will toss a coin, heads or tails, and whoever gets it, gets it.
Also, I wanted to say is what Madam said was a hint, so I'll be very gracious if you give her the prize. But your decision is final, as you said.
Now, this is where NI scores over AI. I challenge anybody who has built the most sophisticated AI system today, at least in 2023, not in my lifetime. Will you be able to empathize? Will you be able to sympathize with the patient? Will you be able to show this emotional gesture which he did in a fraction of a second? Will this guy be able to give up something? I don't think this guy will be able to give up something. This is the difference between NI and AI. It's sad that we are forgetting NI and we have started embracing AI at the expense of NI. Thank you, madam, for that wonderful gesture. I still think you will get a prize. I don't think everybody is going to answer all the questions I'm going to ask. Okay, question number 13. SNOMED CT consists of 3 primary components. What are they? See, you're going to get your prize, madam. SNOMED CT. I'm very disappointed. I thought 3 primary core components. What are they?
It is my guess. Diagnosis, procedures, and investigations.
Let's see the answer. Concepts, descriptions, and relationships. Oh, I'm so sorry, but I didn't see anybody else. I didn't see anybody else put up the hand, but before I projected the answer, I should have waited for a minute or more, but then I didn't see anybody doing it. I'm sorry, sir. This is the answer. I was trying my best to help you. At least one of the answers, if the word chosen was correct, but it's a good try. But SNOMED CT's basic components are concepts, descriptions, and relationship. So please make a note of it. This prize goes to the second lady. Somebody making a note of it? The lady who magnanimously gave it up. So this is what, the lesson for me here is magnanimity pays. You get rewarded for magnanimity. Don't look at ROI alone. ROI cannot be quantified in green bills. Here is a classic example of magnanimity paying. Next question, please. On 20th July 2022, fill in the blanks. The Dash announced criminal charges against 36 defendants in 13 districts across Dash for more than 960 crores INR in alleged fraudulent telemedicine, cardiovascular and cancer genetic testing and medical equipment schemes, abusing the healthcare system and exploiting telemedicine technologies in fraud and bribery. Unfortunately, I don't know enough of AI or machine learning or whatever you call it. I don't know enough to know whether the AI can teach itself and also commit fraud like this, which the NI is capable of doing. Come on, you're all experts, sir. I mean, I am an intruder. I am a neurosurgeon by training. Yes, please. Fill in the blanks. Please read the question again. You need to fill in the blanks correctly. There is no near answer. It's either correct or incorrect. The Dash announced criminal charges across the Dash. Yes, sir, go ahead.
Yes, sir. Dr. Sandeep from IIT Delhi. So I think the answer is the FDA and across the United States against Theranos Private
Again,
Limited.
what is the second component?
The Theranos Private Limited against Theranos.
Let's see the answer. United States, since nobody else put up that. See, this is the trouble. I told you from the very beginning, you must run to the nearest mic and say, I know, loud. See, because the lights are glaring in my eyes, I am not able to see anybody beyond the third or the fourth row. This is exactly why we did not want this. We wanted it to be absolutely objective. See, I'm not able to see people there. So, you need to run up to a mic. So that's why I said, look around you, come up to the nearest mic. Can somebody put mics, please? The floor stands, there are no mics there. No, please put some mics there. Okay. Okay. I think in all fairness, I think this question will be withdrawn for a prize because I am not able to see. The lights are glaring at my eye. Please come to the center, come to the mic. So I'm withdrawing this question from the prize category. The answer is the United States. Deliberately to mislead you, I put 960 crores. If I put US dollars, maybe somebody would have guessed it. So that is why I converted it to Indian rupees. And Department of Justice. So the answer is the Department of Justice filed this case in 13 districts across the United States. So you can see even telemedicine, this is happening. Yeah, okay. Okay. We'll interrupt this for a minute. Please come and collect your prizes before we forget. Stephen Hawking's admirer, madam, please come. That's wonderful. This is truly wonderful, absolutely wonderful, hand in hand. What more do you want? Absolutely wonderful. See, this is why EQ, emotional quotient, I think is far more important than your IQ. Thank you very much. Wonderful job. My wife is here. She's going to get angry taking a photograph of two pretty young girls here. Okay, doesn't matter. Thank you. Next one. Question 15. Telemedicine Practice Guidelines 2.0, released in May 2022 by the National Medical Commission. Mr. Bedi is excluded from this, but doesn't matter. If nobody else answers, you can also answer. Include several changes. Enumerate any two of them. That's all I want. Two changes in version 2.0. People here who are involved in telemedicine, practice of telehealth, should definitely know this. Please shout if you know the answer so that I don't miss anybody. Please come to the mic, sir. Raising your hand alone is not enough. Oh, that's a volunteer, sorry. I thought...
Sir. Sir, here, I know the answer.
Yeah, use them. Your name, please, where you come from, what you are, where you are, everything. Come.
I am Ananda Krishnan from Zoho, Chennai. National Medical Commission released the main of two changes is, one is the consent form, implied consent form. One is the implied consent form for the telemedicine. Another one is implied consent form, as well as another one is drugs also. Drugs also.
Sorry?
Drug prescription. Prescription also accepted, digital prescription also accepted for the patient. Because of the COVID, people also accepted for that in the May 2022.
Before I project the answer, anybody else? Please come to the mic.
The first one is consent.
Yes.
And the second one is like respect of the network. They can still do the consultations, either audio or video, whichever is convenient to the doctor and the patient.
The question is?
Next
changes, several changes. So you are telling me that what two you said were not there in 1.0? So please understand it is changes.
So, yeah, these are the changes.
Okay, fine. We'll note down your answer. Yes, please.
Hi, sir.
Yeah,
this is Dr. Mukul from Apollo Telehealth.
From Akash Healthcare.
Sorry, I'm not able to hear
Dr.
you,
Mukul from Apollo Telehealth. So the changes, one is that inclusion of Ayush practitioner in this release of, which is released in May 22. And second one, I'm forgotten.
Anybody else? Yes, please.
Hi, this is Nikhil Goyal. I'm from Max Healthcare. The two changes was, one, there was category of drugs, A, B, and C. Effectively, over-the-counter drugs were allowed as part of the, guidelines. But the telemedicine practitioners were supposed to mark the B and C categories, which was something which was kind of
I get your point.
Next. And the second thing was as part of video consultations, it was necessary to take a consent, and while taking a consent, the doctor and the patient has to come into a into a waiting room, like, into a virtual waiting room and do the consults, as part of which, like, they are supposed to, record
okay,
that
I get
session.
your point.
Yeah. So these were the 2 points.
Yeah.
Sir, first point is the consent one.
Please, mic closer, I can't hear.
First point is the consent one. And the second one is the delivery to, delivery was previously not allowed by the online platform to the person's door. So second one is the delivery door-to-door delivery.
Second one is what? I'm not clear.
Sir, delivery to the door point of the patient's. Online
delivery of? Online delivery of medicines.
Which was allowed.
This is a classical real world situation where a single judge will have to refer it to a constitutional bench of 9 judges. So I'm going to request all of you to decide which is the answer. The consent everybody says, so we are eliminating it. Yes, that's right. But it's a moot point whether I'm inclined to take one of them, but I don't want to be biased. Next answer, please. Let's go through the answers, and if you feel that I have made an error, please, I'm most this thing. Okay. Excluding RMP from practicing more than one system of medicine. Nobody mentioned that. Every self-employed RMP must digitize patient records within 3 years. Nobody came even near that. Third one, obtaining course certification within 3 years, which was what the Telemedicine Society of India spent a lot of effort and time. Unfortunately, as most of us think, this has been removed. These 3 points were definitely not mentioned. Fourth point, RMP to obtain patient signature or thumb impression with date on informed consent. Explicit consent recorded must be stored. I don't think anybody mentioned this. Consent was mentioned. Yes, okay. The fifth one, prescription of drugs to amended TPG permits. Yes, this was mentioned. Okay. So 4 and 5 have been mentioned. Question was any 2. So who are the people who mentioned 4 and 5, please? You and you. Same thing again. I think we have 1 watch extra, right? I think if I remember right, I did not, I removed 1 question. Am I right? Please be sure that I'm right. After all, you'll ask me to pay for the watch. I can't. Okay, then both of you get it. Please come. See, this is what the difference between AI and NI. NI gives you the option to take decisions on the spur of the moment. Now, my brain has been programmed in a totally different way. I'm not at all sure whether your AI will be able to take such decisions, taking into account every single variable. Congratulations. Thank you. Okay, next one, please. Prescription of drugs, amended TPG permits RMP to describe no, sir. I mean, I know you are the domain expert, but more drugs can be prescribed. More drugs can be prescribed under the amended than in the original one. That's what I mean. Okay, next. Dash will bring together. You read it for yourself. Higher bandwidth, ultra low latency, ultra reliability, enabling seamless. Just fill in the blank, 1 single blank. You are excluded, sir. I mean, you are too senior for that. And you got a prize yesterday. Not fairness.
Answers 5G.
Sir, I am already here.
No, he answered. No, this is what I said. You need to shout. You need to shout. Sir, I made it very
She's
clear.
already given. Sir, same situation.
No, I said you need to shout.
Sir, I have shouted and I have also received this. But I was telling and he just... He's the first.
I mean, he fell into my visual range and auditory range. You did not fall into either of the two. Okay, so I let the House Parliament decide it. Instead of the Speaker taking the decision, let Parliament take the decision. So whomsoever you say is fine with me. Sir, more hands are pointing towards the first row. It's not my decision, it's a parliamentary democracy.
Sir, I have a referee here.
No, for that we need objective evidence in the form of a graph, in the form of a visual, something.
Sir, your team.
This is subjective.
Sir, your team members, sir.
So we'll go by brute majority. All those who want the first person to be given the prize, raise your hands. Very simple, very simple, very simple. More abstention than, I'm sorry, sir. I'm sure you'll get it the next time. Yeah, prize, please. Next.
Please,
Question number 17. Okay, this is the answer. Since all of you are feeling very hungry, I'm not going into all the details, capacity, latency, and every single answer given here, there is scientific evidence of the answer. Congratulations, sir. Have a good day. Nice. Question number 17. Very, very easy. I'm looking at the back. I'm not. Okay, I'll be very fair. Instead of looking at the front, now I'm looking at the back. I'm looking at the back. Whoever is in the back.
Wearable device.
Sorry?
Wearable device.
Okay, anybody else? Anybody else?
Sir, AI.
Huh?
AI.
Okay, anybody else?
India.
What? India? What is it? India, okay. Internet, okay. Okay, yes please.
Sir, e-learning.
Sorry?
E-learning.
E-learning. Anybody else?
Smartphone.
Okay, anybody else? Telemedicine. Read the question carefully. Okay, I asked so many answers because even though the first answer was right, absolutely right. Next answer please. Answer please. Wearable healthcare devices. 533 million wearable devices were shipped in 2021 and an increase of 200 suppose expected to grow, etc. Okay. Next one. Sorry, who answered that? Yes.
Congratulations.
Sorry?
This is a type of AI only.
Sorry, that argument the judge totally rejects it. Not even considered for appeal. See, if I consider it for appeal, it will go to a higher court. Here it is rejected prima facie.
And even he was the one who answered first.
Sorry? I have a suggestion, sir. I don't want to dampen your enthusiasm. I feel very bad. Please come to the front row, sit in the front seat, please. Please come to the front.
Congratulations.
Okay, next, 18. What does in silico mean? I want a proper, detailed, correct explanation. Answer.
Yeah. Previously, the clinical trials were done on the patients or the animals. In silico means the clinic in the selecting any drug from a library and do it artificially without using any human beings or the animals.
Any other answer?
Sir,
you have partly answered it, not fully.
Sir, in vitro and in vivo were used when we were doing experiments in the past. In silico is when everything is done in the computer itself. So rather than a petri dish or something similar, it is done in computer.
It will be completely replacing the wet model and substitution by computational models.
Sorry, please don't answer unless you are requested to answer. See, otherwise there is utter confusion. That's why I have come down here.
Professor, he
put up his hand. Okay, please answer. Repeat.
So, in silico means we will be replacing completely the wet labs and substituting with computational methods, be it drug design or any modeling. So it will be completely computational based process.
Okay, last one. Only 3 are allowed as per the rules, but doesn't matter. 4th.
So all the biological experimentation.
No, only 3 are allowed, please. Otherwise, we'll be here till tomorrow morning.
So all the biological experimentation through computer simulation is performed.
Okay, not enough. Okay, answer please. The first person who mentioned among the answers is an individualized computer simulation used in development, etc., etc. You can see. So the main thing is.
No. It's a fun session, so I thought I should be a part of it.
No, I thought you were. Okay. Yeah, who said? I think you said that. Yeah, I think he said that. You did mention computers, you did mention not animals, etc., etc. The first person did say that. No more answers. Over. Only 3 answers are allowed.
I already answered. He want to say you like why I say the same what is written there.
No, who preceded you? Both of you said computer simulation, I agree. So who said first? Who? Please come. See, this is what makes life more exciting. Unless there is competition, unless there is difference of opinion. But the only thing is don't take a gun and shoot him. That's the only difference. So provided we don't do that. Next one, please. Next.
So with this, we got one more winner.
Okay.
Congratulations.
Yeah. What are digital pills? What are poly pills? Please try to be precise. I mean, a vague idea doesn't warrant a 9,999 rupee watch.
I will be speaking. So myself, Dr. Haraprasad, speaking from University of Delhi. Digital pills primarily represent digital therapeutic solutions, which are primarily AI-based solutions from the pharma industry. But they will not be chemical compounds. They will be working in the form of health apps, and there will be some kind of nudging technology happening.
You know what I remembered when I was in second year MBBS in 1970, I gave an answer somewhat like you. I mean, not these words. And you know what the tutor in physiology told me, Dr. Namaskwaim is no more. I remember so vividly, he said, Ganapati, ignorance clothed in attractive phraseology still remains ignorance. I mean, that's what he told me in 1970. For some reason, I recollected that. Let's see. Next, anybody gets near you or anyone else? Poly pills? Come on, these are all buzzwords used.
Team is suggesting.
Anybody else? Nobody else? Last last call, auction. Okay, answer please.
So we can see one hand raised up.
Somebody say something.
So multiple pills for her treatment.
Digital pills?
Multiple pills are, poly means like multiple pills are together to treat something.
Can you give me an example? You get the watch.
Poly stands for heart disease treatment. I'm not from medical background, but the poly stands. For heart treatments,
give me an example of what are the different ingredients which go up to make a poly pill. Roughly, I don't want the molecular structure.
I'm not from medical background.
Okay, yes sir. Last one.
Different
okay, one more. That's
so digital pills are something wherein you will prescribe the medicine and they are also monitored for their actions. Poly pills are something which we use as a combination
pill,
therapy.
According to you, is modified for action. So if I prescribe a pill for hypertension, it's a treatment for diabetes.
No. I said monitoring. I said monitoring, not modifying.
You said modified for treatment. Okay.
No, monitored treatment.
Okay.
A medicine prescribed and then that is also being monitored.
Monitored. Okay.
Yes, fine. That is digital. Poly pills are when you give medicines for like your heart disease and for your blood pressure and your cholesterol. Both of them
I get
together.
your point. Last answer. Last one.
Hi sir, this is Mani from Gorakhpur.
Why are none of you going up and shouting me first? You're all too timid, then don't blame me that I didn't see you. See, unfortunately, if I'm a frog, I would have had multiple eyes, I could have seen all over the place. But my visual field is restricted. Yeah.
Sir, polypills are, it contains low dose of medication and you must guide patient for prevention of those diseases.
Okay, thank you. I'm inclined, that's all please, 5 answers are over. Sorry, I'm inclined to answer with the gentle, handsome young man in the tie. I'm inclined to go with him. Let's project the answer. In 2015, most digital pill is for monitoring. That's a single most important word which he has used, monitoring. You can see the answers here. Polypill, of course, is a multi-layered pill. I wanted somebody to say personalized, somebody to use the word better compliance, adherence, etc., etc. It's obvious that most people are not familiar with it. I think we will give it to him unless somebody has a staunch objection. Next one, please. I think that's the last one. No, question. Okay, this is the last question. Expand the acronym DSHA. Now again, sorry, before I answer, there could be 40 different expansions of DSHA. 1 minute, you may say Delhi Industrial Society, something you may be right. But when I say DSHA here, it is relevant to an HCIT conference. Let me make that very clear. Yes, sir.
Yeah, I'm Srini from KIMS Health. It's Digital Information Security in Healthcare Act.
Any expansion? No, any further elaboration, comments on that? That's okay. I asked only for an explanation. Yes?
It's Digital Information Security Health Act.
Okay, he had already said that. Sorry. Okay, I mean, any novelty, anything new, we are all here to learn. Okay, last answer. Please remember, as per the prize rules, the first person to answer it gets the prize. Please, I am only asking the second and third person to see what are the different views. This is the last one, please.
Sir, direct initiative for social and health action.
Okay, answer please. No, that's all. 3 are over. 3 are over. Yes, please, unless you have a different answer. Yeah. Same answer, you don't get the prize, sir. What is this? First come, first serve.
First as well.
No, that's okay. Okay. So, draft the digital information security in healthcare. Was that the exact words you used? Yes. Yes, he gets it. Now, if only all of you or most of you had downloaded the software, 45 seconds to download, and then just touched your smartphone, your number would have popped up on the screen, and I would not have looked at any of you. I would have looked at the screen and asked you 1, 2, 3. It is very sad that we are not using technology which we are all preaching. But thank you very much. I'm sorry if I delayed your lunch, but I hope it was worth it.
Congratulations to all the winners, and can we have a huge round of applause for Professor Ganpati, who conducted session in a wonderful manner.
Sorry, apologies again, I forgot. Yesterday's prize winners, please come and collect it. We had originally told them we'll send it by email and all that, but it's easier to hand it over to them physically. If any of yesterday's prize winners are here, who is today's prize winners? You get a prize, is it? Oh, you are yesterday's prize winner. Hey, give me yesterday's prizes.
Sharp 2 p.m. So please don't get delayed. Okay, so let me take the name of winner for yesterday's session. Dr. Naveen, Dr. Nupur, Dr. Sahil Rathor, so Sherin, Mr. Vimal, very good handwriting. Dr. Sahil, Dr. Sherin, Miss Sherin. Absolutely. Let me take the names and you can step forward and take your gift.
All the winners, please sign that you have received.
Absolutely.
I don't want to face litigation in a court of law that I did not do what I did. Please sign that you received it. Now, digital signatures not accepted, physical signatures.
Mr. Vimal. Mr. Vimal? Okay, he already got it. Mr. Okay, Mr. Dipankar. Who's Mr. Dipankar? Yeah, he's the next one. Yesterday's winner, yeah. Dr. Baba. Dr. Alakapal. Congratulations, Dr. Sandeep Kumar. Dr. Raghu, MN. Dr. Raghu, MN. Yeah, Dr. Sandeep Kumar, congratulations. Dr. Raghu. Dr. Raghu, MN. What about Dr. Sandeep Kumar? Dr. Sandeep Kumar, is he here? Dr. Sandeep Kumar. So with this, we are done with our super fun quiz session that conducted by Professor Ganpati. Thank you so much, sir. And please don't get delayed for our session. We will sharp start our session at 2 p.m. So go have lunch and get back on time. Thank you.
afternoon, everybody. I know it's very difficult to get people after lunch, but I think it's equally wrong to keep the distinguished speakers waiting. So we'll start the next session, the first postprandial session, if you like to call it. This is adoption of technology in the last mile. And we are going to, actually this is a sort of, if you want to call it, inauguration, or this is to tell the audience what is actually being done, hopefully will be implemented. Hopefully at the next conference 2 years from now, we will see the results of the very hard work which I assume is going to be done in these 3 projects. It's my privilege to call Dr. Sujay Kar. I've been very closely interacting with Sujay Kar the last couple of weeks to put up this conference, and I must place on record the fantastic work he has done in getting together this distinguished set of people from all over the world. Thank you, Sujay. You took a big load off my shoulders, which I was doing for the last decade. Sujay is the Chief Medical Information Officer, Vice President, Apollo Hospitals Group. He heads the AI, clinical AI initiative, and over to him to specifically talk to us about the CIE, namely Clinical Intelligence Engine.
Thank you, Ganpati sir. If I can even be 1/10 of what you are, I would have done a great job. Can I start with the video, please? Chairman sir.
My dear doctors, we finally found a new way to say thank you to the nation. By dedicating our experience to all Indians, we found a way to protect it. Using all our resources to shape a secure tomorrow, we found a way to enhance India's healthcare. With superb technology, love, and care, I found a way to make India truly healthy. By integrating clinical intelligence with millions of patients' journey at Apollo, as I turn 90 and Apollo turns 40, I recognize and appreciate that as a doctor, you have been fighting from the front lines, doing what needs to be done to help your patients lead their healthy lives. When my team conceptualized the clinical intelligence engine, we knew we found a breakthrough that is set to revolutionize healthcare as we know it. An intuitive clinical digital assistant designed by doctors for doctors, built for accuracy, efficiency, and scale. Clinical intelligence engine has shown tangible improvement in care when used by our doctors at Apollo. Such powerful innovations, I feel, must not be limited to Apollo alone. We found a way to make this technology available for every Indian doctor at no charge, so there will be no limit to its boundless potential. We found a way and the perfect day to invite you. And I invite all my doctor colleagues to join me in my desire for every Indian family to have health and happiness. Yours truly, I am Dr. Pratap C. Reddy and everyone at Apollo Hospitals. I wish all of you best of health. God bless.
It's always a privilege to listen to Chairman sir and take his blessings on the work that we have been doing for almost now 2.5 years in building what we call as the clinical intelligent engine. Can I just go back to my slides? Yes. So what exactly is this? In the next 5 minutes, I'm just going to quickly run you through how we built it. So we started off looking at the data that is available at Apollo hospitals. In fact, we took about close to 2 million patient records from 2015 to 2019, and then went ahead with a stepwise method to actually see how we can parse the data and do what we call in natural language processing, entity recognition as the first step. So if you are actually looking at how chatbot or chat GPT has been built recently, there are 4 steps. And in the first step, and I think Shika covered it yesterday, the first step is looking at the entity recognition, where you identify different clinical, clinical entities or clinical words or keywords in the entire mass of 2 million records, which has close to about 1 billion data points. And then in the next step, you begin to actually look at what are the interrelation between each one of them, and we call it relation extraction. So these 2 steps are very common to large language models or even to the NLP work that we have done. The third is when you have done these 2 steps very nicely, you move into the third step, which is about how you ask questions to your model, and they provide you the answers. There are some work that we are doing onto this at this point of time, and we are going to refine it as we move on. Currently, the accuracy is about 87 to 90%, but we do have a headroom to go ahead and look at that. And the fourth one is when you have done all of this work, you now begin to then create clinical case summaries by using a technology called natural language generation, which helps in putting together all the clinical information in the correct perspective and giving you a narrative as if your brilliant junior medical staff had done this for you by looking at patient symptoms. This is what is Clinical Intelligent Engine. It has 2 phases. One, of course, is for the physician, where we are able to generate, given the patient's symptoms, a complete case study. And that's where we are integrating patients' health records, previous health records. That's where we are integrating his medication history. That's where we are also looking at triage, anatomical navigation. Nitin was there earlier today, who's working very closely with us in actually looking at the various different cues to bring it together and build it. What is there for the patients? For patients, we are building in the conversational AI. It already exists in our 24/7 platform, where they can put in their symptoms, go through a simple question answers that they will do with doctors, which gives them the differential diagnosis, also the recommendation of the lab test, which specialty to show, which doctors to show, and then give a case, case summary on that. The last bit of thing is that what we are working on is now anatomical navigation on that. Then the triage part, which is very, very important, and Nitin told you about the language, or in India we have different regional languages, if we could make it in that. So that's in a nutshell what you have in CIE, or Clinical Intelligent Engine, where you have everything from differential diagnosis to medication recommendation, lab imaging recommendation, case sheet generation, contextual clinical search if somebody wants to do it in that way. I will stop here now because I think I've run through it in the interest of time, and I have some wonderful speakers to follow me. I have one last video, and thank you very much for giving us this opportunity to showcase the work that we have been doing at Apollo Hospitals and Apollo 24/7. Thank you. The last video, please.
What could make a doctor's life easier?
Something that helps me keep pace with the latest innovations in my field.
Something that helps me save time on documentation.
Something that makes differential diagnosis faster.
Welcome to the era of CIE, a decision support tool built by doctors for doctors. Using 40 years of patient journeys from Apollo and real-time learnings from over 6 lakh medical journals led with AI, the CIE makes clinical processes more intuitive, efficient, and accurate than ever. Use this advanced tool to take patient history in real time, with each question linking to the last response in the right order. Get intelligently structured case summaries within seconds and arrive at a differential diagnosis in the shortest possible time. Get collated case reports, treatment modalities, and diagnostic recommendations, all in one place, built on millions of data sets and clinical knowledge base. The CIE is your window to the latest advancements in the field of medicines. So, are you ready to embrace the new? Explore the CIE, our chairman Dr. Reddy's and Apollo Group's gift to the nation, and trusted by 4,000 Indian doctors. Visit www.ciengine.com for more information.
The only point
What could make a
The only point that I would have missed is it currently has about 800 symptoms, about 1,200 conditions, and it's been validated by around 500 plus clinicians at Apollo hospitals. And then, of course, we do have a team of around 20 doctors and 50 engineers working on this project. Thank you. Thank you very much.
Thank you, Sujoy, for keeping up to time. Before I call the next speaker, I can't resist making an observation that as a doctor who practiced NI instead of AI, I believe that the doctors of the future who use AI will replace doctors who do not use AI. I don't know why the word artificial is used in AI. What is artificial about it? I honestly don't know. I think it should be assisted augmentative. If what you're using is assisted intelligence, augmenting your natural intelligence. And I believe that AI will never ever replace a human being, but doctors who do not use AI will soon be replaced by doctors who use AI. It's now my privilege to talk. It's a very intriguing title. I'm looking forward to hear. I don't know how you love an EMR. I'm absolutely no idea. You know, this says most loved EMR. So Mr. Rahul Vinod, who's Chief Architect and General Manager, Apollo Telehealth Hyderabad, will now tell us how to love a EMR.
Good afternoon, everyone. I think there was an interesting discussion yesterday about follow the money versus follow the need. I think EMR is something where there is both need and money. I understand Dr. Ganapathy saying how you do love EMR because of the history that EMR has presented over the last decade, not up to the mark of the requirements of the doctors or not up to the mark of requirement of the healthcare enterprises. EMR Studio is exactly solving that problem. We are trying to reimagine how EMR looks in the future. Next slide. So EMR Studio, we are a small team building the world's most loved EMR. Why world's most loved? Because we have the most prestigious doctors using this EMR, giving us inputs on how to build it, and most advanced partners in terms of technology who have collaborated together to build this. Let's, even before we get into the details of what EMR in detail is, let's just understand what's the current challenges of healthcare enterprise today are. We know that today there is no visibility for an enterprise when you are managing healthcare at scale in terms of data-driven decisions that cannot be taken. We are aware that patient walks in to a clinic or a care setting and then walks out, but we are in between that journey, wherever there is potential for revenue to be realized that is not being tapped in, and there is a high churn of patients, and at the same time, because of the technological limitations of adoption of EMR, doctors are also dissatisfied. Let's reimagine the same care journey. This is a sample care journey I have taken based on a clinic workflow, but we can go on about the same journeys, whether it is a home care, inpatient, etc. So what if when the patient walked in, he had seamless registration, like how ABDM solved with QR code based registration yesterday? What if the doctor had all the pre-work necessary, whether it is screening or the curated data, presented in a seamless format to him even before the patient walks in, like how Dr. Sujay has presented the clinical intelligence engine? And what if when the patient walks out, the system or the healthcare enterprise understands all the prescriptions or the orders that a doctor has written, and they have the context to actually request the patient or understand what the patient actually needs to get those services fulfilled then and there itself. And if in context of care continuum, if this system and the data visibility is available for a longer period of time, we automatically can understand if, take an example, if the patient has just been diagnosed with diabetes 2 years down the line, we probably know that he will either need a advanced consultation with an endocrinologist, or maybe he's probably starting insulin, and we know that he needs to be trained on how to take insulin, etc. So now with the data and the visibility across the workflow of the patient, across the care journey in an enterprise, the enterprise can actually have the context to speak to the patient rather than just speaking alone in a dismantled manner. So that's what EMR Studio is solving. One, we are not building it as a product, we are building it as a data platform, which essentially means we are plugging in every partner that we could speak to. We understand that startups move ahead with a much faster innovation pace than enterprises can today. So we are removing the barriers of integrations that were there yesterday in the legacy HIS systems or EMR systems, and we are trying to create an open ecosystem where EMR actually acts as a gateway to these startups and gateway to the healthcare innovators to plug into the doctors and the healthcare enterprises. We solve the challenges of workflow, managing care teams, calendars, scheduling and availability. We have multiple integrations with video calls, cloud telephony, etc., to manage communication channels between the physical world of patients walking into a clinic or virtual world, or even second opinions where doctor is talking to a doctor and not to patient. The case sheet engine that we have is extremely modular. Most of the EMRs that exist today, they solve one case sheet and they build the entire product out of that case sheet and sell it. Rather, we have taken a different approach. We have built a case sheet builder or a case sheet engine for you. Doctors can, based on their specialty, based on their needs, based on their care settings, can actually create and customize their own case sheets. As of today, we have more than 50 plus case sheets, and each case sheet actually has these components we call, which are building blocks of this case sheet. If you take a physical form of a case sheet and break it down into sections, those are called components, and we have more than 500 components as of today. Connected device ecosystem, whether it is a laboratory device that gets into a care setting or a high data frequency streaming patch medical device that gets connected to a patient, we have the capability to integrate those devices, get the data to the doctors, and actually reports at the end of the care journey. We create reports, and actually much more modernized reports than a normal prescription or a written PDF that doctor gives out. These reports are actually mobile responsive, and now we have, just yesterday we have tried to create a generative AI video where the prescription tries to explain itself to the patient, rather than patient have to take or consult someone else to understand what is written about it. So essentially what we are trying to give away is look at EMR as a platform, as a data platform for the enterprise, and not as a product that solves one single use case. We can build products on top of it which solves particular use cases, and the enterprise can actually build a lot of solutions with this platform. There is a famous saying in technology, if any product which is not which is not built on top of the platform can always be replaced with an equally competitive product that is built on top of a platform. So if you are a hospital or a healthcare provider looking for a data exchange platform or a platform to adopt all the innovations in healthcare enterprise to your care setting, EMR Studio is your place. I'll just skip through some of the slides. We have a very, very modern tech stack, modular, containerized. Compared to many of the existing HIS systems, this is extremely low cost. It scales down to zero when not in use. For example, if your doctors are not using the system in night, it costs zero. In mornings, it costs and scales up on demand instantly. Safe and secure by design, we are compliant with ISO standards, and we have also started our certification process with SOC2, and in process we'll also be procuring HIPAA and GDPR to go international soon. Yeah, so we have been part of several government projects which have which had huge impact in terms of scale and the impact that they create with the people. Whether it is programs like teleophthalmology or screening programs that we are going to have a talk about, it's all backed by the robust EMR studio that we have. Yeah, please reach out to me if you have any further queries. Thank you so much.
Thank you, Mr. Rahul, for keeping up to time. I personally feel that the single most important thing in the acceptability of an EMR. See, the EMR market is getting very crowded, and I foresee that in the next couple of years, EMR will be incorporated into the healthcare delivery system, both in the public and the private sector. It's always difficult to strive a balance between user acceptability. You need to get into the mind of the end user, the doctor, the physician assistant, the nurse who uses it, even if it means sacrificing a wee little bit for the very comprehensive, detailed number of descriptions. It's now my privilege to request Sri Ram Kumar, Additional Secretary, Ministry of Health and Family Welfare Department, Meghalaya, who is going to talk to us about digital dispensary and cancer care in Meghalaya. For those of you who have not been to Meghalaya, it's a most wonderful place, and I think it's really great that we are having somebody from there.
Thank you, Dr. Ganapathy, and thank you for having me here. Thank you for the entire Apollo team. So let me, without further ado, I'll go to the part of the presentation. As Dr. Ganapathy had mentioned, I am from Meghalaya. Do we have the presentation? The presentation first. So Meghalaya is a northeastern part of state in the northeastern part of this country, which has a population of 3.5 million. But the 3.5 million population are living in 7,000 localities or villages. So that is an extreme challenge for us in terms of service delivery. So that's something I'll touch upon. Yeah. Now, oh, sorry. Yeah. So in terms of digital intervention as government, who do we actually address to? This is the famous bottom of the pyramid theory of Mr. C.K. Prahalad, a famous economist, which was in discussion for a very long time, till early 2000s, I guess, and then suddenly went off grid. But somehow I still believe in that, and we can see that this bottom of the pyramid, there is a huge population which is the bottom of the pyramid, which are not able to access a lot of technology at Saints, because all the technology is built, operated, and revenue model generated for these first two sections, and not for this section. So our aim was, the principle what we work is that how do we bring technology closer to this section, and that's the important part we want to discuss, and I'll take you through that. So the pillars of digital intervention for Meghalaya will be like, in these four principles we work. One is the collaboration. Today we have collaborations with Apollo, with another partner called Grameen. We have multiple partners on the ground who are willing to take and address the problem of bringing solution to bottom of the pyramid. And research is very important for us. Integration, system integration is so important, because we have so many, as Dr. Ganapathy said, EMR is a very crowded market today, and the market is very crowded with EMR. Similarly, with all digital health applications, it's crowded. But we need to have a system integration, otherwise we don't build. So whatever comes through, we would like to have through a system integration, and innovation is fundamental to this use of digital health or digital or technology-based any interventions in health. And at the core of it is citizen empowerment. If none of this is going to result to this citizen empowerment, then we don't see a point of it. So that's the most important agenda as a government unit. That's where that's where our importance is there also. Now the principles which govern us are four, I would say four to five. The data or digital instinct should be empowering and not extractive. There is a huge hunger for health information. Multiple people in multiple roles want information on health. Yesterday someone mentioned there are 1,300 parameters in an ICU which you can take it. and everyone is interested because of building AI and everything on top of it. But we are into a matter where we would like to have an empowerment of our healthcare worker who is on the ground. It has to be empowering for the citizen also. It has to be utilitarian and not a photo op. Many times we do a lot of things in terms of experiment, but we are not exactly sure how to do a system integration and how it can be actually useful for those service providers as well as citizens on the ground. So it has to be utilitarian, and it has to be adaptive and not arrestive. Very, very important. The platforms which we build as much as possible, if it can be open source in government, that's a very important thing. And if it can be adaptive. For Meghalaya, an example, there are three important tribal languages in Meghalaya: Garo, Kasi and Jaintia. Now, the main features of whichever digital health and etc. comes are all in English. They're not in the local language. Adaptability becomes a problem. So we are designing things and working people who would like to design with that local language. These languages are spoken by not more than 7 to 10 lakh people. But in a country of such a big country, it's a very small number. But that is important for a state like Meghalaya because we have very, very concerning health indicators. Meghalaya tops the incidence of cancer in the entire country. For a small state, that's a pretty big, dubious place to be in. So, and next is convergence and not standalone applications. As and for, it goes again with a system integration pillar. This has to be possible to converge, and it has to be able to integrate rather than working on a standalone. The last is data openness. We believe complete in data openness. In fact, we are probably the only state in the country which has an open website called meghealth.in, where you can actually see, today you can just open and see yourself on how many pregnant mothers are there, where they are there, and how many are high risk, and etc. These data are even downloadable by an Excel sheet, and even for research. So we are actually promoting academic institutions and anyone else to go research and give us feedback so that we can actually improve. It's quite a good website, and many of you might be able to be interested. Now with Meghalaya, in terms of digital dispensaries, so the whole idea was 7,000 villages are there. How are we going to service them? To display only with government service is not a very, very wise option is what we thought. We thought we'll encourage partners to be with us. Apollo is one of the partners where we have the digital dispensaries. This is one of those digital dispensaries. We have digital dispensaries in real remote places where the closest highway is something like 1.5 hours away. The closest railway station is 3 hours away. And there are these places, but thanks to telehealth and COVID and a lot of adoption. And we have 5 under the Smart Village Movement initiative, where we take up in bringing initiatives of health, education, everything. Under that initiative, we have had these dispensaries in Meghalaya in 5 locations. We have 20 more from another organization called Grameen, who are also working in similar space for us. These are all paid services and not free services. But there is a huge thirst for primary healthcare. The bottom of the pyramid is where primary healthcare matters the most, and we don't have enough service providers for that. So my pitch here is that those who are interested, if you can focus on that, it's a huge market, but the focus is pretty not good. We generally have built a solution for top and try to adapt it for the bottom of the pyramid. It should be probably the other way around. And we have good consultations. People do come, and there's a lot of uptake for these centers in the rural areas, which shows the thirst for healthcare at the rural areas. And in the bottom of the pyramid, Meghalaya is even in the bottom of the pyramid in terms of accessibility and literacy rate. The next project is this first cancer care project, which is a very ambitious project which we are taking. As I said, Meghalaya, East Khasi Hills district, the capital district of the state, has extreme high incidences of cancer, particularly the oral, esophageal and throat cancers, where we are trying up with Apollo, and we have the World Economic Forum in terms of how do we screen the entire population of the susceptible population of 35 years above, screen them for 6 types of cancer, map the entire thing on a good oncology data model. And here is where Apollo system, Meghalaya's running systems, and the national level systems will all integrate into one another very smoothly, so that we can see the complete continuum of care. And that will enable people to be very aware, and we can avoid tertiary level care, and we can see to that people who require the care at the earliest stage. And we know that cancer, if you detected earlier, the chances are very, very high to have a good, healthy life. So that's what we are working on. This is a very ambitious project. I hope we'll be back here in a year or two to tell more about the level of the project, where we are on in terms of this is a case which might help for the entire world. And what are the other interventions we are doing? We have 4 key interventions, not more, in fact more than that. We have an app which tracks every single pregnant and lactating mother across the state. At any given point of time, we are tracking close to 40,000 pregnant mothers in Meghalaya alone, and their children also. We have a whole ECD helpline which talks to pregnant mother on counseling based on which stage of pregnancy they are. There is an ASHA pay. These are the ASHA, the rural health volunteers who work. Their payments are always a problem. They live in very remote areas and online interaction is difficult, but we have built an online offline mode of application where they can claim their incentives and it is paid on a weekly basis. We are the only state to do it. We have built a whole system only for this requirement. It's a particularly human-centric design which we have done. eSanjeevani is a robust consultation mechanism. Even in remote areas, we are trying to make it possible through technology adaptations. And positive public health management. This is a very, very important initiative under Smart Village movement again, where generally the data has to be empowering and not extractive. We build on that principle, where we are also giving a citizen face for every health interventions which we do in one app. So if the citizen has a smartphone, the family has a smartphone, they can actually see what's happening. They can have nudges to have better health practices, to avoid bad food practices, and etc. So that is something which we had worked on. It has given good results, and we are in the process of expanding to the entire state. Now, coming to the last point, drones are something, because it goes to the theme of the session. How do you address the last mile delivery? A lot of people have tried on drones across the world. It's not a thing which Meghalaya had tried, but many of them could not figure out how do we do the costing, how do you set it up, and what do you do. Meghalaya is probably the first in the entire, if not the country in the world possibly. We are not very keen about making tall claims, but we are keen about delivering results. So we did not do that, but this is where we had set up a drone station. It is a node from hub. From the hub, we have a lot of spokes where we can deliver medicines in real-time basis. It will carry bloods, it can carry back samples. It does, particularly where we have a lot of dispersed population, where a lot of population are living in rural areas which do not have access, or the health facilities do not have access. This comes as a big solution. So I will leave with the last video, and if there is something else we can talk later. So can we play the video?
Meghalaya is known for its beauty of its hills. In all its beauty, there are challenges. Accessibility is one of the biggest challenges that we face in Meghalaya, and because of poor accessibility, especially in rural areas, medical healthcare has become a big challenge.
Many of the areas are cut off during monsoons, for example. Many of the areas are hard to reach areas.
Karo hirsa banga songrangan ia semsang narsa sini de kawadi cidalodi gari manjani gaman sagabarangko ba ang naba manjaning aro vaksin rangko ba otnanik nekani rangko manaya.
Singa basak bade rama tongsa rangonar yange mungna gari dona gatan manja jok 4-wheeler omang ba singa dona gatan manja maina ramarang blungen rumela. Unigaman cha dona gatan manja imna basupre singa ja achi anga kilometer gani gatan takana kore singa ja achi ni anga mo singi vaksin rangko ra e singi thak nanga pas bostu rangko ra e.
These are things that are inevitable. These are some of the biggest challenges that we are facing as medical professionals, especially in the state of Meghalaya.
India has made incremental improvement in terms of using the technology for health. And Meghalaya has actually taken 2 steps ahead by introducing the innovations in health by using the drones for the supply of medicines and several essential drugs to hard to reach areas.
And this is very unique, not only for Meghalaya, but for entire region and as well as for the country, because this is the first time where an integrated drone hub has been established. There will be daily flights which will go and come, and this will be a small command and control center for these drones to go and come. And the payloads have been defined now, like vaccines, serums, antivenoms, basic essential medicines, blood samples, TB samples, and etc.
So this is a very special collaboration between Tech Eagle, MHSSP, and Government of Meghalaya. It is happening for the first time in Asia, where a proper hub has been built, and a day-to-day drone delivery will be happening for the supply chain of healthcare logistics.
So this hub and delivery network with the indigenized end-to-end drone delivery technology, including drone communication technology, is to basically uplift and transform the logistics of healthcare, which is in the remote, hilly terrain and rural area.
So in these hilly regions, to cover a distance of 30 to 35 kilometers, it takes around 4 hours or 5 hours. We are cutting it down to 40 minutes or 30 minutes. This is the kind of impact that we are creating.
Our vision doesn't end here. This is just the beginning, this is just the start, I feel. And we are looking at how we can scale this up, because this is a scalable model where we will be looking at how we can take this to the next level.
Right now we're carrying 3 kg payload for a range of around 100 km. Eventually this particular technology will be taken to the hundreds of kgs payload and ranges in 500 kilometers also down the line.
We are looking at this to be converted into a new mode of transportation, like railway station, bus station. There will be drone stations. This will be that kind of drone station. So that way it's very, very unique. Yeah. Thank you. We have done more than 100 flights now, 150, so thank you.
Thank you, Mr. Ramkumar. That was a very effective demonstration of how technology can make all the difference. I'm delighted that Meghalaya is slowly bridging the gap, and I'm sure that one day it will be one of the forward states of the country. We are absolutely running short of time, so I think we will, those who have some questions, burning questions to us, please contact the speakers directly. I'm sorry, sir, we have to proceed with the next session.
But before that, to present memento to all the speakers, I request speakers to please join us on stage, and I request Mr. Ashokan to please join us on stage to present mementos. All the speakers. And I must say, extremely interesting session. So let's have a huge round of applause for all the speakers. Thank you so much, Mr. Ashokan, for doing the honor. Thank you so much, all the speakers. Thank you. All right, ladies and gentlemen, now it's time for our last session of this day. So are we all ready for the last session? How's the energy? Okay, so before we conduct our last session of this day, do you want a relaxation session for 2 minutes? 5 minutes? No, I'm going to conduct something and you will definitely love it. May I go for it? Do you want a relaxation session? I need little more voice. There's a problem in my ear. Do you want relaxation session? Okay, so what you need to do is please stand up for a while, everybody. You will definitely like it. I'm telling you. Okay. Now what you need to do is, sir, you can also stand up. You will definitely love it. And after that, you will have more big smile. Okay, so everybody is looking in the front. So kindly take a turn on this side. Let's have a turn. Let's have a turn on this side. You can make small lines. Okay, so what you need to do is put your both hands on a person who is standing in front of you, on his shoulders, yeah, on his or her shoulder. Any idea what is going to happen now? Absolutely. The person who is absolutely correctly said. So what you need to do is 30-second shoulder massage and your time starts now. And I'm serious. And I'm really serious. Keep on doing it. Oh God, just look at everybody. They are saying no more session, please. This session, we are really liking it, enjoying it. Please keep on doing it. Keep on doing it. 30 seconds is not that done. Keep on doing it. Just look at everybody. So, are you enjoying the session? No? Okay. Now you will. Now what you need to do is turn on that side a person who has benefited you. Now it's your turn to give benefits to him or her. Come on, let's just go for it. Oh my God, just look at everybody. People are pro in massaging. Just look at man in a green sweater who is doing it in a very sober, beautiful manner with a very lovely smile. Okay, ladies and gentlemen, so with this we are done with our relaxation mode. So once again, let's have huge round of applause for yourself. Okay, so now I would like to call upon next chairperson here for the last session of this day. So I request Mr. Sumit Gangli, who is CEO GAVS Technology, Chennai. So can we have louder one, and let's welcome him one more time on stage.
Would you join me in thanking Resham Bhalla? For the last 2 days she's been emceeing this event. So would you join me in thanking her, please?
Thank you so much, sir. Thank you. Thank you.
The last session is a kaleidoscope. So we have a whole host of divergent views. So why don't I start with inviting the panel, Professor Sangeeta Desai. She's the professor and head department of pathology, Tata Memorial Hospital, Mumbai. Bagmishika Puhan, associate partner, TMT Law Practice, New Delhi. Dr. Sai Praveen Haranath, senior consultant, pulmonologist and critical care specialist, medical director, Apollo E-Axis Tele-ICU service. Naresh Purohit, director, systems engineering in India and SARC, Nutanix India, Gurgaon. Shobhanik Raut, general manager and regional head business solutions, Tata Communications Limited, New Delhi. And do we have Ganesh Subramaniam here? Ganesh Subramaniam, co-founder and VP R&D Engineering, Vios Medical, Bengaluru. So again, we're having a whole host of folks who are going to talk about various ideas and various plans that will directly impact healthcare practice in India and overseas. For me, I took the topic very seriously. It's the butterfly effect when unrelated events directly impact things in different parts of the world. Bronx, which is one of the underprivileged locations in America, was the epicenter of the COVID. And you had folks from Chennai who were based in Bronx for the last 10 years supporting COVID recovery through the ICU. If that's not a butterfly effect, pray what is? And that's who we are at GAVS Technologies and GS Lab. We work very closely with IIT Madras, and we've been doing a lot of work in the AI area. And over the last 2 days, some of the key things that we've been hearing about, social determinant of health, we're hearing about health inequity, we're hearing about AI, and we've been working in various areas trying to transcend healthcare from healthcare 1.0 that you were mentioning, Doctor, to a healthcare 3.0. The important part is that we have been involved in patient experience through digital front door. We've been working on reducing the social inequities in Detroit hospitals through the democratization of healthcare. And then finally, we've been working with community behavioral health, Jewish Board, and a whole host of behavioral health agencies using AI and technology to improve mental health. And again, in terms of talking about the kaleidoscope and the butterfly effect, at Bronx, we have been working for the last 11 years, leveraging our support center in Chennai as well in the US, and we've been able to reduce cost for Bronx Care Hospital by almost 40%. But what's very important is, in doing so, we've been able to directly contribute to their clinical management, because the cost saving in their non-core activities has directly impacted their clinical management. In the area of mental health, there is Jewish Board. Again, all of us consider that the Jewish population to be one of the most, the rich and affluent society. But you'll be surprised to know that in New York, they have a significantly amount of underprivileged Jewish population. And Jewish Board, Hebrew Homes, and a whole host of others have been supporting them. And we've been again working in New York and in Chennai and in Pune, supporting mental health using a whole host of AI. Premier Inc. is one of the largest procurement agencies in America. They work with 4,000 hospitals, and they do procurement worth $65 billion. And they have data of almost 40% of the American patient discharge system is available with Premier Inc. And we've been working in AI enabling a whole host of their hospital infection acquiring, or for that matter, the HCAP on acquired pneumonia and various others. So that's really what I wanted to cover, that folks from Pune, folks from Bangalore and Hyderabad have been working on AI and supporting companies like largest providers and peers in California, where they're trying to democratize healthcare through cloud computing. They've been working on AI, they've been working on infrastructure, and we're doing that along with IIT Madras. So without further ado now, why don't I go ahead and invite the next panel leader. So Bagmishika Puhan, would you join us, please? Is this the one? Yeah.
I'll use this. Easier for me to manage one. Hello, everyone. I know you guys have been hearing a lot about implementation of AI, or for that matter, technical solutions into the healthcare ecosystem. My talk would be focusing on how we should be able to navigate through the legal and the ethical constructions or constrictions that are actually placed. And what I'm going to do is, I'm not going to talk on the laws that are there per se, but I'm going to give you a brief glimpse into how you can manage creating a solution and treating it as an enabler. Prior to this session, Dr. Ganpati mentioned that there's a high likelihood that doctors who use AI will be the ones who are substituting doctors who wouldn't be using AI in future. Now, one of the key elements that he was trying to stress on there is that we have to look at adoption of technology more from the point of view at it being an enabler and not being a substitution. Now, with that, I will try to restrict my discussion for a lesser time period so that we can actually have more of interaction amongst us. So, okay. Now, first things first, it's a misnomer. I will not be talking only about AI. The implications that I'm going to discuss today will not be just relevant for the purposes of AI or machine learning. It will be scoping in every single element of usage of technology in the digital health ecosystem. If you see, one of the first things that I mentioned right there is how trust forms the paramount construct for a relationship to exist between a doctor and a patient. Now, because there is an element of fiduciary relationship that is created between these two stakeholders in the ecosystem, it is extremely essential that when you are relying on the data that's coming from the patient, has to be as accurate for you to be able to accurately diagnose
and be able to create a treatment plan for them. What is missing, when you look at this slide, there is also a discussion about how. Now I'll take you to the last point mentioned on this slide. What is being perceived? Here when I'm saying, I'm speaking also from the consumer side of things. So when I see that there is a doctor who is sitting on the other end and I'm not able to physically meet that person or greet that person, it creates a general perception in my head that probably what I'm getting is not exactly what I have signed up for. So there is always that feeling in the mind of the patients and consumers. Trust me when I say this, I am also coming from a professional service sector. So imagine you at least have to physically examine a patient to be able to diagnose them correctly. I do not need to meet my client to be able to understand their scenario appropriately. But there is still a perception that unless and until I meet my lawyer or my doctor or my teacher in person, I will not be able to gauge if what they are giving me in return is accurate, appropriate or not. Married to this issue is that, again, like I mentioned, married to the issue is that because there is a lack of physical presence, there is also the perception of vulnerability or unwanted exposure seeping into the minds of the patients. From whatever reason, I mean during COVID, if you saw for the telemedicine practice guidelines itself, the prominence or one of the prominent thing that was noticed by the National Medical Commission, the Board of Governors, was that because of incidence of people being restricted to their households was so high, there was an increase in the mental wellness issues related to that. So the first amendment that ever was made to the telemedicine practice guidelines was addition of 3 drugs which was urgently required by the Indian Psychiatrists Association, who then made a move before the government and it happened to be implemented. The reason I'm saying this is people were not comfortable because these were issues which my clients were bringing to me, that people were either not sure that should they be turning their video on, is the doctor recording it, or how is the doctor managing it, and for that matter, is the doctor sharing that information ahead or not. So because of all of this issue, people think there is more than what is expected of them or what is absolutely required is being collected or is being sought from them. Now, the third point here talks about, we have been hearing about how there are so many technologies. Now, the distinction here is that you guys are already rolling out these products, you are using them. So you would know that if a solution, you can see for yourself if there is, the solution is efficient or the efficacy has been tested or not. Imagine when I am on the other side, when people come to me, they're coming to me to understand if the flow that they are suggesting is appropriate or not. I am not then thinking then as lawyer. First I'm thinking as a patient, will I buy into this plan or not? Is this good for me as a user, as the final consumer of the product? So I'll give you a quick example. Most of you would be familiar with it. When IBM Watson was being discussed back in early in 2011 and 2016, when they reached out to so many people, the reliance that it was coming from an entity of that nature and the fact that there would have been sufficient trials and sufficient administration of real pilot projects done or proof of concept being carried out was so high that there was a perception that it will be sporadically adopted by everyone. But that has not been the case. If you, to this date, if you go onto the website, you will see the adoption is not what was projected. And this particular phrase is something I come across every single IT paper which discusses IBM Watson, where they're talking about how the promises which were made were much taller than what it actually was able to achieve or deliver. Now, this is where I face most of the issues in the adoption of technology. Yesterday, I was actually having a discussion with Dr. Sai Parveen here, and when he asked me a question that, when you're feeding in some information into ChatGPT, you get a response. How good is it? Or what could be the legal consequences of it? Now, one of the problems is that who feeds the information? Is it always a doctor who is feeding it? Is the technology service provider relying upon data which they have picked up from medical literature? What happens is, and this is a real time live examples that you guys will be able to, if you do a Google search of use of AI technology across multiple sectors, you will see that the most impacted sectors happen to be healthcare, the criminal reform system, and finance. Now, I'm not saying that, if there's a decision which is probably relied upon by a doctor which has germinated from an automated tool, cannot have apparent or physical implications. I mean, probably if it's a matter of, immediate treatment, then the results, if they are negative, they'll be apparent in nature. What strikes people most is that when there has been incorrect information fed into financial systems, the consequences are very immediate. Especially in the US, people have not been able to rent, people have not been able to take loans, and multiple, plethora of other issues. Imagine that's a consequence in a sector where you can immediately feel what is going to happen if there is an incorrect statement or there is an incorrect data set which is fed. However, when we are talking about aggregated data sets being created from public health records or from patients' health records, and then we are trying to accurately map a treatment plan or trying to reach at an appropriate diagnosis for the patient, that cannot always be the case. So because of these gaps and lacks, every time there is a discussion around how to use technology solutions within a health system, there is a mandatory requirement in every jurisdiction across all legal frameworks that the person who is feeding the information is not just feeding information from trusted sources, they are also ensuring that they communicate to the end user and take their consent. That's also something which was being discussed earlier in the first half of the day, that you take the patient's consent in trying to give them a solution which is going beyond you as a professional. The last aspect, which is something that I'm sure most of you will have a question, is that way back in 1980s, when a Canadian company started, launched a particular product for chemotherapies, oncology treatments, the Therac 25 case. It was so sad that there were people who died on the table while receiving chemotherapy, radiotherapy actually, because what happened was the data sets which were fed were supposed to be regulated by the attendant or the available technical staff there. But the technical staff did not know that what data sets are being fed and how is it managing between or differentiating between one patient to another. So there were at least 4 reported cases in very quick fraction of time across different locations where people were shot to death on the machine. And it was at a point of time where nobody knew how to regulate it, and it's actually one of the cases which has never been regulated and there has been no response received from it. It's only after that that US FDA has become as stringent as we see it today. So on this last bit, I will not want to discuss it here. I would rather have you guys ask me questions directly off the stage. But one thing here that we have to understand is, because there is involvement of so many individuals, one who is creating the hardware component, somebody who is developing the software, somebody else who is feeding the data, it becomes very difficult to ascribe liability. So even if the law will want to put one person responsible for it, it will not be appropriate for the law to do it.
Thank you.
So with that, I conclude my discussion. The rest of it is mostly to do with privacy. Again, those are specific questions that you might have, which would be typical to your ecosystem or to your product and solution. I'll be happy to discuss them offline if you have any questions like that.
Thank you so very much, Bhargava. And of course, you're going to talk about ethics as well. That's another huge aspect in terms of law and ethics here. So would you now join me in welcoming Professor Sangeeta Desai. She represents one of the most reputed institutions, Tata Memorial Hospital. She's the professor and head, Department of Pathology. Sure. The green one, ma'am.
Okay. So, wish all very good afternoon, and right in the beginning, let me thank Dr. Ganpati for making me part of this beautiful and action-packed conference. I'm going to speak on digital pathology.
Just press the green one.
I am pressing.
Okay.
Yeah. So let me first explain to you what a surgical pathologist does in a cancer hospital. So when the patient presents with a mass lesion or a tumor, the first thing is, which is done, first step is to obtain a biopsy, or if the surgeon is certain that the patient has the tumor, the surgeon resects the entire tumor. The entire specimen comes to Department of Pathology, where it undergoes several steps of processing, and the final product is the paraffin block or the glass slide, and this glass slide is viewed under the microscope, and then the pathologist decides what this tumor is, that's the diagnosis, how this tumor is going to behave, and whether it's going to respond to the treatment. So that is diagnosis, prognosis, and prediction. So this is our job in a cancer hospital, and believe me, no treatment progresses ahead without having this basic step of diagnosis. So these are the various steps, and I said about this in the previous slide. Even now I'm talking about these various processes because that has impact on the final product, that is the image. So the final product in conventional setting is the glass slide, which is viewed under the microscope. Now, when this microscope gets replaced by a digital scanner or whole slide imaging device, what we get is a virtual slide, and then when we see this virtual slide on the monitor, then the conventional surgical pathology gets replaced by digital pathology. So this is what this is digital. This is what it is. So it is use of computer technology to convert analog microscopic images into digital images. So once we have this virtual image with us, we can do variety. There are variety of applications. So these are basic modes, imaging modes. But in today's era, if I'm talking about digital pathology, I'm referring to whole slide imaging and not the first three modes, that is static, video, and robotic. So these are the various applications of digital pathology. The first set is clinical. So in today's era, whole slide imaging or digital pathology is being used for primary diagnosis, for computer-assisted diagnosis, so interpretation of various biomarkers. Many of the AI algorithms are already into clinical practice. For second opinion, because once there is a virtual slide available, we can send it across, we can transmit it, and the pathologist whom we are referring to can opine. Remote frozen section support, multidisciplinary tumor boards, which is a key factor in cancer management, quality assurance. Coming to research part, there are AI-based algorithms, standardization, development, validation. Dr. Amit Sethi has already talked about it in the morning. Then there are various quantitative image analysis tools, which are, some of them are already in clinical practice, some of them are still in the development. And the last part is education. So there is something called tele-education. Digital pathology is being used for external quality assurance schemes, for image libraries of rare entities. They can be maintained using digital pathology. Now, how we have been using digital pathology in Tata Memorial Hospital for primary diagnosis, for second opinion, for frozen section diagnosis, for multidisciplinary tumor boards, for external quality assurance scheme, for various meetings, education. In fact, education is the most important application of digital pathology. For various quantitative image analysis tools, which are actually, we are issuing reports based on these quantitative image analysis tools, and there are various AI algorithms which are in development. Coming to the last part, that is telepathology. We have been in this business since the year 1999 when we started with we started telepathology with first generation static telepathology system, which is now getting replaced by whole slide imaging. And we have published our work in various international peer-reviewed journals. So basically what we have done is we have demonstrated equivalence between conventional microscopic diagnosis and image-based diagnosis. So once this basic step is done, then you can do whatever you want to do with these images. The first application, the latest one in 2020, March 2020, what we did was when COVID pandemic struck, on 20th March we established remote reporting from home, and we were the first or the early adopters in the world to do this. We sat at home and rendered diagnosis, cancer diagnosis, And this we have published in Journal of Pathology Informatics. And what we did was we successfully established, validated this entire process of sitting at home and reporting in 567 cases with no major discordance and with very, very minimal minor discordance. So this was a very exhilarating experience we had. We have been routinely using it for multidisciplinary meetings, for various discussions. And now Tata Hospital is our Department of Atomic Energy. We are under Department of Atomic Energy, is coming up with various centers across the country. And we are in the process of linking all these centers. And in this process, last Saturday, we received a whole slide imaging device in our rural Punjab center. So the next step is having telepath link between the center in Sangrur and center in Mumbai. And on similar lines, there is something called National Cancer Grid, which is a consortium or conglomerate of cancer institutions across the country. And this is going to be a very ambitious kind of project, but we are making a small beginning by having a telepath link between our Punjab center and Mumbai center. Coming to Pathomix, Dr. Amit Sethi has made my job very easy. Pathomix is when you have a virtual slide, it has hundreds, thousands, and millions of data points, and you can analyze these data points and extract features and quantitate various features. And this is when the AI marries digital pathology, that is Pathomix. In fact, there are various applications of artificial intelligence in routine diagnostics and workflow enhancements. In fact, sometimes I wonder why A is artificial. It is most ideally assistive or augmentative for pathology. So pathologists, as routinely, we do a lot of repetitive tasks, like we screen for metastasis, we quantitate various biomarkers, we count mitosis. There are many quantitative tasks which we undertake. We grade the tumors, and we also have a lot of predictive biomarkers in cancer. And those are, many times, they are molecular technique based. Can we attempt to predict these markers looking at the virtual slide? This is kind of research applications. Some of these algorithms are already in practice. And the last is AI is also helping us with histological quality control tools. So most of it has been explained by Dr. Amit Sethi, so I won't take much time. Basically, there are 3 steps: identification, then segmentation, extraction of features, and development of algorithm. I am a medical doctor, so I won't be able to expand much on it. And we have done a lot of work on breast cancer, and basically for estrogen receptor positive breast cancer, which is node negative, there is a very exorbitant molecular test which is used to check whether that particular patient requires chemotherapy or not. And what we are doing, what we have done is we have devised an image-based risk score, and what we have found, it is adding to the, it is a value addition to the molecular test, which is very exorbitant. This particular manuscript is under review, and there are some other additional publications out of this work, and they have been presented and also published internationally. The latest project we are going to embark on is AI-enabled digital pathology platform for 3 cancers: breast cancer, prostate cancer, and head and neck cancer. It's again for diagnosis, prognosis, and prediction of therapeutic response. And so applications, when there are such applications, there are always challenges. There are pre-imaging factors. I have been talking about various steps which are involved in the processing of the tissue. So these steps impact interpretation of or standardization, validation of AI algorithms, image standards, file formats, because there are numerous digital scanners and they do not cross-talk with each other because of proprietary issues, and generalizability of algorithms, that the algorithm which is developed based on Caucasian population, can it be applied to Indian patients? So these are the issues associated with AI algorithms. Dr. Sethi has already talked about this, so the slides are almost same because he's our major collaborator. And so I request the researchers who are in this field to make use of this particular cancer imaging biobank, which is housed currently in Tata Memorial Center. And the bank has to mature, so it will be open to the researchers very soon. And it is going to, we are starting with head and neck cancer and lung cancer, and it is going to have various annotations. It's going to have subgroups pertaining to diagnosis, treatment pathways, as per the staging of cancer. So this is going to really facilitate research in a great way. So here I acknowledge my gurus and my colleagues, and thank you very much for patient hearing.
Thank you, Doctor. This was really fascinating. And David Sinclair is a professor from MIT and Harvard, and he's been talking about even digital commodes to kind of do some proactive prediction on terms of cancer from stool and commode at home. Yeah. So thank you again. Would you all join me in now welcoming Dr. Sai Praveen Haranath, Senior Consultant and Pulmonologist and Critical Care Specialist at Apollo.
Hi, good afternoon, everybody. Good evening. Thank you for staying back. I know the topic we have picked today is telemedicine in disaster settings, the sprint and the marathon. All of you are going to be facing a sprint and a marathon shortly. You're going to sprinting out of here to catch your flight and marathon lines at the security, but please stay for this talk. So I'm just going to talk today about what's been done in terms of telemedicine in disaster settings. As you know, telemedicine evolved several decades ago, both in India and around the world. And one of the biggest use cases was in emergency settings. Next slide, please. So one of the facts that we have to face, as we know in the ongoing Turkey disaster, is that it's a fact of life, and disasters are not going to go away. The number of people either injured, killed, or change their life completely is in the millions. And this is something we have to think about, because every time there's a disaster, it looks like we're scrambling. It looks like we're running to figure out what to do. COVID showed us that a disaster can impact us completely in every aspect of our lives, but we've forgotten COVID. Just think about it. Did you even think about COVID the last few days? All those lessons we learned seem to have disappeared. The reason I bring it up is that if you look at the PubMed article trend, just using these two terms, telemedicine disaster, it spiked in 2020, 2021 or so, and again it's dropped down and the number of articles are coming down. Our new friend, ChatGPT, so I asked him, write a note on telemedicine and disasters, and it gave me a 300+ word, extensive, accurate, readable, legible detail. So I kind of asked him again, what do you think about telemedicine disasters? And I gave it my topic, the sprint and the marathon, and it understood what I was asking. It actually said what I was going to speak about today. It talked about early deployment for patients and saving lives in the initial setting of a disaster. It also talked about the long-term requirement for the primary care needs that are going to come up. It even mentioned that people are going to forget their medicines, lose their medicines. They're going to need hypertension care in the future. This is a chatbot talking to me and telling me what I'm going to speak about, and it was accurate. So how can telemedicine help? The diagnosis, the treatment plan, immediate support. It can offload the work that the providers have to do on site. It can also help you in triaging, and it can also help you educate. There could be people, clearly when a hospital is collapsed, you're going to have people who are not healthcare providers who are trying to do healthcare things, and you can actually guide them on the job. There have been studies showing that if you had a patient in a hospital, you can train a nurse in 10 minutes how to use an ultrasound machine or an echo machine to get an accurate echocardiogram, and they've studied this in a randomized fashion. So really speaking, it is skill sets and data that matter, and you need to deliver expertise to places that don't have it. There have been studies in Santa Rosa in California when they had the giant fire there, and they looked at telemedicine utilization. Clearly, the telemedicine utilization went up afterwards. It decreased the number of people using their inpatient services right after the fire. Likewise, in Brazil, they had a similar situation where they used a device. They actually shipped a device which had a complete way to examine the patient to the site, and they were able to find out and help in complex diagnosis because these patients in that fire had cyanide poisoning, and it wasn't an area of expertise for the local team there, so they got second opinions right away, immediately. Anybody know what those numbers are? I'll give you 5 seconds. Somebody must know it. Raise your hands if you know it. Nope. Nope, nope, nope. Come on. What's my topic? Usain Bolt and the marathon, Kipchoge's. Those numbers. You need to know those numbers because it's important, and I'll tell you why. So what is a sprint, what is a marathon? A sprint clearly is you just start running. And by the way, they've done studies where 7,000 steps is enough. So if you're not clocking 10,000, don't worry. If you hit 7,000, you're actually good, and that's a JAMA study. So sprints need massive energy. You need massive input at the start. You need to kind of get all the stuff there in a short duration, and that's the kind of stuff that the military does, that disaster response teams do, which individuals might not be able to. At the same time, you do need to think about marathons where you have to support this entire population. Just think about Turkey, 34,000 dead, hospitals destroyed, health infrastructure gone, no medications, and in the next several weeks, there are going to be people who are out of hypertensive pills, out of diabetic pills, ending up in hypertensive emergencies with head bleeds, diabetic coma because they didn't get insulin. It's something which we don't think about, but we should be, because these are things you can plan for, because every year there are disasters of this scale. Who's that? Nobody knows? That's Kipchoge, the guy who ran 42 kilometers under 2 hours. And his quotation is, "No human is limited." And this is Usain Bolt, and he says, repeating is harder than anything else. And I think these are important things to think about, because if you want to achieve success in healthcare, you need to get it to everybody. And I believe digital health is the way to go forward. I was talking yesterday, fortunately, with Dr. Ilona, who had given a keynote address, and she said, public health is where you do small changes for large populations. And that is essentially what telemedicine can do. Telemedicine, not just in a disaster, but in any setting, can actually transform lives. There are rapid uses, and as I mentioned, we're forgetting COVID, but during COVID, we were using it in emergency settings. We were using it for helping complex resuscitation. I was doing consultations for patients who needed ECMO. We were actually able to get into other ICUs, and people opened doors there. All the credentialing, the licensing, all those rules fell apart because we realized unless humanity bands together, we're not going to solve this. But we forgot. All those barriers and walls are up again. What's the long-term use? Rehabilitation. You can help in remote cardiac rehab, as somebody shared earlier today, helping with non-communicable diseases, and of course, transitioning phase as health systems build up, even with education. Mental health, we've heard this repeatedly. There are multiple apps out there which do an excellent job, and it's important even without disasters. But think about the amount of post-traumatic stress that is going on right now. And what's that? I'm sure you've killed a few, right? Do you know that 800,000 people a year die because of this little guy here? And we haven't solved that problem. This is just a reminder that putting things in context, we're at a conference talking about health IT, about patient quality, but we haven't fixed this. So we need to figure out, how do you get the digital tools we have in our hands? How do we bake that cake with all the ingredients right at our hands' reach? The scope of the problem, let's take really quick. Patient, 63 years old, in Turkey, got rescued from the earthquake, fractured femur. They did the surgery in the operating emergency tent. And then she forgot her blood pressure pills. She has a headache. She passes out. She has a head bleed. What do you do? Then she gets an infection. How do you deal with it? You can. Surprisingly, you can. I'll tell you how. Now, there are multiple models of care delivery, and one of them is to remember that data should travel with the patient. Monitoring should travel with the patient. Doesn't matter where they're located. They could be at home, they could be on the ambulance, in the hospital, on rehab, but an emergency or critical care should be able to treat a patient anywhere, anytime, every time. And I believe technology can help with that. In COVID, at Apollo hospitals, we actually managed several thousand patients in remote sites using our command center, where we were able to do actually critical care as well as actually educating people in terms of upskilling them, and also with the help of the ATHS as well as the Apollo system of telemedicine, actually very quickly deploy paramedics to help. And that if you take COVID as a large disaster, we sprinted and put teams in sight, and then we had the marathon over a year of actually training and upskilling. What are the challenges to actually do this? These are the usual suspects. Most of it is cost, most of it is interest and support from hospital and other teams, and of course, there are some things such as the doctor there doesn't want it, and those are big factors you have to figure out how to fix. With Dr. Ganapathy here, who's a mentor to all of us, and whose prime quote is "Geography is history," which I keep quoting everywhere. We wrote an article about summarizing telemedicine to expand access to critical care around the world. And in disaster settings, nothing, I believe, can get deployed faster than a telemedicine setup. Let's see if this video plays. I think, let's see here. Okay. You can turn the volume down if you want. This is essentially a quick view of what we do in our command center. This is several years old. We've been doing this for a while. So we can look at patients, we can look at their x-rays, we look at their cardiac rhythm. In fact, we can actually zoom in and look at their pupils if you wanted to, and also look at ventilators. Now, ventilator care was a huge thing in COVID. It still remains in disaster settings too. And I can actually troubleshoot ventilators looking at the waveforms. AI is going to do my job very soon. These are areas which nobody has worked on yet in scale, but how hard is it for a machine to tell me what's going on just looking at numbers and waveforms? And that's also going to happen soon. And I show you this because this is a real-life example where we were able to deploy quickly, and now we continue to manage patients around India, and I also do it for the US, so we're actually able to manage patients that way. How do you scale this up? I call it the 5I paradigm, and that, I believe, is the intent that you need to want to do this. And what is your incentive? Are you getting paid for it? Are you improving quality of care? Are government supporting you? And then how do you incorporate innovation into this? And how do you actually make sure that there's no interference from factors that can derail what you want to do? And of course, finally, it depends on your institution who is supporting you. Ultimately, anything we do in health, at home, wherever, depends on what is the value of an interaction, what is the trust that has been built, and how can you bridge that barrier? What are the risks of doing something like this? And how can you develop faith to make sure that somebody wants to take your service? And in telemedicine, I believe that it is very simple. You're essentially helping patients. Some of you are healthcare providers here. Let's not forget, technology is only a tool, and a tool is just a tool. You're using it to deliver care. It doesn't matter that you're far away from a patient. And right now, every doctor in this room, I'm sure, gets messages from home, from other people asking, what should I do for this? What should I do for that? That's telemedicine. In a disaster setting, I believe this is a quick way to solve problems. And what can you do? I don't know who gave me my shoulder massage. It's still hurting. It's still here? Okay. But you can exercise. Obviously, exercise is important. I bring this up here in many venues because sitting is horrible, standing is good, and most of us are healthcare providers responsible for thousands of people, so we need to stay healthy. So exercise, that could be your biggest take-home message from this conference. But do consider telemedicine as an option for care. And what is that option? You want to support access and equity of global health. You want to encourage capacity building, because as we saw in the exceptional example from Meghalaya, everything fell in place. They did an amazing job of making sure patients got medicines and have drones delivering things. And of course, you need to also make sure there's collaboration so that you have the collaborations now and not in a rush when you're running in a disaster. You start talking to people and have those networks built so you can reach out to them when the need comes. And of course, use it for the marathon that is preventive health, and use it for the sprint that is critical in emergency care. And I love to close with this, where it's important to remember that you should never stop learning, because life never stops teaching. And again, I appreciate the opportunity to come here and give this brief lecture. And if you can do something for Turkey, please do it. Thank you.
Thank you. Thank you. Your presentation, Doctor, and Dr. Sangeeta Desai, fantastic presentation. And I think sitting is the new smoking. So we could even stand up while listening. So could we now have Naresh Purohit, who's the Director of Systems Engineering, India, Nutanix, India. That was very nice presentation.
So good afternoon. I was expecting this response. So good afternoon. Thank you. Because when the chairperson said that 2 presentation has gone really well, I started shivering. And I took the deep breath and I said, no problem, let me do my best. Yeah. So guys, I know all of dignitaries are here from paramedical, doctors, and from my bottom of my heart, I thank each one of you for saving our life in COVID, and you do your best. This is small gratitude from my side that if doctors were not there, probably I could not be alive here. Thank you very much. But now it comes to my job. I make job of my doctor easy. So you require data, right? If data is traveling with the marathon, will it solve the purpose? It has to be sprint, right? Because if you're processing a data which is sitting a patient next to you and you want to process each and every data of his medical history, it cannot be marathon based. I'm sorry. I'm used to of that clip mic. I'm extremely sorry. No, it's okay. I'll try to be. So it's my unconscious mind brings it back here. Sorry for this. So what I was saying is the data and the image, it has to be processed with the lightning fast, right? So I'm presenting a company here which helps in terms of processing this data with the lightning speed. So who are our, associates? So if you see these logos, these are worldwide logos where we are associated and we are helping them in terms of having data being reaching to doctors and paramedical staff the fastest possible way. Not only data, the image, okay? And these are some India, customers where we are working with them in terms of solving the business problem which they are trying to give the world-class patient services, recovery services, telemedicine services, and mobile services. So all these services which they are trying to achieve in terms of in their domain to be the best, we are helping them building it up. So what we do? The two key domain, one is on HIS, PACS, and VNA. So because there are humongous amount of the images which is being lying in the hospital, how we can fetch that? So if we can put it into the right archives, and one of my colleagues speaker was talking about the law in terms of keeping the patient data protected, how we can do that. So what we do, we have the partnership with all these OEMs where we ensures that any of your image and the data which is being kept in your hospital or in any of the cloud for your AI has to be HIPAA compliant, and it should be kept the statutory government's law, and whatever you want to keep the data in terms of the law of that particular land, you can do that. So that's two things which you do, and that company name which I'm presenting here is a Nutanix, which works in terms of a different associate ISVs, be it a variant for oncology, and if you talk about the HIS and the PACS, there are multiple. I'll talk those details in my subsequent slide. But if you want to see here, so one of the piece when drone technology being shown here, so think about that. Can we have this data being processed where it is in a remote e-health center? If it has to come to the central center for the doctor to process, how quickly we can do that? So we have this remote and branch clinic, which we have worked in terms of building up a very small e-health center where you can have only a small equipment being lying, and every process data can be processed over there in terms of recommending something over there itself, and then it can send all the process data back to the central data center where you can have the big analytics being running in terms of what was the state of the patient, how it was behaving, and how his recovery is happening. So those all things can be done. Rest is self-explanatory what we do in rest of the space, but one use case which I want to pick it up here is the VDI. So today doctors want everything on their palm top, on their hand. So think about that, and I keep telling it to my son that why you are so paranoid about your job. And I keep making a fun. God is with the doctors, but sometimes God is not with the technology because I can't say sorry. You agree? I don't have an option of saying sorry because I have every logic with me. Customers, patients can ask me why this data has not reached there. It was the link problem, it was the processing problem, I had to fix that. So any patient which is processing required for their data, if doctor is reaching from his home to hospital, and by the time he has to operate, if he can see all the patient information in the 10 minutes of a time, it's a big saving for that. So can we process that image and the data and everything about that patient and send it across to that palm top with the lightning speed? By the time he is coming, he is about to operate the patient, he knows every parameter of that patient. So these things we are working with our customers and helping them to build this. So these are some PACS and VNA associate partnership where we help them in terms of building up for the hospitals, for the labs, in case if you are using any of these things. We have our booth, please be there, we can help you out in terms of what kind of solution we have built with them, right? So these are like, when I was talking to the Apollo and all these leading hospitals, what are the business problems we are trying to solve? One is the performance. If performance is not been there, probably we will be running into marathon, and marathon is not the solution for everything in healthcare. It has to be sprint if it is a medical emergency. So in that situation, but we cannot avoid complexity. Things are, because hospitals and the paramedical is more of a patient services. They are not a IT center. So things become more complicated, more complex, the more component comes into the data center or into the hospital. So can we avoid that complexity? So these are the two parameters, and then skill set in terms of managing that. It becomes a big challenge. So with this essence, we have taken 4 key use cases, as my presentation was mentioning. Can we have the HIS, EMS, EHS, and PACS and VNA in being done into the hospital in such a way that it's a zero touch. So you will not be putting any efforts in terms of managing your internal IT. It will be self-sufficient to manage it. So these are the platform which we were having as a healthcare solution, where we are building it up. And one piece which my fellow colleague has mentioned, the security. So this is one of the, out of 10 meetings, 9 meetings, every time the first discussion is only on the security, how you can handle the PHI. If it is not being managed, that it will be a big problem for the entire hospitals. So we have created that stack, and India leading hospital, if you have seen my second slide, it was having all those logos, which is running their hospital on us. And in fact, just to share from this podium, TMH Mumbai is running their pathology lab on us, ma'am. So you might not be knowing it, but I was there last month, and I was interacting with the doctors. So their pathology lab, which they are running, the new pathology lab, it is running on Nutanix platform. So proud to be partnered with TMH. So what I was trying to say here is, IT has been always been given the second stage, but IT plays a pivotal role in terms of building up everything which doctor does with the patients. It cannot be ignored. So if it has been well taken care, I think the patient will be very easy to manage. And why we say this is because we believe simplicity is very hard to achieve. Complexity is very easy to achieve. I can build anything in your hospital by creating a complex environment. But can I put my thought in terms of making it very simple? Because it has to be handled by non-clinical staff. And in hospital, it is always a scarcity of the resources. Can we have a very small skill who can manage the entire hospital, be it a PACS, be it HIS and EHS kind of environment? Yes, we can do that. And security is built in where it is the automated. So like everybody was talking about AI, we don't believe that something has to be built in. We believe in built in. So can we build in from the day one when equipment lands up into your permissions? Without your permission, it will not have any data being taken out. It cannot be displayed anything until unless legitimate authority and permission and authorization is not being given, right? But one point which most of the doctors and hospital staff talks to us, can we get return on investment? When we were working with all these hospitals, it is not the profit center. Outside the world, people, they think hospital is one of the profit center. But we understand what kind of expenses you guys have put it into the hospital. It's a life and death situation. So it cannot be exorbitantly high in terms of the cost. IT has to be a true TCO and ROI based discussion rather than whatever you want to put it into a whims and fancy, you can't do that. So we believe that all the solution we built with desired ROI and the TCO, which any hospital or any of the institution is looking for. So what do we do? Very simple, picture shows by its own. So this complexity has been reduced to a single 2U or 4U box. So it can sit any of the corner in your data center with 2 network switch, and you can manage that. It's that simple. Your power, cooling, everything is in well taken care. So when, again, my fellow colleague was showing 5i, I was very impressed with him. I was just thinking how I can make it e-health
5 steps. So if you see here, there was no information in past, right? So from where the e-health starts. So first you have to gather the information, then you have to start communicating it. After having the right communication, you will find out the right interaction, and then the actual health starts, where your transaction and integration with the entire hospital ecosystem starts. So if we have built this, this is the true e-health which we have to build with a new age infrastructure which we are pioneer, and we are associated with leading hospitals in India and abroad. So this is on the security side. I was mentioning, this is not bolt-in, it's built-in. It is starting from the scratch. The moment person comes into the data center, it has been well protected from all the compliances which you are looking for. So what we do? So these are the facets of any transformation. So if you want to build with choices of any hardware which you want to choose, these are leading OEMs, you can do that. But we don't restrict any hospital that if you want to use this technology, you have to do it by our own way, no. So if any point of time you want to move to any of the public cloud for any cost, power performance, and all those constructs, we can do that. But sometimes people, they come that they have association with Indian cloud service provider, so we have associated with one of the cloud service provider where we can give you entire speed, the performance, the TCO and ROI, and all these constructs can work with all these clinical use case which I have shown on top. So this is one platform, any application, and one cloud. You decide what you want to build. You should not be restricted in terms of scaling your hospital and any of your institution which you are leading to. IT should be just a factor which should help in terms of building it rather than restraining it. So this is the true piece which we build for our customers. So imagine this, if IT can really help in terms of innovating it, IT can help in terms of improving your patient care, the way my last presenter was showing, that what it is important is the experience to the patient along with the services which is being delivered to him. So if we can do all these things, I think IT has reached to the pinnacle, and what we do is, these are some of the use case where rapid plan, the dose diagnosis, the dose recommendation, all these things can be done with really with the lightning fast along with your PACS and VNA solution, and Nutanix helps in terms of doing this. So with this, what we say is, it's a cloud smart for next generation e-health, and we help our customers to build that. Thank you very much with this.
Naresh, thank you so very much. Only thing I couldn't disagree, the doctors really can't say no. You neutralize the whole liability insurance industry in that case, if they could just say sorry. Now would you please join me in welcoming Shobhunik Raut. I think I'm the only one being a Bengali who can pronounce this first name. And of course, Bagnishika Pohan as well. Those are some interesting tongue twisters. Mr. Raut is the General Manager and Regional Head, Business Solutions for Tata Communications Limited, New Delhi.
Thank you, Smith. Good afternoon, everyone. So we are listening a lot of the medical and then technology and how the technology and medical both are handling each other. So I will try to cover up how these both segments can come together and make it a more success. So to accept, we all are living in an era of transformation. Every day, all of our touch points in life are getting transformed in different shape and form, and so bit of the healthcare as an industry as well. So if you look into the various scenarios, specifically post-COVID, this transformation has taken a lot of pace, and we all almost accepted that cloudification is kind of the way forward, and healthcare is no longer behind of it, and most of the ecosystem, the equipments, the telehealth services, the other medical equipments, all are getting the touch of the cloudification, and for that we can expect more and more the cloud-based services to come up, and where we can actually gain a kind of the benefit is that getting a lot of the virtual healthcare services, the platforms where the patient, the data can actually be accumulated for the future, the reference, more and more the people are saying making it a more open ecosystem so that there is no monopolism into it, and make it a more federated system so that the innovation can be more better and it could be more faster in terms of the healthcare industry to move on. And making most of the services, rather than a physical or a face-to-face, make it more like a digital services so that it makes more speed and more accurate of making it done. And finally, as a lot of the speakers were talking about how the remote monitoring or remote management can actually be making done so that you can eventually make the patient's life saved, because every minutes are important. So here the importance of the digital and the platforms coming in.
No, you don't have to aim at anything. Just press the green button. So press it a little firmly. No, just press it, the green one. Yeah. That's right.
Okay. So what is the observation? So now we come from an organization who are majorly the digital ecosystem enablers. So we always think that rather than a very specific technology to provide to a particular requirement, can we make it a more the integrated ecosystem so that the outcome can be more efficient? So when we are talking about this transformation, the digitization, it all talking about the three major pillars. One, once you are talking more digital, and specifically at the time of COVID, what we have seen when you are doing a lot of the medical the consultation over the video conferencing, the experience was one of the issue, that sometimes the calls is getting disconnected, or the voice is not coming properly, or things are not very seamless. So that was more of a kind of a teething issue. So that's why we felt any transformation we are trying to do, the first thing first is the experience has to be good so that it can be effective and it could be actually taken to the next level. Second one is that you cannot digitize one or two particular touch points. If you're trying to digitize something, you have to digitize the entire value chain so that it can be more effective. So what the observation is that this hyper-connected ecosystem is actually fueling to make all your touch points to be more digitized. So in fact, if we are thinking for a digitization in healthcare, we also have to think that how much maximum we can do in the overall value chain. And third one is, I think Naresh was also talking about, anything you do specifically in terms of transformation, security is the core. Because you are actually dealing with the patient's data, the organization data, and those data is not critical for the organization, but for the patients also. So security becomes critical. So anything you do, you actually have to keep the security in mind. So these three pillars are very critical to keep it intact in case of any transformation what you're planning for.
No, press the green button, you don't have to aim at anything.
Okay. So I'm not going to read about all the technology names. These are very predominant in terms of the transformation, what is happening, specifically the telepresence, telemedicine, virtual clinics, the omni-channel communication, what we're trying to do, because now we are all going to touch the customers in various shape and forms, in various channels. Can we make it all those integrated? The AIs are taking a major shift in terms of the diagnosis and critical, the patient care and all. The IoT and wearables, specifically in terms of the predictive maintenance, or in terms of the data collecting from the different machines. The cloud adoption in terms of hosting your application so that you can get the data 24/7. Surgical care robots, which is now very critical in terms of your all critical, the operations what you're doing. The RP analytics to make the clinical applications more smoother and finer. And the last thing which is the blockchain, so that you can actually make the overall process more smoother and more secured, and wrap it up with a cyber security. Now, what is the effect which is going to the major stakeholders? So if you think about the healthcare, there are three major stakeholders into the overall ecosystem. The consumers, like patients, like all of us, the ecosystem enablers, like could be the government, the policy makers, the IT heads, CTOs, and finally the healthcare service providers. Now for all of them, what are the different, the ecosystem expectation? It is coming. So consumers are majorly looking for the online medical records. So if I am being a patient, I will always look for whether my patient's data is available every time. I can actually go and look for it. The ecosystem enablers are mainly looking for a kind of the cost-effective healthcare system so that it can actually integrate everything and make it more easily available to the people. And healthcare service provider, for them, they want an internal ecosystem which is more efficient and user-friendly. Now, if we go to that, what and how we as the organization, we are planning to support. So we have categorized into multiple things like making a telemedicine as one of the integrated part, omni-channel communication platform, the cloud platforms for keeping your application and data to be stored, creating a SOC to make the security portion taken care, modernization of your all application through the lot of the containers and the DevOps services, IoT-based medical asset services, and an end-to-end the network which is required for the users to connect to the platforms. Now, very specific, we'll be talking about a platform which is something like integrated and interconnected digital medical, the healthcare system. So it is majorly providing a kind of all modular services like your virtual clinic, your the report management system, your hospital management system. But it is till that time it is fine because it is available. What we are trying to do, we are trying to integrate the other services like the network, your security, and the cloud, so that any user who is trying to connect from any of the locations to this platform, be it is a patient or be it a doctor or any hospital chain, they can actually come into one platform which can provide the entire services over the virtual mode, right? So even in fact, so when there is a patient which is getting carried over the ambulance, so what is important that till that time is reaching to the hospital, can we do an kind of the e-ambulance kind of a solution so that with the help of AR/VR, the command center can actually look into what is going on into the ambulance and give the vital reports into it. So the VCMP is majorly carrying out the smart OPD, which is the EOPD or EICU, along with the e-ambulance. In healthcare management is majorly the HIMS and the light HIMS, depending on the kind of hospital change we are looking for. And finally, for the RMP, it is a DICOM platforms we are looking for. To coming to the communication part of it, this is a platform part and the communication part where currently the hospitals and patients are connected over various the channels what we are talking about, like the WhatsApp, message, or voice, or video, but all those are disintegrated. This platform, what we are talking about, it is getting the entire the channels into one orchestration platform and connected over an intelligent contact center. So someone who is trying to connect to one particular platform, they can eventually use the same platform for the customer who are looking for services or in connect or to the post-connect situation. So this entire life cycle can be connected over the platform of the omni-channel communication platform and the contact center. And finally, I'm going a bit slow here. The final thing, which is more like the infrastructure we are talking about. So this is one platform what we are trying to create. So from any user to headquarters or maybe the hospitals, if they want to get connected to any of the cloud platforms where your application are hosted, the end-to-end network connectivity along with the security and obviously the telemedicine portion coming in can be clubbed into one platform, and eventually can give into one digital ecosystem for the telemedicine part of it. So with that, I will take a pause.
Thank you. Thank you so very much, Obanik. And of course, 5G has some huge utility in almost creating a local area network in the healthcare system and giving some massive bandwidth. So thank you so very much. And Ganesh, would you join us now? Ganesh is the co-founder, VP R&D Engineering, Vios Medical from Bangalore. Once again, Shobonik, thank you.
Good afternoon. First of all, thank you to the organizing team to provide me as an opportunity to talk about talk today. Of course, infrastructure is what was proposed to me as a topic. I'm sure it is not the last thing that is usually get thought through in your own application development. I'm probably the last speaker of this session, so I guess this always will be in the top of our consideration in any development, any application or any consideration of any telemedicine or any such platform we intend to build. This will be a sort of a critical component in this whole ecosystem. So, at the start of it, I mean, infrastructure, I mean, I'm sure that even in this panel sessions I've been hearing, there has been such a diverse set of topics, starting from legal to, the hardcore healthcare practice as a practice in pathology to, the infrastructure elements, telemedicine. And likewise, I think in the last couple of days, there has been so much of diverse set of topics cutting across various domains, right? So at the crux of all of this, I think pretty much everyone would agree that there is an infrastructure element to it. I mean, infrastructure in the sense it's not just the communication piece. It is a combination of several components in the system to deliver a reasonably and effective healthcare to the consumers. I think to that effect, remote patient monitoring is basically a service or I would say an application that needs a good solid foundation infrastructural piece. So I think we'll go back. So I think the key aspect of infrastructure, of course, today we know that for a scale of India's operations, which a lot of, although there is a sizable technology penetration, mobile phone penetration across, there's still a digital divide among the consumers. I mean, even though they may say that, okay, there are 50%, 60% penetration of mobile applications in across the country, there is still a significant lack in consuming this or using that effectively for accessing healthcare services, right? So there is even studies talking about only about 10 to 15% of users are able to use that services, even though there are plenty using 3G or 4G connections across, okay, about 50%. So there is still a big aspect of digital divide, or the democratization, as many people have termed, is the need of the hour. Like, we have we even recently thought through this in other domains, like the classic examples, which is a success story in India, is the financial inclusion, right? And today we talk about UPI as a way of how it has brought about a wave of inclusivity. Anybody, any vendor can actually use UPI effectively, and that way it has brought in a lot of financial inclusiveness in the population. And this means at the foundation of it, I mean, if you look at it, still there are financial institutions that work in silos, right? When they have their own apps, they have their own infrastructure, servers, and things like that. But there is something that actually ties them together, and that is that ecosystem that has built, that is enabling these systems to interact and interoperate and deliver that service to the end user. Likewise, I think in the healthcare, we need certainly a thinking in this direction. I'm sure there is already been talks yesterday, as well as a lot of momentum in the government as well, that is moving things in this direction. Essentially, we need something which is not just not just can work in silos. I think many of us has already talked about how data access, or even data moving with the patient and terms like this are very critical. When you look at it, is the end user, that is in this case is a patient, empowered with access to his or her data, right? So I think in a way that the UPI story has really helped us give that confidence that it is possible to address this in other domains as well, like the healthcare. So at the core of all of this is the ability for the systems to interoperate, even though they may be in silos, but they have the ecosystem to allow them interoperability to happen. At the same time, make it accessible to everyone. I mean, if you take the UPI story, it is even the commonest man is able to use, the farthest man from the urban center is still able to use that story. Along the same lines, it is necessary for the healthcare delivery also to follow this similar paradigms, right? So I think it's just moving on. Okay, so what I want to touch upon this here is the key elements of this unified healthcare interface. Like we have the UPI, and where all the ecosystem partners are part of this story. Okay, so you may have users, you have users like patients who need access to this data, the diagnostic labs, the physicians, and all of them are verified and actually become part of this ecosystem. Likewise, the hospitals, and of course all the startups and other community who provides various applications or various systems and services that need to be also verified and made part of the system. So even though these various components may be working in silos for serving their own internal needs, but still when it becomes part of this ecosystem, we have a mechanism where these services are accessible to all these stakeholders. Like, so hospitals should be able to access a patient's data. Doesn't matter where that patient was last treated, or is there his patient's history needs to be accessed for this, for providing a more effective treatment to the patient. So likewise, I think the fundamental to all of the UPI story is this need for a unified health interface. I'm sure there are a lot of right signals that are happening in the environment to move in this direction, and already a lot of people have explained how they are implementing this in their own ways in these organizations. But eventually, it is not enough for that to fulfill the needs of that organization. True democratization will be achieved only if this is universally available, like the UPI. Okay, in terms of, so that's the platform piece, which is more about the ecosystem, the stakeholders of the ecosystem. Then we talked about servers. I think some of them talked about how how services and are enabling that platform piece, and also the big part of this, again, it was also elucidated from some of the key panelists, was the communication infrastructure. I think today, like I said, there has been a significant amount of increase in these penetrations in India across different geographies, but it is not enough to deliver truly all the services seamlessly across all sections of the society. There is still pockets where you don't have either access to the internet or anything, but still, how do we deliver services, in a way that it can, without the need for an active internet? Like I think the UPI, again, a story that tells about how you can do transactions without having an active internet site. Okay, so you don't need to have an active connection to deliver, to interact, or even send and receive payments. Likewise, can we enable access to information that is necessary for the consumers, in this case patients, to receive when there is not necessarily active internet available. Okay, so of course there is today various communication infrastructure, the 4G LTE, which is what we use predominantly in urban centers today. They expect to remain dominant till the next few years. In India, at least, as we see the rise of the 5G and other stuff, as more adoption increases. And obviously with 5G, we'll have more access to more sophisticated health applications delivered. Like, could have remote surgeries, I think robotic surgeries, assisted robotic surgeries, some of them talked about, and other therapies, other forms of therapies being delivered. Of course, there is another intermediate piece that we as a country could look out for, is the low power wide area network. Could be one intermediate step that India could explore, where you don't need to invest in lot 5G infrastructure, but you could ride on certain add-ons to the add-ons to the existing LTE infrastructure, so that we can actually deliver much more cost-effective services to remote areas. Sorry. Okay, so what we do at Vios is primarily that at the backbone of all the components is a lightweight infrastructure. So essentially, all of our data is under 2 kilobytes per second. So that way, we can use even a traditional dial-up connection to deliver, to communicate data in real time to our thing. So it's highly optimized to, to carry efficiently the payloads across different things. At the core of it is the platform, which contains several components. So we have a wearable system that is typically worn on the patient's body, and it collects all the bio vitals from the patient's body, such as the ECG, and that is actually, those bio vitals are captured and processed at the bedside, which is basically a FDA approved software component, and then that is relayed across to various consuming stations. It could be at the nursing station or a physician's laptop, or even a command center like platform where this data gets aggregated, and you can actually decide whether there is a deterioration in the patient's condition or not. So the entire ecosystem is built on a lightweight backbone. So,
thank you.
Yeah.
Because we're going to have questions after this.
Sure. Okay, that's pretty much what I had. Thanks once again for giving me an opportunity. Okay.
So would you all please once again join me in thanking the panel. Any questions from the audience? I do have a question for Professor Sangeeta Desai. Do you see biomarkers and pathological apparatus at home doing a lot of predictive insights as against interventional work post an occurrence?
Can you repeat the question?
Yeah, what I meant is a lot of the work that you're talking about, like they talk about a lot of protein gets released in the body prior to cancer's onset. So is there some way or form, are you seeing consumerism of digital pathology that we can do at home prior to it being a post-occurrence?
Yeah, see, biomarker testing is a routine activity in cancer management. And what I was referring to is use of AI algorithms to predict biomarkers. So instead of a exorbitant molecular test, where we are either using tissues or blood and we are spending a lot of money, instead of that, you already have a slide with you of a tumor which you already diagnosed. Can you subject the same to AI algorithm? Now, so many such algorithms are already in market, they are being developed. Now, all this can be, you are asking whether it can be done at home, right?
Yes.
Now, this home thing started with COVID. And there, a lot of existing rules had to be relaxed, and that was a lot of flexibility was offered to pathologists. Now, here in India, we are not bound by those rules, but we are basically disciplinarians, so we follow those rules, like College of American Pathologists, and so all those guidelines are there, and believe me, but now we are, I think, post-COVID, but those guidelines still remain, and they offer same extent of flexibility to pathologists. So it is possible. That's what I would say.
Thank you. Any other questions from the audience? Yes, please, Doctor.
I don't have a question, but I have a comment for Dr. Sangeeta.
Please.
There is a very famous saying, physicians know everything but do nothing. Surgeons know nothing but do everything. Pathologists know everything, do everything, but too late. But I think in her case, it's in time.
Very well said. Thank you. Okay, if there are no other questions, I want to really thank the panel. I've truly enjoyed hearing all of you, and some of you are fantastic speakers, and thank you for your time. Please.
Absolutely amazing session by all the speakers. Please stay here. Please stay here. I would like to request Mr. Paul Keyworth to please join us for felicitation.
Thank you.
Can we have the gifts, please? So one more time for all the speakers, give it up loudly, please. Thank you so much once again. Thank you.
I think, do you want me to, or would you want Shabnam to do that? Go ahead.
Okay, to wrap up the session, I would like to call upon Professor Ganpati on stage. So one more time, let's welcome him with a huge round of applause. A very, very energetic man. So.
Ladies and gentlemen, it's indeed a privilege to see so many of you here at the last session on the last day. I know how difficult it is. You have been through about 14 hours of intellectual, I won't say fasting of intellectual. You have been given so much food for thought. Before I invite Professor Govindan, who is the director of the Indian Institute of Science, we deliberately called him to address the valedictory function because we believe that in my lifetime, you see I've got a lot of white hair, but in my lifetime, I'm delighted that the Indian Institute of Science, a 113-year-old institution with globally ranked as one of the top universities in the world. We're not talking of India, we're talking of the world, with a high number of citations, publications, etc. The temple, the Mecca of learning for science, particularly for science, and of course, engineering, research and technology. He is planning to start an MD, PhD program. And I believe that in the next 8 to 10 years, we will have properly, formally trained, not only clinician scientists, but we'll also have clinician technologists. Yesterday in the medical devices session, the heads of departments of 3 different IITs and 2 leading CEOs of 2 leading companies were lamenting the fact that clinicians are not really involved in technology, and I as a clinician was lamenting the fact that technologists, engineers and scientists are not getting clinical help. The Indian Institute of Science, sir, we are delighted, is going to fill the gap. Yes, it's going to take a long time. And I think it's very apt that over 14 hours, incidentally, we had 25 speakers from outside India. 10 different countries were represented yesterday and today, and we had 29 thought leaders of India. We deliberately did not have parallel sessions. Every single session was a so-called plenary session. So 59 papers, plus of course some e-posters, etc. A joint conference. The International Patient Safety Congress in the next room has attracted more than 1,200 people. When I started organizing this, when Sangeeta Reddy asked me to do this, the first conference 13 years ago, I was honestly a little skeptical, though obviously I love technology, but being an old-fashioned medical doctor, I was a little skeptical about how we could marry engineering, science, technology, and clinical care. The very fact that we have survived for 13 years, and this is the 10th conference, shows that this is here to grow. I don't want to take more of your time, and sir, it's my privilege and honor, sir, to please call you to the dais, and I'm sure you're going to tell us, I would like you to tell us on the role of the Indian Institute of Science in developing healthcare. I mean, that would be my overall request. Thank you once again.
Thank you for those kind words of introduction. It's a pleasure to be here. Of course, I was, thinking I would be a fish out of water, but when I saw the byline of the conference, the butterfly effect in action, I felt quite at home, because the original area of research that I engaged in was chaos theory, and which is where the butterfly effect came from. And I guess here it refers to the exponential effect of technology on healthcare, especially artificial intelligence has had an exponential growth, and that is something which is going to transform healthcare. So as was pointed out, we at the Indian Institute of Science, we are a 113-year-old institution founded by the Tatas, and we have now embarked on this new adventure of starting medicine along with science and engineering. So we have been doing science and engineering for so many years. I took over as director after, in the middle of COVID. So that time I thought, this healthcare research is going to become very critical for India. And having a hospital and a medical school within a university setting, a research university setting, is something which is really required in the Indian context. It's very common in the US, UK, and other places, but in India, we have excellent standalone medical institutions, but not institutions which combine all these elements into place. And that is becoming more and more critical, having science, engineering, and medicine all come together. And we saw a beautiful example of that in the mRNA vaccine that has already helped, maybe billions of people around the world. So this, mRNA vaccine was required the confluence of all 3 disciplines. You needed, of course, deep biology to come up with the vaccine. And you also needed nano science and engineering for the lipid coating, the nano lipid coating for delivery. And you needed, of course, medicine for taking it to the patients, for doing all the trials and so on. So here is an example where you need all 3 of these disciplines to come together, and that is something which we feel is still lacking in India. We could do better. And that is the reason why we are starting this at IASC. And some of the ways in which we will be able to contribute to the healthcare segment is, of course, one is we are going to have a hospital also, an 832-bed hospital to go along with it, which will All of this will be on our main campus, and it's going to be a postgraduate medical school. So we'll be admitting MBBS doctors, and they'll be pursuing MD, PhD, and DM, PhD, or also MD, MTech. So an MD in radiology and an MTech in data science or artificial intelligence. These are combinations which would not be possible in a regular medical institution. So, and also, medical technologists who will be well-versed with both medicine and technology, since we are very strong in biosensors, in all sorts of technologies. We have a lot of experience in NMR, nano engineering, materials engineering. All these are very critical if you want to build, devices, if you want to have new technology coming out of it. So we hope to also embark on some, futuristic research directions using this medical school. For example, one very interesting area is, which we have already started some work, is using nanobots. These nanobots, these are things like, what you have seen in movies some years ago, science fiction movies on the Fantastic Voyage and so on. So where we have these helical screws which are guided by magnetic field from the outside, and then you can guide these nanobots through tissue and blood vessels, and this can help in targeted drug delivery at the required site. So this is something which we are engaged in, and also things like body on a chip and digital twin. Digital twin is something which technologists are very familiar with. You have digital twins of machines and so on. But what we would like to look at is a digital twin of a human being. So all of us, ideally, some decades later, will have a digital twin, and that digital twin will be, in some sense, a digital replica of ourselves. And that digital twin will age along with us. And then what you can do is you can test all your medicines, everything on that digital twin before you try it out on the human being. So this is something which can really personalize medicine and make sure that the effects of the medicines, the drugs that you give, are something which are compatible with the physiology of that human being. Of course, this is really futuristic. It's going to take probably several decades before we achieve that. But we also have, as an intermediate thing, step body on a chip. We also already have organs on a chip, so we can connect these organs through microfluidics, and that is something which we would like to pursue through microfluidics, where you can again, probably do some trials using these drug trials using these bodies on chips rather than human beings. So there are a lot of potential available for this, and even what we do on the AI side is something which can help. Of course, people are talking about having 5G and of course later maybe 6G, which will really reduce the latency and enable rich data to be transferred very fast. But we are still living in a reality where you have low data transfer speeds, and WhatsApp is the primary form of communication. So one of the projects that we did at IISc was this X-ray Setu project, where we are able to diagnose pneumonia from images of the lungs which are transmitted through WhatsApp. As you know, WhatsApp severely degrades the quality of the image. So we are able to diagnose pneumonia using, at an accuracy comparable to that of radiologists using just purely the WhatsApp images of the lungs. So this is something which can really scale up, because scaling up is something which is very critical for India. I think probably realistically maybe we have, even though officially it may be something else, but realistically maybe 0.5 doctors per 1,000 patients, maybe the qualified doctors who are attending to patients in India. So and especially in rural areas, the number of doctors is very minimal. So we do need technologies like this to be able to scale up and cater to this population. And also another area we are working on is telemedicine and telemedicine with haptics. Because one sense that you really do not get with the conventional telemedicine is the sense of touch. So whether that also can be replicated in the telemedicine environment is something that we want to look at. And especially as the number of elderly population in our country grows, we already have 150 million people who are 60 plus, and it's going to become 20% of our population by 2050. So it's going to be a real challenge taking care of them, and we really need technological solutions like this to scale up. So we are working on these, and also another area, since we have a parallel conference on patient safety, that's something which comes to my mind, is how do you reduce errors in treatment using AI? That is something, again, we are interested in. I think a study which came in the New England Journal of Medicine last month said that 1 in 4 patients who goes to a hospital comes to some harm because of some issue. So that was the statistics. They came out in a peer-reviewed paper which came in NEJM last month. So how do we reduce that? We have all heard of ChatGPT. So when you combine ChatGPT with video capabilities, then that can track the doctors and nurses' interactions with the patient, the treatment options that is given, the surgery. And since it will be trained on a huge database of accepted procedures and treatment protocols, then this can, in real time, point out if some errors are being made, and that can then be used to reduce patient errors. Another interesting way, which is especially true in India, is because we are a multilingual country, that leads to, again, some errors in treatment. The nurse may not understand the language of the patient, or the doctor may not understand the language of the patient. There can be miscommunication between the two parties. So with Google, through ArtPark, a company floated by IAC, we have embarked on a Vani project where we are recording speeches from all the districts, all about 750 districts from across India. And then we'll have a system, we hope to build a system which will then be able to translate in real time between different languages and even maybe different dialects. Because in India, dialects can change within tens or 20s of kilometers if you go from one place to the other. So these are the possibilities that open up when you marry technology, science, and medicine. And these are the possibilities I think India needs to be at the forefront of. And the medical school that we are starting at the Indian Institute of Science is just one endeavor to ensure that we are at least at the forefront in some of these areas. So with these few words, let me thank you for inviting me and for this opportunity. So I hope we will collaborate in the future. Once we have the medical school, I'm sure we'll have much more opportunities to collaborate in the future. Thank you.
For Professor Govindan, please, sir.
It was really heartening to hear this thing. See, I was part of the Ministry of IT long back. And obviously, see, I was given the mandate there to support R&D in newer areas. Invariably, I used to end up with IITs and IIC Bangalore in particular. I recall one particular incident. You see, we had the excellent work was being done by Associate Professor I.S.N. Murthy on ECG analysis and all that. So they were working on arrhythmia. We supported them to develop a real-time arrhythmia monitoring system. It was in early 80s. They came out with a beautiful product. Now, question is, there was no industry who understood what they have come out with, real-time monitoring system for. And then you see, obviously I waited for industry, small, middle, small scale or middle level industry, medical industry was there. They didn't. Then some of those research scholars who were working on those projects, they went abroad, and suddenly after a couple of years, the people who had gone there from IIC Bangalore, suddenly a Meditronics, a company, they came out with a real-time monitoring system. My God, my heart, I felt so bad. And then suddenly local industry comes to me, sir, you had advertised that know-how is available for this. Manika, young man, you should have come 2-3 years earlier. You could have been pioneers, you know. So it was your particular talk really reminded me. But somehow, you know, whatever was your medical and my R&D grants were always there as long as, and some excellent work was done at IIC. Thank you very much for your this thing. It made me recall that particular incident, which I still carry some regret. Okay.
Yes, please.
Sir, regarding the MD PhD program, so it is a very good initiative for, especially for doctors. So I am personally, even I am an MBBS doctor. I have completed my MBBS from FMC in 2015, and I am presently studying at IIT Delhi. I am doing my MTech in biomedical engineering. So if this kind of program would have been available in my time, so I would have definitely loved to do it. But I think it is a great initiative for the future generation of doctors. It's a great initiative, sir. Thank you.
No, since I've been given the mic, and I'll be very brief, Lev Shapiro and I were discussing. I'm from Princeton, New Jersey. He's from Philadelphia. Siemens Healthineers has 500 data scientists in Princeton, and they've actually a full-blown data twin for the brain. It's already functioning. So just a point that we can't afford to say it'll take a long time because it's actually happening, sir.
All right, thank you so much, Professor Govindan. Thank you so much for your special presence. And thank you so much, Professor Ganpati, for doing the honor. Once more time, let's have a huge round of applause for his presence. You made this conference most special with your presence. So with this...
I know everybody wants to leave, but can I please crave for your indulgence for another 300 seconds maximum? I want to call on stage the magnificent team which we have on the stage. And as you know, getting a conference like this organized, particularly at short notice, we had so many challenges. This is the 10th conference of THIT where I have been actively involved in. Maybe I should also say au revoir, goodbye. I'm not sure whether the next conference I would be as much involved as I am now. So I want to place on record my gratitude to this entire magnificent, please come on stage. I mean, there are hundreds of things which can go wrong. I almost feel like submitting an article to a high impact index, PubMed index journal on do's and don'ts in organizing a conference. I mean, it was amazing. Now I can tell you when everything is over, sir, we got this place at 2:45 in the morning. Conference started at 9:30 in the morning because the previous day was a dinner function where the CM and MPs and MLAs, everybody come. 2:45 in the morning we got. I think they got about 10 or 12 carpenters who were working the stalls. I mean, it was just unbelievable. I mean, it's enough to write a story. Please come.
Absolutely. This conference wouldn't have been possible without them.
And this young man is the conference secretary. So the most unreasonable demands which I made, without protesting, I mean, I'm sure he would have protested, but he didn't convey it to me. So this young man was the one who led the entire group of people. It was not a normal conference. As I said, we got the entire...
All right, so let me take...
Yeah, and also I'll be forgetting, I had 3 other senior people to help. Dr. Sujoy was the one who brought together about 75% of the scientific program. He had to catch a flight. In spite of a personal ill health at home, he had to catch a flight. He's left. Mr. Vikram Taplu, CEO of ATHS, also fell ill. Mr. Ashokan, please come. He is the new CIO of the Apollo Hospital Group. He and his IT team, I mean, for the last 42 years I've been attending conferences. I know the problems involved. You'll see not a single slide went upside down, nothing got reversed, nothing, almost nothing happened. It was a 99%. So these are all the people. I would like them, may I request Professor Govindan please to do the honors.
So we have our very hard-working volunteer on the stage. So let's have a huge round of applause for Nitish, Ranganathan, Pratmesh, Nutan, Lakshmi, Ankit, Brinda, Jarman, Vinod, Mahesh, Saurabh, Kanchan, Saundarya, Triyanka. Please let's have a huge round of applause along. Bharat, Rakesh, Dheeraj, Daniel, Farooq, Wani, Shija, and Hari Kiran. Thank you so much all for your smart and hard work you have been doing from so many days. So thank you so much. Just because of them, this conference went super special, super duper hit. So thank you so much all for your efforts and hard work you have done for the conference.
A special round of applause to Mr. Ashish.
Absolutely. Most hardworking guy, yes.
All these people together. And of course, our MC also, who has been with us from yesterday.
Thank you so much, sir. Thank you. Oh, thank you. I'm glad. Thanks.
Mitra, come here. That is Mitra. Come on, shake hands with me, please. Come on, you're more into, that's better. Thank you.
And now, once again, let's have huge round of applause for the most strongest pillar behind this conference. It's Professor Ganpati. Can we have louder one for him, please? And once again, let me tell you all, our 11th edition is going to take place this year only at Chennai on 16th and 17th September. So once again, let me tell you all with great euphoria, our 11th edition, RTHIT 2023 11th edition going to take place in Chennai on 16th and 17th September. So let's get clicked together along with Mitra. I hope you all enjoyed these 2 days and you have completed this conference with your participation, with your presence. So thank you so much for being a wonderful and amazing audience. Thank you.
One final comment. Any bouquets, brickbats, please come to the mic and you're most welcome to criticize us with facts. We want to raise the bar. We want to do better next time.
Absolutely.
Would you like to have some feedback?
Of course. Absolutely. So whatever feedback you would like to present, you can definitely write it down and we would. So as we complete the 10-year milestone of this international conference, and this is our commitment, as long as technology and healthcare keep innovating and growing, we will keep pushing the boundaries of what is possible. So thank you so much. So with this, we are done with our 2 days conference. Thank you so much for being here. I'm Resham Bhalla signing off.